So, all right, we are live. Hello, guys, and Mr. Tarun, do I need to make you a co-host?
Yes, sir.
So, where do I do it? Do I stop live stream first and then do it? Participants. Okay, done. So,
Sure, sir. Thank you.
uh, welcome, ladies and gentlemen, and esteemed colleagues, distinguished guests. It's with a great pleasure I welcome you all to this enlightening webinar on performance of fetal echocardiography. Very happy that more than 2,000 delegates registered. In fact, 2,200 registered last evening. So that reflects a global interest, and many of these colleagues are from Middle East, from Southeast Asia, from Europe, from it's a global one. So today we have privilege of having a host of panelists, the internationally renowned speakers, and you understand that fetal echocardiography is performed by three professionals. One is they come from three streams like Ganga, Yamuna, and Saraswati and Sangam. So three specialists are, because it's a fetus, so fetal medicine specialist, because it's imaging, so radiologist, because it's heart, so cardiologist. So these three streams, fortunately today you are going to have this trifle pudding taste. One fetal medicine specialist, Dr. Prashant Acharya, a radiologist, Dr. Ramamurthi, and myself, cardiologist, Dr. UP Singh. So we would start our session. Basic focus is to give you an expertise of how to perform a good fetal echo. This would be of interest of everyone who is doing fetal echocardiography today. There's always a room for improving your skills in performance of fetal echocardiography. Fetal echocardiography is a very, very challenging field. It's an ever-growing field, and the average kind of learning curve is about 5 6 years. So and we are still learning. So let's begin our talk. And first, can we have a short run of a promotional video by GE? This is sponsored by GE. And then we'll begin with our first speaker, Dr. Prashant Acharya. I think we are not seeing the video. I think we can forego that right now. Let me invite Dr. Prashant Acharya, our first speaker for this webinar. We can start with this session right away. Dr. Prashant Acharya, if you are doing fetal medicine and you don't know Dr. Prashant Acharya, I think you are not well connected. You got to know in India, everybody knows Dr. Prashant Acharya. He is a fetal medicine specialist. He is an MD and FICOG, but he did undergo an ultrasound training and diploma in pelvic endoscopy in Germany, and he was trained in King's College London. A feather in the cap, he is the first Indian to represent us in ISOG board membership, and he is currently ISOG ambassador to help teach to mentor people all across the world. He specializes in fetal heart. He has a large collection of fetal heart specimens, the dissections, and he is very passionate about it. He is thick into fetal echocardiography and fetal neurosonography. And in fact, he just launched Fetal Brain Society. He's written number of books, but one of books which has been the bestseller is 100 Thumb Rules on Obstetric Ultrasound. He has been running number of courses, training programs, and he's a widely traveled speaker and most sought for faculty in most of the international conferences. Dr. Prashant, please.
Thank you very much, Dr. Singh sir, and for your kind words. And let us start and focus with the business first. What I'm going to discuss today is four-chamber view. What all you must know about four-chamber view. There are quite a lot of things. Fetal ultrasound, I put it as fetal neurosonogram, and fetal echocardiography is like this video.
This drawing is much bigger than it seems, where from far you might think that you see a bunch of crows, but then you zoom in and you see that one crow isn't a crow at all. Then you might see that there's a little glowworm on top of its head, but then when we get closer, you can see that it's actually a little fictional creature with an astronaut ant on its back. And if you look at the tiny, tiny little thing that the astronaut is holding, you can see that it's a little atom. But what's a tiny, tiny little atom to us might be bigger than the world to someone else. And if we zoom in to the electron in that atom, we can see that there's a whole other world inside that leads to an observatory, that leads to some amoebas looking out into the distance. Now, what you might not know is that if we back up out of the electron and go into the other electron, we can see that there's a world inside it as well. This drawing is much bigger.
So, as I always say, that fetal echocardiography, the ultrasound is like this. You go on searching, you will find a lot of things again and again and again. So it's about how depth and how knowledgeable you are in doing a scan. Somebody will see right up to amoeba, like Dr. UP Singh. Will see Dr. Ramamurthi can see up to amoeba level, which we have seen in the last video. There are many people who will see, okay, there is one simple crow. So we do not want to stop at okay, you can see some crow, but which is different. But we want to reach up to the looking at an amoeba level. That's a microscopic level. You go on evaluating the fetal heart, and then you can reach up to this. So the issue is, if you really do not know how to perform the fetal echocardiography, and if somebody asks you to do fetal echocardiography, this is going to be my condition, and I do not want. My condition has to be this way. Okay, so I do not want my situation like this. So I would learn fetal echo much in detail, and it's about the visibility of the heart. And visibility of heart is always like just after the webinar or any after good congress, you will feel there is going to be a trigger like this. There is going to be a peak of expectation. Okay, tomorrow morning I'll do everything. Then suddenly you realize that, okay, something is difficult, but if you continue, if you sustain that learning curve, you will at the end, you will reach to your plateau of doing fetal echocardiography. So it's about what you did yesterday, you are going to get it tomorrow. But if you want to get something which is different than what you got yesterday, you need to do something different today and tomorrow. So that which you never had, you will have something, that depth and detail ultrasound you will have. We always say that fetal ultrasound during pregnancy has to be a tube of pregnancy care. One at 3 months, that is 13 weeks. One at 5 months, that is at 22 weeks. One at 7 months, that is going to be around 30 weeks. And one scan at around going to be the 9th month, that is 35, 36 weeks. Because we see lot of different protocol. What are different things? What 13 week we can see in ultrasound? What we see in ultrasound at 13 week? That we can diagnose early lethal cardiac malformations which are not compatible with life. All you can do it, because the termination will be easier and better. That's the reason we do first trimester, 3 month early fetal anomaly scan. In that we do early echocardiography, and we see lot of things. 20 weeks or 23 weeks, we do lot of comprehensive diagnosis for better accuracy of the fetal cardiac malformation. That is going to which will lead to a good counseling, good optional management, better investigations like 22q11 deletion, or maybe single gene disorders, or maybe trisomies, and still termination is reasonably practical and possible. At 7 months, for late developing cardiac malformation, especially the cardiac block, coarctation of aorta, critical aortic stenosis, and some more cardiac malformation which may crop up during later life. One important point is that's a time when you can probably better prognosticate which are already diagnosed. Say, for example, tetralogy of Fallot, where you can probably prognosticate it better than at 22 weeks. And the same way is double outlet right ventricle, how is going to be the surgery, what is going to be the outcome. Your counseling is going to be far better. And the same thing at last month, probably timing and the place of delivery, or does she require in utero transfer, especially like duct dependent cardiac lesions, she may require in utero transfer, so that after the birth, pediatric cardiologist can take over for a better outcome. The prostaglandins can play a pivotal and vital role. So that's whole in nutshell the importance of each evaluation at each different gestation. And now you know that I always say that there is a similarity between driving a car and doing a fetal echo. Follow the rules, take some precaution, use a gadget to its optimum best. This is where many of us are lacking, in using your gadget to the optimum best. And if you do not know, don't try. You will end up in disaster. And that's always, I feel, you should learn the fetal echo. And because once it is learned, that art is learned, it is for lifetime. So learn it. Now, there is one issue about the fetal neurology neurosonogram. Fetal brain is different at every gestation. At 25 week, it is going to be like this. You have got a clear vermis, you have got a clear corpus callosum. But at 17 week, it is just developing. But at 12 week, neither vermis is there, no corpus callosum is there. But the advantage with the fetal heart is the anatomy remains same at 12, 10 weeks, 12 weeks, 17 weeks, 24 or 34 or 39 week of the gestation. So smaller is the heart. If you use a higher resolution probe, you can see probably quite a lot of cardiac structure during your examination of the fetal heart. So that's an advantage doing a fetal echo, that the structure does not change. Anatomy does not change at 12 weeks or 22 weeks or 32 or 40 weeks. So that's the advantage. So I wish that everyone should take the advantage of that. So let us learn from fertilization to the zygote to morula and to blastocyst and a three-layer embryo. From three-layer embryo, there is an amniotic membrane, and there is an ectoderm, mesoderm, and there is an endoderm. And if you this is you see, if you cut in an axial plane. But if you see on the top, from on the surface, you will have a primitive node which starts bulging, and there is a primitive stick which starts coming, and these primitive that's the important point where you find so many of things. There are just two stages to tell you. Now, from this primitive node and primitive stalk, at this stage, there is a current which starts a clockwise rotation. And these clockwise rotation will define fetal left and fetal right side. Any problem in this clockwise rotatory movement of the cilia, which throws the cell on left-hand side, that defines that, okay, on this part, the cells which are thrown from which a left side of the structure of the body, which are going to be formed. That includes spleen, stomach, and also the left side of the heart. And that's how the situs orientation will be developed in the fetus. So if you understand this, then probably you will understand the heterotaxy and the situs problems much more easier. If I cut the cephalic end in an axial plane, you will have this ectoderm, mesoderm, and the endoderm. If you still go further, there are three different loops which will start, and this is going to create from where you will have the creation of, this is the area from where the cardiac tubes or these blood islands will get together and forms the heart tube, and that's where you will find the heart tube which are formed like this. And these heart tubes which will come nearer because of the folding of the embryo, and these folding of embryo makes the heart comes together, and these tube becomes more parallel in fashion. And there are many genes responsible at different level. What are the genes responsible for taking all these stages of the fetal heart development? Three major group of the genes which are responsible are GATA4, TBX5, NKX2, and there are multiple combinations which will lead to many kind of malformation. Let us see how then what is the embryology, because unless you understand the embryology, you will never understand why these different kind of malformations which happen. These two separate tubes comes together, and then you have on the top you will have an arterial end, at the base you will have a venous end, and in the middle you will have the fusion of the cardiac tube. And these fetal heart tube, when it gets closed, when you have got the closure which is going to happen at this end, from where you will have a multiple kind of the grooves, because it is going to join together, you will have grooves at this point. So from top, you will have a truncus arteriosus, then bulbus cordis. You have got a right ventricle, which is connected to the left ventricle, and there is an atrium, which is down there at the bottom. Then what happens? At this stage, because it's a tube, then you will have, just look at this, one depression, or what we call it as the push, which happens here, and one happens there. Instead of straight tube, you will have two kinking which happens, and these two kinking will lead to what? A rotatory movement. And then you have got an left atrium, you have got veins entering into, there are on the right atrium, there are again three sets of veins which are entering into there. There is a common truncus arteriosus, and there are two aortic arches which are coming out at this point. And then you have got a rotation happens, still rotation happens. So atria which was below will go up. You will have three set of veins here, three set of veins here. Then there are two ventricles which are there, which are technically fused, and there is common arterial trunk. Then you have got right aorta, right arch, and the left arch, which are already there. And then you will have a still embryology which happens. And these embryology, what happens? I'll go a little bit faster. And the looping, I put it across like this again, making the same looping. One bulge here, one push here, and that's how the looping happens. And these you will have a common arterial trunk, two ventricles, right ventricle, left ventricle, and that's how an embryology picture which is there. So from these different set of the looping, now let us understand what happens inside. If I remove the myometrium, and go in, what happens? At this age, if I look it from the left side, what happens? That at this stage, you have got a common ventricle, you have got a common atria, and they all are joined by a single valve, or there is a single gap. I won't call it as a valve, but a gap. And from this point, the bulging will happen, and this is the area where you will have both formation of mitral valve and the tricuspid valve. So if it stops here, then it's an atrioventricular septal defect or AV canal defect. And then if you really go and understand that, okay, let me go move forward. Then there are two ways, as I told you. This is where your AV, tricuspid, and mitral valve develops. These vascular interventricular muscular layer will go up, and this is where you will have a complete development of muscular portion of interventricular septum. All muscular VSD will be able to see at this point, but the area which is left out, where the septum will come from above, and this is going to fill up this segment septum, and that's a perimembranous portion of the interventricular septum. And so this is a part of the septum dividing aorta and pulmonary artery, and you should be, this is not muscular portion, this is the membranous portion. Now you have got a very peculiar kind of development in the interatrial segment. The first septum which comes down, that is what is known as septum primum. And this septum primum, it is always will have a hole which is left. This is known as foramen primum. If it gets completely, it divides it completely, then the blood from right atrium will not be able to go to the left atrium. So what nature has devised, that it has created one more hole here, what we call is the septum secundum, the foramen secundum. And to cover the foramen secundum, you will have development of septum secundum. But if the development stops here, this is where it's a septum primum defect, or we call it as a partial atrioventricular septal defect. So this is how you will have one more foramen, that is foramen secundum. Once the foramen secundum develops, then the foramen primum gets closed. And to cover this, there is nature has created a septum secundum, which is, the foramen septum secundum, which opens into the left atria. And that's the reason you call it as a foramen of oval flap. And this is exactly what we try to look during ultrasound. This is a valvular arrangement. If it opens, it doesn't develop like this. You will have a complete development of the atrioventricular septal defect. So there are many bicuspid, tricuspid valve, all will happen. In four-chamber view, one of the important segment what we are going to evaluate is a pulmonary vein. So this is one simple way of illustration, but let me make it more simple for you. During the 27 to 29 days of embryo, there is a splenic venous plexus, and this is going to open by a single vessel into single channel into your left atrium, and these all four veins opens here into that sac, and this is going to open into the left atrium. Eventually, this single vessel will become shorter, and eventually it vanishes off. So you will have entry of four veins inside the left atria. So if at all this does not develop, it does not join here, in that case, this is total anomalous pulmonary venous return. And instead of opening this vein here into the left atria, it may open into the right atria. That's a opening of TAPVC into the right atria. If this goes up and join this, the jugular vein or the brachiocephalic, it's supracardiac, the same extends into below the diaphragm. We call it the infracardiac TAPVC. So how TAPVC develops, how the pulmonary veins, because these are the structures which we are going to see into our day-to-day practice, and that's how a partial AVSD is. So this is normal cardiac TAPVC. It opens here. This is what a supracardiac. So it will go up, and then if it is go down, this is where it is going to develop an intracardiac TAPVC. So once we have Oroshimita syndrome, it opens into the hepatic veins. That's how it develops. So this is what I have already discussed. So let us go and learn how to perform fetal echocardiography. Four-chamber view plane. I'm restricting myself to only four-chamber view. Whether you take AIUM guideline, which is showing far more, which is demanding little more depth of evaluation, there again you will have a four-chamber view. And whether it's an ESWOG guideline, it will also tells you that these are the four-chamber view is very important, and they have enumerated the situs, they have enumerated atrial chamber, ventricular chamber, atrioventricular junction, and that much of detail which you need to evaluate during your four-chamber view plane evaluation. So then the guidelines which says that your four-chamber view evaluation, the cardiac evaluation should start from abdominal circumference, because you are going to decide whether stomach is on left-hand side, portal vein and the gallbladder, is it on right-hand side, is the situs appropriate? And then you are going to go up and look for the four-chamber view plane. The stomach and apex of the four-chamber view both should be on the left-hand side. So these left-hand side, we have to decide which is fetal left and fetal right side. They are on same side does not is sufficient, because situs inversus totalis, where apex of the heart and the stomach both are on right side, still it can have 20% of the Cartinger single gene disorder called Cartinger syndrome, and which we need to rule out, and that's the reason that's the reason you should be looking after this kind of foot. Now, looking at what we do in fetal heart evaluation, we start from situs, we take a 4-chamber view, and then we go for the 3-vessel trachea view, and then we take LVOT, we take RVOT, and whether we use your electronic probe, whether you use a mechanical probe, or whether you use your standard 2D probe, aim is to look for all of the structure and look for the cardiac screening. It starts from, as I told you, abdominal circumference, start from this 4-chamber view plane, go to 3-vessel trachea view. That's in complete axial scanning, RVOT, LVOT. This is where you can, if you evaluate the 6th section, I can guarantee you that you will be achieving more than 85% of success in doing fetal cardiac screening. During your first time screening, in what my aim, my aim is to detect more than 70% of the cardiac defect, I would be looking at abdominal circumference, 4-chamber view plane, 3-vessel view, and 3-vessel trachea view. If I evaluate these 4 sections, still I will be able to do the 70% of the cardiac defect. But today, what I am going to restrict myself is to 2 segment, AC and 4-chamber. If you do even these 2, you will detect more than 60% of the cardiac conditions or cardiac defect that you will be able to diagnose. So anomalies are at 4-chamber view. I'm just enumerating the list, what you can see, and we will be seeing at what you should be evaluating in cardiac disproportion, cardiac chamber arrangement, tricuspid valve, mitral valve problems. Then you have got a pericardial effusion, intracardiac or intracavitary cardiac mass. All as I enumerated on the left-hand side, situs, axis, cardiac size, crux, VSDs, ASDs, AVSDs, area behind the heart, 4-chamber view, cardiac wall weakness or aneurysms, and whatnot you can identify. Just enumerating the list completely, just to evaluate, just to make the list still more accurate, that you can understand why this 4-chamber view is really important in your evaluation of that. And abnormal 4-chamber view can be associated with these kind of malformations. So if you keep in mind 4-chamber view, still you will be able to identify aortic valve problem, pulmonary valve problems, and outflow tract problems, as I enumerated. We have already discussed that at 12-week, it is going to be the small organ as compared to 22-week, but the structure, if you see, it's same. Whether you evaluate at 12-week, still you see 4-chamber view plane, and this is the same what you see 4-chamber view plane here. This is 12-week, 13-week, this is 23-week. Because you are aiming at a 12 olive size of the heart, at 22-week, 12 size of a chickpea size, you should be knowing this. So before going anywhere, let me first tell you about the anatomy shown on the autopsy specimen. The screen on the left-hand side, I have just opened the chest, removed the sternum, and removed the thymus. What is there is, this is the exactly behind the sternum is right ventricle. Attaching is left ventricle. This is the coronary. This is left atria. Here is the outline chamber, that is right atria. This is the pulmonary artery. The aorta arises behind pulmonary artery, takes turn like this. But what actually it is, let me explain you in the video. Here I have this big chunk which you see is a thymus. When you lift the thymus, behind the sternum, you will find the thymus. And when we lift the thymus, I have lifted the thymus, and then this is where exactly, let me freeze at one point so that I can show you each of the organ. I will let me stop at this point, so that, okay, let me stop here. No, just the forceps is coming in between. That's great. At this point, as I told you, this is right ventricle, this is left ventricle, these are the coronaries. Then you have got a left atria, this is right atrium, This is the here is going to be the pulmonary valve. This is main pulmonary artery. From here, it is going to give rise to the left branch and the right pulmonary branch. And this is going to continue as a ductus arteriosus. From left heart, you will have ascending aorta going up like this behind pulmonary artery. Then this is the ascending aorta. Ascending aorta. This is first neck branch, second neck branch. This is the third neck branch. This is the vagus nerve. And after the third branch, before this aorta joins the ductus arteriosus, a portion which is here, this portion is known as aortic isthmus. That's where majority of coarctation of the aorta, coarct aorta, which are going to be here. So just have this is the arch, the aortic isthmus, main pulmonary artery, ductus arteriosus. During 4-chamber view, we cut at this section. 3-vessel view, we cut like this at this section. So you have got pulmonary artery, aorta. This is where you will have a superior vena cava. So from left to right, you will have PAS. And when you cut at this point, you will find a tracheal V. 3-vessel trachea view. Here the trachea is going to bifurcate, and you will find 3-vessel trachea view or aorta, which is going to be coming here, and the ductus arteriosus, which is going to come here, and they are joining each other. And this is what exactly V, formation of V. It is again pointing towards the left side. This is the apex, and this is pointing towards the left side. This is what exactly we are looking in your fetal echocardiography. So here is the ultrasound image, and here is going to be this is the 4-chamber view going up. Then you go up, then you have got a crossing. This is what you will have. Then you go up. This is a 3-vessel view, and this is 3-vessel trachea view. So that's the basic fetal echocardiography, and that's what anatomy which we are going to understand. Left and right side orientation, as I told you, we always utilize drawing a doll on the left end, and we use a knuckle. And there is one more place is like clockwise, anti-clockwise rotation. But make sure that you have identified, because if I draw a doll here, my thumb becomes my right side. The knuckle is a spine. So you change the position. If it is vertex ROA, it becomes like this. So near the probe is going to be the fetal right side. That's how the fetal situs needs to be evaluated, and you can identify fetal left hand side, and that's what you can say. And on the 4-chamber view plane, there are a few things. One, you get an apical 4-chamber view where your ultrasound waves goes perpendicular to from the apex. Here, because they are going to enter here like this, so the structures which are going to be hit perpendicular, they will be seen much better. But those structures which are parallel to the beam, they will be seen less clear. So the perpendicular structures are your AV valves, your pulmonary veins, your atrial wall, but the interventricular septum, which will be less demarcated, or the color flow across the screen may be a little less demarcated. So if you find apical 4-chamber view, that's the best for pulmonary, atrias, AV valves, and their evaluation. Another view which you are going to get is a basal 4-chamber view, where you evaluate the heart from the base. But look at this, because here the ultrasound hits at 90 degree on interventricular septum. So you find the details of interventricular septum much better than any other thing, because pulmonary veins are hit again 90 degree like this. So again, pulmonary veins are also better evaluated like this. So a basal 4-chamber view is in fact may be better in case of majority of the evaluation of the fetal heart. One is a posterior 4-chamber view, where the spine becomes more anterior, and your evaluation is little more difficult, because you are the shadow of the rib, shadow of the spine coming in between. But here, if at all you find like this, you can utilize your color much better. Learn to rotate your probe, bring your spine to 3 degree, and then you will have my evaluation of the fetal heart. Now there are 4-chamber view things which you need to evaluate is a crux, which is very well seen. We are going to see the things. You have moderator band here on the right ventricle, and then you will have intracardiac evaluation of the four chamber. This is what we are going to discuss. I always say there are 12 points needs to be seen. Situs we have already discussed. Look for the axis, look for the size, two ventricles, two atria, interventricular septum, crux of the heart, two AV valves, two pulmonary veins getting into the left atria. Look at a rhythm, it is good or not. Look at a pericardial fluid, up to 2 millimeter, which may be normal because it's fluid needs. There has to be some fluid to avoid friction. And one of the important point is area behind the heart. You have to see only one vessel, no two vessel. Another round hollow structure which may be there could be of esophagus, which can be there. So you need to see these 12 points. Let us focus on cardiac axis. Cardiac axis, draw a line from the sternum to the spine and interventricular septum, 45 degree plus or minus 10 is normal. And these evaluation, this cardiac axis, I would probably put it like, if you have got a watch on your hand, it is like a 5 o'clock position. If you 5 o'clock, if whatever fetal heart is in, that 5 o'clock position remains static. So it should not be 4 o'clock, or it should not be 6 o'clock. If it is 4 o'clock, it's a left axis deviation. 6 o'clock, it is mesocardia. And that's what you need to understand. Now about cardiac position. Draw a line in the midline. I will expect 1/3 of the heart on the right side, 2/3 heart on the left-hand side. Any deviation, again, it's a problem. It's a dextro position, or it's a position on the or a mesocardiac position. So the cardiac size, again, cardiac size is 1/3 in the total chest area. And again, this is going to follow the rule of 1/3. So you should be evaluating this cardiac height, size, and position, because cardiomegaly, it is one of the structure which is one of the important finding in looking after this cardiomegaly. Look for the cardiothoracic ratio, and one of the important point is the cardiac width. If the thorax is small, heart is normal, or heart is big, thorax is normal. You can differentiate by taking the width of the heart muscle. A cardiac width, it is going to be 1.1 times the gestational age. So if, say for example, if you are evaluating at 30 weeks, I will expect 33 millimeter of the cardiac width. If that is 33 millimeter is normal, still CT ratio is altered. That means I'm talking about the thoracic hypoplasia. If the CT ratio is altered, if the heart is bigger than this, it is not the thorax at fault, it's the heart at fault. Because in both ways, your outcome is different. You need to evaluate, and this is what, as a rule of thumb, which we follow. Again, the atrial width, because we are also discussing the biometry chart. The left atria, right atria, or left ventricle or right ventricle, all should be at least half of the gestational age. If you are evaluated 30 weeks, any chamber has to be at 15 millimeter. Anything above 15 millimeter, more than half, that chamber is dilated. Half of the gestational age, if it follows, that's where it is going to be quite good. So there are many rules you can take up. You can take up this from our website or my book, all different kind of cardiac anatomy. So you have looking off the cardiac anatomy grossly. Let us see what happens inside the heart. I will freeze it. I will stop the video here. Now I'll tell you some of the basic differences, how to recognize the right ventricle and the left ventricle inside the chamber. That is going to be important when you are talking about CCTGA or TGA. This, if you really see, this margin is very smooth. But look at the chamber margin on the right side of the interventricular septum. You have got a moderator band, and that's how you have got the cavity, which is going to be quite irregular. This is the right ventricle. And if you see the left ventricle, which is quite smooth, except which is going to be on the outer side, but inner wall on the level of the interventricular septum, which is very smooth. Look at this. Interventricular septum, which is on the left wall, is smooth. On the right side, this is very irregular, and I will just remove this ink so that you can have now you can have the video of these, and you can have video of both the videos which you can identify how good the things are, so that you can always say that okay, your interventricular septum wall should be smooth. Here this is smooth, and that's how intraventricular anatomy is going to be. Now comparing, as I told you, comparing left and the right side, you have to look for the intrachamber intracardiac anatomy, and that's what probably we have discussed, that you on the right hand side you will have moderator band, and then there are no chordae tendini attached on the interventricular septum on the left hand side, but there are attached, it is attached on the right wall. There is nothing here attached. So no cordial attachment on the septum normally on the left hand side, whereas these can be seen much better on your interventricular septum basal view, smooth lining, cordial irregular margin, moderator band, and that's what you can identify intracardiac chamber. Coming to interventricular septum, and as I told you, interventricular septum we have already discussed, but I would like to draw your attention to the point from these interventricular septum. Coming to next point is going to be the crux of the heart. You know that the right ventricle tricuspid valve is going to be more towards the apex, and this mitral valve is going to be away from the apex. That means these two vessels these two attachment on interventricular septum they should not be at same level, because they are at different level. There's going to be a gap between those two valve attachment, and that's the regia, that's the area we call it as a crux of the heart, and the crux of the heart, which is very vital, because that's what is going to create one interventricular septum, septum primum or interatrial septum. Then there is a mitral valve, and there is a tricuspid valve. So it's like a crossroad. So there is a junction which is going to be coming here, and this yellow point is going to be your area where you will find something we call it as a crux of the heart. Right. So crux is best evaluated here in apical four-chamber view, but the septum primum is better evaluated in a basal four-chamber view. If you want to diagnose partial AVSD, it is this basal area, basal view, which will be more helpful. Foramen of oval valve flapping, which will be better evaluated in your basal four-chamber view, and that's the best thing. So we have already discussed this, and this is what you can have a septum primum eval. This is a foramen of oval septum primum evaluation, which you can have, and you can have these foramen of oval flapping. You can see the foramen of oval flapping like this. So much detail what you can see. Before moving further, you also should have a clear idea about the atria. Left atria, if you really see, is like you will have these like as if your balloon is pulled, and on the right atria, which is going to be bald, and a finger-like projection will be seen on your left atria. And this is what the finger-like projection which is going to be there, and you can see 4 pulmonary veins entering into the left atria, which is you should have clear idea. In the right atrium, you can have Eustachian valve, where the vestibule is going to open into the right atria, where you may find this Eustachian valve in the right atrium. I'm just showing you on your ultrasound, which you can have these kind of valve, which you can. A crista terminalis on the right atrium also should be seen, because you may find it like there is a white band. Don't get it mistaken with an atresia of tricuspid valve, because that's a common. One more important clue is going to be the Comodine ridge in your left atrium. If it is there, you see that at least one set of pulmonary vein is entering into the left atria. If you see that, that's quite a normal thing, which you should be aware of. One structure, area behind the heart, and these area behind the heart, as I told you, this is one normal. You have got only one vessel area behind the heart. Let me freeze four chamber for you. Let me go back little. I'm at four chamber. This is four chamber, but area behind the heart is this is the spine, which is kissing aorta, and aorta, which is kissing the left atria. So there should not be any vessel going like this between the atria and the aorta. One more point is there should be only one vessel. If it is 1 and 2, you are talking about continuation of hemiazygous, continuation of azygous vein, and continuation of azygous veins. That means you are possibly talking about the heterotaxy syndrome. Heterotaxy. So think IVC discontinuation, and this is linear insertion of AV valve, and this is what actually we are looking at. So here you can compare. Let me stop this also. This is where you have only one AV valve, complete crux is seen, one vessel, there are two vessels. I know I'm look at the shape of the atria, which are same. So I'm talking about atrioventricular septal defect and at isomerism. Here, look at this is the spine, this is the aorta, this is the atria. There is a long distance between atria and the aorta, because there is one extra vessel running through. So that is a total anomalous pulmonary venous return. So look for those structures which are easy, and the things which you should be looking at in atria, interventricular septum, and ventricular chambers, like what I have mentioned, and area behind the heart. Now coming to some of the malformations in ventricular septal defect, which is in a four-chamber view. That's what we are going to be looking at, four-chamber view plane. And there are many kinds of interventricular septum, ventricular septal defect, which are going to be associated. And there are many malformations like AVSD, tricuspid atresia, and many. I have just enumerated the list. And always think about how the blood will be completed in circulation, how RBC is going to move. If you think in that line, you will be able to diagnose your malformation. Like defect can be apical, muscular, mid-muscular. I showed you in embryology that these three defects, which are primarily through your muscular portion development. Inlet VSD is, and these three outlet VSD, perimembranous, and inlet, they will have a major chunk of associated cardiac, not only malformation, but also associated fetal aneuploidy. So there are many kind of fetal ventricular septal defect, right from apical VSD, where you find the VSD, which is there, mid-muscular ventricular septal defect, or a perimembranous ventricular septal defect, or there is going to be an inlet ventricular septal defect, or this is malaligned ventricular septal defect, and because aorta is exactly overriding, and still there is a defect. So this is what is important is look for the defect. These perimembranous VSD, inlet VSD, and perimembranous overriding of aorta with malaligned VSD. These three needs genetic testing. The rest of apical or mid-muscular VSD you can avoid. You may not avoid. You may not evaluate. If you apply your volume, you may find it like this, and you can always identify the structures. Like this is what you can see. Okay, that's a hole. That's a hole in the septum, and you can identify. You can dissect it, and thoroughly you can evaluate the tract, isolate the tract, and you can identify. We have already seen to evaluate the crux, but crux, let me show you what you can see on your volume. This is what I'm just showing it to you. Diastole, systole. I have all three here. Just look at this area. During the diastole, this is the crux. This is the septum primum. You can diagnose septum primum, and this is all the crux which is you can identify. So this, and because there are many genes responsible for the crux anomalies, and there are I've just enumerated the list of genes which are responsible for crux malformation. When you are talking about crux malformation, there is a gap. So there can be exaggerated gap, there can be a linear insertion, or there can be reversal. So there are 4 different kind of malformations of the crux which you can identify. Loss of offset. There was an offset which has lost. So practically they are at the same level. You are talking about AVSD, you are talking about double inlet VSD, or double inlet ventricle, or you can also talk about inlet VSD. And exaggerated offset, only one malformation is Epstein's malformation. And if it is reversed, you are talking about congenitally corrected transposition of great artery, where there is going to be atrioventricular discordance. So I have given you all 4 malformations, like right there. Here, if you really look for a normal one mitral valve, tricuspid valve, here this is the moderator band. There is no separate the crux which is seen here. This is the tricuspid valve, this is the mitral valve. You are talking about Epstein's, and here it is the ventricle chambers which are in fact, it is other way around. This is congenital corrected transposition of great artery. All pathology specimens of all crux malformations which are in front of you. So if at all, the moment you find AV valves are at same level, please look at the structures which I have enumerated. Please have a look at single flow. There is a regurgitation. Look at septum ASD, inlet VSD, and so on and so forth. Let me tell you a word about AVSD, which is synonymous with AV canal or a cushion defect. The whole concept is like normal. This is what the structures which we have seen, but let me open this for you, and I'll let you know that this is what a septum, this is where you have got a common AV canal, and in fact this is the one where this is, you have got one chamber which is bigger, one is smaller. This is not this is both chambers having asymmetry, and this is unbalanced AVSD is the diagnosis. So the AVSDs which can have the single valve, but it may be associated especially with the bradycardia in case of heterotaxy, most of the heterotaxies. Otherwise, you may have a linear insertion single valve with a normal rhythm. So many things are there, and there are things which you, if you find linear insertion of AV valve, think about this. Look for the color flow. You will have a single inlet. Look for the bradycardia. If bradycardia, look at the atria which are going to be similar, both left atria. Look for the area behind the heart, and look for associated malformations. Now this is one balanced AVSD. Both chambers are going to be seen, which are quite normal, and you may find an unbalanced AVSD also. Let's look at this volume image. Here, both are, look at the chambers which are both same. Chambers which are, you can see linear insertion of AV valve. Let me freeze it for you. This is a similar chamber. This is what, this is normal. Here, same linear insertion AV valve. And when I go further open, when the valves are open, you are talking about only one valve, close, open. So that's what you can think about it. And in unbalances, one chamber is going to be quite quite small as compared to other. Now partial AVSD, which is typical thing, where this portion, this is septum primum. Let me freeze it for you. You will have a complete idea. Okay. See, this is where there is a gap in the septum primum. So this is a foramen primum which is present, and you will be able to identify the blood flow flowing across that, and that's a partial AVSD. And partial AVSD also, there is going to be a disproportionate length into your chamber width. You can diagnose AVSDs even during your first trimester examination. This is a 12-week heart where you have got a single chamber which was diagnosed, and that's what you can diagnose. On color flow, outflows are normal, but look at inflow. It has got a single inflow. So it's all about AVSDs. At a 4-chamber view, you can have double inlet, and many more associated malformation you can diagnose on the crux evaluation. So now these crux evaluation at the same time, if I cut, then you need to evaluate the valvular arrangement, and this valvular arrangement is going to tricuspid mitral. In front is you will have an aorta, and then absolutely in front you will have a pulmonary artery. So I'm just playing the clip for you. This is how, if I cut here, then you will have mitral valve, tricuspid valve, aorta, and a pulmonary artery. Any rearrangement of these normal normal, if it is going to be in TGA, both are going to be parallel, and in DORV, it may be a different arrangement depending on the type, and congenitally corrected, it is pulmonary artery, you will be behind by one of the tricuspid valve, mitral valve. In aorta, where it is going to be behind by the tricuspid valve. So that's how your CCTGA. Now, one more clinically important defect from crux, let us go to the abnormality to cardiac axis. Cardiac axis can be, as I told you, it can be 45 degree plus or minus 10, but any deviation plus more 10, so up to 65 degree here or less than 25 degree, we call it as a left axis deviation or right axis deviation. As in left axis deviation, unless proved otherwise, you are talking about the malformations of the outflow tract. Make sure that you have seen your left outflow tract or left and right outflow tract, because any cardiac axis deviation which will be associated with many of the cardiac defects. So abnormal cardiac axis from 45, if it is on the left-hand side, left. If it is on the right-hand side, you are talking about right cardiac axis or mesocardia or right axis deviation. So left axis deviation, and because axis deviation evaluation has to be a part, and these axis deviation, which is going to be instead of 5 o'clock position, if it becomes 6 o'clock or this is 4 o'clock. So from normal evaluation of the cardiac axis like this, here, this is what interventricular septum, and this is the line drawn. So this angle is much more than this angle, and these axis deviations are to be decided that okay, we are talking about left axis deviation, and this left axis deviation is associated with many malformation. Showing you one more autopsies to prove left axis deviation. And axis deviation is whether you do it at 12-week, 24-week, or 32, it's same. And you can have your axis evaluation, which will be almost around 45 degree right from 12 weeks onwards. So an early fetal echo, just after 12 weeks, still your cardiac axis is going to be same. So you should be evaluating that cardiac axis right there. So this is a nomogram, which is going to tell you right in early gestation also, this is going to be the same. But here the issue is, whenever you have got an abnormal cardiac axis, all of them will have quite abnormality in more than 75% of the cardiac defect. And in cardiac, when you find a cardiac axis which is deviated, also think about 22q11 deletion and orothymic hypoplasia. Think about outflow tract and 22q11 deletion. That means you need to do invasive testing and identify. It has got sensitivity of 72, specificity little better. It has got a good positive predictive value. If normal, less negative predictive value, but it has got a good positive predictive value about the diagnosis of the cardiac malformations. So in conclusion, when you have got left axis deviation, many outflow tract malformation needs to be evaluated. The outcome of tetralogy of Fellow also depends on largely on, you can predict if more and more left axis, not really good outcome. This is what Alfred Abu Hamad and the group, they said that any axis which are going to be bad, which were having lot of associated cardiac malformation and also the increased nuchal translucency, and instead of nuchal translucency associated with genetic disorder or a cardiac defect. It was an axis deviation which had a better predicting value. So here, look at for a septal defect. Increased nuchal was only associated with 15%. 53% will have abnormal cardiac axis. Any conotruncal malformation, 6%, 76%. So look at the associated abnormal cardiac axis and look at the nuchal, only nuchal translucency. So it is about simple things can give you much better information. Now left axis deviation, let us also take you some of, we'll go through some of the examples. If at all you will find it. Look at this is Epstein's malformation. Look at a gross left axis deviation and look at the valvular attachment here on the right hand side, utilization of the right ventricle. So that's what you have it. Now coming to the next point, which is like again looking at the left axis, one more left axis deviation, which you can appreciate at 12 week. Whenever you have got a left axis deviation, think about these cardiac causes, and these cardiac causes can have many different varieties, and you can diagnose. This is what I'm not going to go into the details of each of the malformation. In nutshell, there are two good reasons why there's going to be an axis deviation. One is cardiac cause, which we have already seen, and there are non-cardiac causes also. So one is like if it is left cardiac causes and non-cardiac. In the non-cardiac, you may have push effect. There is something more on the right hand side. You're going to push the heart on the left hand side, or there is a pull effect. There is something in the heart or the left lung hypoplasia, which will have, or agenesis of left lung will have a pull effect, and you may have a left axis deviation. Make sure that you have ruled out all of them when you find cardiac defect. Abdominal wall defect also has got associated with the left axis deviation. So think about this and look out. I have just put it enumerated the differential diagnosis if at all you are interested. Epstein's malformation, which we have already seen. I'll show you one normal case which we have seen, and this is the volume which you can always diagnose. Let me freeze it for you. This is where valvular attachment is. So instead of valve attached here, it is attached here. Now I play the video and then you will probably appreciate it better. So this is where the opening is and your evaluation about the defect, and which is going to lead to this kind of regurgitation right from at the base, and you will have Epstein's malformation, and that's what it is. Right axis deviation, many reasons. Again, many reasons for left axis deviation, like isomerism, situs inversus, inversion of ventricle. You have got ABSDs, DORV, common trunk, all can have associated this. And at exoposition because of the CCAM of the lung, left pleural effusion, right lung agenesis, or left diaphragmatic herniation can push the heart. One of the example here it is about isomerism, mesocardia, right arch, and both has got three lobes of the lung, and which we are not going to detail in the discuss in the details. Now, you know how to diagnose the TGA, but important point or important crux in differentiating between TGA and CCTGA is the chamber identification. During your 4-chamber evaluation, most important is to identify is right side is right side, is left side is left side, or right side looks like left side and left ventricle looks like a right side. So we do not want to get confused. So we need to evaluate. We need to evaluate the fetus like this, and these fetal evaluation we'll be taking each one by one how to look for this malformation. So identify, we know the identification of left and right. So still a TGA. In TGA, if I freeze it here, let me freeze it here. This is the spine. This is the sternum. You have got a right ventricle, but look at it, there is a moderator bend here. Interventricular septum, tricuspid valve is there. Smooth the left valve. I know right ventricle is at a right side. So I'm pretty clear that the ventricular anatomy is whatever it has to be, it is there. There are two parallel outflow tract. It tells me that it's a transposition of great artery, but ventricle is on right side, and aorta is arising from the right ventricle. So you are talking about the corrected, not corrected transposition of great artery. It's a TGA, or a transposition of great artery. But let us look at this case now. Again, a volume can give you a lot of simple information. Two vessels, outflow tract, good complete diagnosis. They are not crisscrossing, and this is exactly the same fetus or the same autopsy specimen of this sample. Let us look at the details about evaluation of this. This here, I see it's a parallel outflow tract, because I see the parallel outflow tract. But when I look at the chamber, this is the spine, this is the sternum. But look at on the left side, you see the moderator band. So here the chambers are reversed actually. Because chambers are reversed with TGA, my whole diagnosis is not transposition of great artery, but it is congenitally corrected transposition of great artery. Now let me tell you, this is normal. Here, this is moderator band just behind the sternum. Left is on left, and look at this. You have got a spine, you have got sternum, but where the right ventricle should be, this is the left ventricle. So this is a case of congenitally corrected transposition. This is transposition of great artery. Transposition of great artery needs immediate treatment, immediate after the birth. CCTGA, you may not need immediately after the birth. But this is where you can survive. TGA has got brilliant outcome, provided you have diagnosed it correctly. So that's the value of doing evaluation. Some cardiac malformations. This is tricuspid atresia, no tricuspid valve, which is seen, and still because of the large VSD, you will have got a lot of things. Hypoplastic right heart with fibroelastosis in the right side. It is my tricuspid valve dysplasia. This is where you will find a little opening, which is blood flow, which is flowing. The complete atresia, dysplasia. Then this is a Pramod Ahit's case, where you have unguarded tricuspid valve, which you can diagnose. Then there is a rhabdomyoma, which you can always diagnose. Look for tuberous sclerosis when you diagnose rhabdomyoma. Now, from that part, let us go to ventricular disproportion. If right ventricle is bigger than the left, or is left is bigger than the right, many things. Let me show you. If you find these kind of chamber discrepancy, one chamber is bigger than the another one with no other defect, it is not with no other defect. There will be something. Make sure that you have identified, which can be, there are good reasons. I'm just enumerating that almost there are going to be 14 reasons where right ventricle is going to be a little bigger than your left ventricle. So there, it's a complete list which I have enumerated, and you need to rule out. The left ventricle is bigger than the right ventricle, probably right hypoplastic heart syndrome, early pulmonary stenosis, tricuspid or tetralogy of Fallot, which could be there. A hypoplastic left heart syndrome, which is again easy to spot on, easy to diagnose. It has got, if it is easy, the outcome is really worst. In India, very few people agree to continue the pregnancy, and you have many things which will be if you don't have VSD in left outflow, when you have got a left hypoplastic heart, aorta is not going to get blood. So one outflow tract is going to be smaller. If there is a VSD, blood will flow into the other chamber, so that in outflow will be developed. So it's about, if the size of the outflow, also think about whether you should be identifying VSD or not. That will determine the outflow tract size. Showing you it's a common arterial trunk. You have got a, you see, yeah, I will just show it here. Look at the chambers. only one common arterial trunk. If I open, there is a severe left hypoplastic heart associated, but there is a small ventricular septal defect and only one chamber, which is of good size. So that's what you can identify. Right hypoplastic heart syndrome. I'll also show you one case like this. Is a very small heart on the right hand side, but still with VSD, that means I do expect normal outflow tracts, which you may have a good in 3-vessel view, you may have good outflow tract. This is with VSD. So what this is with VSD. So you may have good size outflow tract. Okay. And here, because there is no VSD, your outflow tracts are actually you will have a reversal of flow here in the outflow tract. That's what you can identify. So you have got a normal 2-vessel outflow, whereas here is only one outflow tract with the reversal in other side, because there is no VSD, no blood is coming out of. A tricuspid atresia. This is one valve which is absolutely atretic. There is no attachment. This is a large one aorta which is seen, and that's a backflow from the pulmonary artery which will be there. Let me freeze it here for you. This is only one chamber. This is a complete atric wall. You can see it here also. You can see other wall. This is the wall, but only one chamber which has got an outflow. That's what which is going to be determined. Now, a word about isomerism. I think I've got still Singh Saab, how much time I have? Hello.
I think about 15 minutes.
Fair enough.
Because I skipped my talk in the morning because you wanted to be free. So I'll deliver my talk at 11 o'clock and then Dr. Ramamurthi at 11:30.
Okay. So looking at atria, situs issues which we have already discussed, and situs inversus totalis, it is associated with Cartagena syndrome. Look for situs inversus totalis, and this is what a dextrocardia with common arterial trunk, which you can see the dextrocardia and common arterial trunk, which you can always identify. Now, simple things. Heterotaxy. We know that when heterotaxy, if you really understand what these heteros means different and taxis means arrangement. Instead of 2 atria, left on left, right on right, 2 lobes of lung on left hand side, 3 lobes on the right hand side, spleen on the left hand side, stomach on left hand side, and the liver on the right hand side. If this arrangement is different in a situs, that means you call it as heterotaxy. And there are some of the things which if you really identify, if you really understand, then it comes to it is easy to understand. Why in 4-chamber this isomerism is important, because in abdominal circumference and in 4-chamber view only you diagnose isomerism, and you also diagnose which type of isomerism it is. So in heterotaxy, if you really understand that there are 2 kinds of heterotaxies, thoracic organs is characterized by a rather symmetric arrangement. You have got 2 atria, and you have got similar lobes of lung, and see that there are quite a few things which you need to understand. In heterotaxy, when you look at abdominal arrangement, it is all irregular. Whereas in thorax, in heterotaxy, you will have similar atria on both the side. You'll have similar lobe of lungs on the both the side. So if I've got a right heterotaxy, it is the right atria on both sides and 3 lobe of lung on both the side. So that's what I will expect in heterotaxy. So in the thorax, the organs will duplicate. In abdomen, there is no duplication, but it is either deletion or there is asymmetric arrangement. If you remember this line, in thorax, it is duplicating. In abdomen, it is either deleting or it is irregularly organized. The moment you understand these as a concept, your identification or heterotaxy diagnosis is going to be simple, easy. So now I will talk about simple things. if I draw a line in abdominal circumference in the midline, you will have aorta, which is just exactly in front. Then you will have your inferior vena cava on the right hand side, liver on the right hand side, and you have got a stomach on the left hand side. That's what is arranged in abdomen. And in the thorax, because I cannot identify lobes of the lung, so that's of no point, but I can identify the atria. I can identify the atria, right, it bald, or the left, you'll have a pulmonary veins going inside. So that's what I will be looking for. In left atrial isomerism, as I told you, it is going to be duplication on the left-hand side and deletion on the abdominal side. So duplication on the thoracic organ, if I continue with the same principle, I will expect two atrias, two left atrias on in the thorax. But in abdomen, I either deletion or irregular arrangement. In heterotaxy of left hand side, inferior vena cava is absent. So the blood flows through a zygous vein, gets drained into the right atrium. So that means you are talking about IVC deletion and azygous continuation. And in thorax, I should see two left atria. Okay, and no right atrium. Because there is no right atrium, the SA node which is there, which should be on right atrium, which is not there or not located elsewhere. There are going to be cardiac arrhythmias because SA, it doesn't generate the waves. You have got cardiac arrhythmia, and azygous continuation means area behind the heart will have two vessels. When you see these two things, you are talking about nothing but left heterotaxy, and that's what that easy the things are diagnosed. Complete heart block, interrupted IVC with azygous continuation, and you may find hydrops with cardiac block. Think about left isomerism. So this is exactly what it is. You have got two vessels like this, and a similar thing you can have similar kind of left atria, and look at the appendages of left atria here, appendages of left atria here, and your diagnosis is simple like this. So this is what a small this is IVC aorta, a very small little zygous vein which is going to drain into the superior vena cava. But instead of the angle from aorta and inferior vena cava, there is going to be a large angle. Instead of angle, when it goes straight up to thorax like this, you are talking about continuation of hemiazygous, which are going to be parallel. In right heterotaxy, what I expect, I follow the same rule. The duplication in the heart, in the thorax, deletion or altered arrangement in abdomen. Altered arrangement in abdomen is like aorta and inferior vena cava are going to be just juxtaposed, means they are going to be side by side, whether on left hand side or whether on the right hand side, anteroposterior side by side. They are going to be not opposite side, left, right, no. It is on the same side. Where in thorax, both are going to be no left atria, both are going to be right atria, and that's the reason you will have more complex cardiac malformations which are going to be associated like TAPVCs and all kind of venous system, coarcta aorta, bilateral SVCs, and many kind of malformations in right atrial isomerism. Here there are you can see this from all sorts of isomerism where you can identify many things. A juxtaposition which is going to be there. So a balanced translocation which you can always identify. So what is the difference between right and left isomerism is very simple, that you have got abdominal, you have got on the same side IVC aorta like this same side, but in left isomerism, in the thorax, they are juxtaposed side by side, right? So you will have that kind of arrangement difference in that. And right and left isomerism, the chamber discrepancy or the chamber similarity, bald on both the side, and here both chambers are going to be same. That's what. And in the area behind the heart, you have got single vessel, and in the left you'll have two vessels like this. So in the four chamber view, what are the genetic malformations which are associated? First and most common thing is, I would like to put it across like that. Okay, we may have, most annoying thing is echogenic cardiac focus, where people misdiagnose and diagnose so many anomalies. So echogenic cardiac focus carries actually no weightage, and please diagnose appropriately rather than making in an erroneous diagnosis. I'm not going to go into the detail, but I would like to tell you one thing, that when you have got, just look at, I'm enumerating the number of genetic syndromes associated with cardiac defect, especially four-chamber view. And there are many things which you can identify during your Cartier syndrome, during situs inversus totalis. Now, how to reach? Dr. Singh have said me that you should take a bit about a volume imaging. So I'll take for 5 minutes, then I'll show how to perform. So role of volume, it's like geometry. X-axis like this, Y-axis like this, and a Z-axis like this. We used to draw a line, X-axis, Y-axis, then we used to draw the graph. So it is exactly the same way, and this is going to have rotation. So that it's a knob for X, there's a knob for Y, and that's a knob for the Z-axis. So you can rotate your image. And this one, last blue button, I mean yellow button, where I can walk through, I can go in and I can come out, go in and come out. Because heart is a three-dimensional structure. Any structure which is three-dimensional, like heart and brain, best evaluated by volume imaging, provided you know exactly the anatomy of the heart. That, okay, I'm looking from left side, I'm looking from right side, whether I'm looking from below or up, and what you are looking at. If you have idea, then probably you will come across. So there are X, Y, and Z planes. There are X, Y, and Z planes. This X plane is like where we have captured the image. So we call it as an X plane, reference plane. Usually we should take it in axial plane. You will have 90-degree orthogonal plane, which is going to be a Y plane, which is reconstructed plane, and this is going to give you sagittal section. And this last one, where is Z section, this is Z plane, again it is reconstructed, it is going to give you coronal section. So at one go, you will have everything together. And if I add on the render image, here you are going to find the render image at this particular section, how the heart is inside. So once you have understood this, then there are important points which you need to understand is acquiring image, optimize your 2D, how to acquire, we have to do it live, and we will show. Acquiring what type of image, is it a 3D, 4D, or is it a STIC, or is it a biplanar acquisition for which is possible with electronic probe only. You need also to learn the navigation, cutting, walking from in, out, right to left, is primarily game of a movement of one reference dot. The moment you have understood the game of the reference dot, then you understand this. Now I will show you one complete video. Okay, here I'm trying to look at a 2D image. I'm trying to evaluate, okay, I'm fine, 3-vessel outflow tract, 4-chamber is fine. Now what a normal thing, that's how I perform echo. Switch on the color, I take a complete sweep again and see whether I need to find any malformation. If not there, then I'll straight away acquire volume for 15-degree for 7.5 seconds. So once that data is with me, now I'm the king. I keep my probe aside. I have reduced my size of the image. So now I know that this is the one chamber, another chamber. This is a pulmonary artery, and this is the aorta, which I know. So from here, then my simple thing, then everything starts. I can also evaluate only one reference plane, so that I zoom it and I can go forward. So this is what my outflow tract. Now I know that this is diastole, interventricular septum is good. My reference dot is exactly here. If you see here, I have got my reference dot. So if I cut it here, this is going to give me the axial plane, where what I expect is one chamber, another chamber, and this chunk is going to be interventricular septum, and I don't expect any blood flow going through and here and here. So that's what I will expect, and this is what makes my volume imaging very simple. Okay, this is I'm looking at an outflow tract, again, left outflow tract, 4-chamber view, crux I can see, my walls I can see so many intracardiac structures together, and I can go on evaluating. So this is what now I am going to the render mode. I've just rotated image to make it upright so that I understand it better. Because I'm looking at it posterior aspect, I rotate it in front. So now for everyone, I've just rotated in front. So this is what during systole and during diastole, I have got a very clear idea that this is what my image is. Let me freeze it for you. This is a complete image during diastole. And just if I move forward, this is beginning of systole. And if I go still up, this is a good chunk of full systole. So outflow pulmonary artery, aorta originates behind, no VSDs, nothing. So that's about a STIC volume imaging, and that's how we just do it. A foramen chamber, 4-chamber view. I think I'll skip some of these cardiac the 4-chamber cardiac function, because I need to show you some live fetal echo. Let me show you fetal echo live. Here, how we probably do it. This is what I'm right now doing a 4-chamber view plane. I'm just doing a regular routine evaluation of the heart. I know that this is one outflow tract, another outflow tract, good interventricular septum which is there. I know 3-vessel view, 3-vessel trachea view. I'm fine with the outflow tract. I'm good with the 4-chamber view plane. But I also make sure that whenever I'm acquiring a volume plane, I will reduce my PRF little, because even if it overflows, I can correct it later on. So from here, I little more less PRF it is there, but I have acquired the image. I started acquiring the image, and my job is finished. I've stopped acquiring. Now just look at my I have just done it. What here? I'm just freezing it for you. This is what I'm just trying to get your one plane in your TUI image mode. This is button where it is going to be TUI image mode. Now the color I feel too much. Then also I'm reducing the speed so that I strain less to my eyes. Reduce the heart rate. You can always reduce the heart rate. I'm just walking through from the base of the heart to the 3-vessel view. So this is what I'll probably do. From now, I have gone to a render mode imaging. This is one pulmonary artery I can see. I can see the left outflow, and also I can always walk through. I can walk through the chambers, and I can identify many things. So from that, I'm just capturing it again for you. This is one more again, just capturing it again. Because every time the fetus may not be in a good position. So it may take some time. So don't get frustrated. Eventually you are going to get. So let me play it for you again. Outflow tract, chambers which are good. If your color perception is good, then your volume acquisition is going to be better, and your analysis is going to be better. Now you can see during even your septum primum, you can see. You can add on TUI. You can add on what is known as VCI, volume contrast imaging. Now I'm good. I'm happy with my acquisition. I can have a better moderator band is seen, interventricular septum, because here my primary interest for you to show the 4-chamber view. That's what I'll be happy to do it. Apex is formed by left. This is right ventricle, moderator band, interventricular septum is good. Both AV valves are good. Aorta is at shape. There is nothing between aorta and the spine, and that's how I will probably do it. Now let me show you the first trimester. The same way, a first trimester also can be done, and let me show you how which we can
normal
do it.
2D echo along with your color or HD flow, and then how we can utilize STIC to get more information from that. Let us start. Right now, I'm at my 4-chamber view plane with the biplanar mode. I'm just looking at your 2D examination, and this 2D examination, I know that I could see 4-chamber view right now. And then at a 4-chamber view, I have placed my cursor for the 4D STIC. Okay, now once we have acquired your volume image, now you can see here, my finger, at this point, I'm in a multiplanar mode. Multiplanar mode, important point is this yellow reference dot. Wherever it is there, it will show the 3 dimension, the cutting in axial section, coronal, and a sagittal section. So from there, I'll switch over to render image because that is easier to understand. Then what I will do is I'll press the single image because I'm more interested in render image. I'll put it this way. So here, if I stop, look at this is the stop button. I stop it and then try to scroll. Here, I know this is a diastole because both the chambers are being filled. And the moment I go in the systole, I know this is pulmonary artery and this is aorta, which goes there right there. So this is all crossing of major vessels, which is normal. I could see tracheal V, which is formed. I could see interventricular septum, which is good. There is no defect. This is what as simple as that. In this, now I run the clip for you and reduce the speed to 50% so that you appreciate the systole and the diastole, and you can say confidently that this is even at 13-week, 2 days. I know that fetal heart is absolutely normal. From there are other different views. If I use a TUI section, what I will reduce, I will increase the slice. I will add on VCI. This is the VCI. Look at the difference what adding a VCI will make. It will make your image crisper, sharper. And here also what I know, I have to reduce the distance so that I evaluate the feet, each of the section appropriately. And then what I will do is I will press again this switch to make it the single frame. And once during this also, I know that this is the pulmonary artery. This is the button which you can use to look like a walk through what we called it. Because I want to evaluate the ventricles, they will be more appreciated in diastole. I will put it, I'll roll my trackball to take the cardiac systole, the cardiac cycle into the diastole. Now I can see here where a complete interventricular septum, which is there are 2 chambers which are feeling really well, and that I can look that okay, my the entire system is quite.
So at the end, my recommendations are going to be fetal echo is easier than what you think. Grayscale, HD flow, color, and slow flow, that is important. Make sure that you follow the protocol. You follow the rules. See the 12 points in 4-chamber. Look for the situs, and that's what my recommendations. Because there are 60% of the cardiac defect you will be able to identify during only your 4-chamber view plane. We can continue evaluating 4-chamber view plane, I can tell you, for 4 days. For 4 days, only one section, we can just go on discussion. We can go on discussing the planes. So, but because we have, although it's a huge time, 90 minutes time, we have already discussed, still I find which is going to be, I'm not showing you any abnormal things, but because a few things which I have shown you, this is what my recommendations are going to be. And thank you very much, Dr. UP Singh, for giving me the opportunity to discuss what I feel about my 4-chamber view plane. Thank you very much.
Wonderful, sir. Excellent lecture and excellent lecturer. You know, we know him. So our gentleman is represented western part of India. And we have somebody from the south of India, and I am representing Chandigarh, the north part of India. So in the meantime, let me go through the questions what we have. And I think I would do the honor by running a commercial video, the sponsors of the. So let me now read out a couple of questions. I'll keep my screen share on so that next presentation would be from me. There are questions. I think most of people have said excellent, wonderful, amazing lecture. So I think it's a good feedback for sir, but he's been hearing this for many years. Now, there is one question that can you please explain the sites by left hand and doll?
Side by left hand.
Can you please, I'll just read out as it's typed. Can you please explain sites by left hand and doll?
Okay. Can you see this? I think
Yes,
you
we
see
can.
this, right?
Yeah.
So this is my head. If I'm standing, this is my head. This is my left leg. This is my right leg. This is my right hand, and this is my left hand. These knuckles are spine. Consider these as a spine. Okay, so if I stand up, then the thumb represents my right side, isn't it? This is my right side. Okay, so if the baby, see, consider I'm pregnant. Okay, and okay, I'll be like this. If the head is here, the spine is on maternal left side, then the head, this head is like below, the spine is here. That means because my probe is going to be here, so the first structure which comes is fetal right side because it presents the thumb, and the left side is going to be below. So when you see a screen and on this side, on the top, when you see an ultrasound bar like this, it is the structure which is near your this round circle is going to be the fetal right side, and you find stomach, tracheal V on this lower portion. So for example, fetus is having transverse position where the head is on right side, spine is on anterior aspect. In that case, what happens? The head, this is the head which goes like this, spine on anterior aspect. So because spine is on anterior aspect and probe is going to be here, so it is at this side is because it is left side. On the top, what I expect on the top is going to be the stomach. I expect the apical four-chamber view, and I expect tracheal V on this side. If it is bridge position, say for example, bridge is here, head of the spine is on maternal right side. This is bridge, head up, spine anterior. So because my probe is always here, near the probe is going to be the right side and away is going to be the left side. So that is how your situs orientation by drawing a doll, because my left hand is free. I am not doing anything with my left hand. So I
Yeah.
use my free hand to identify the situs, which is becoming very easy. And because see the clockwise, anti-clockwise, there is one more method, but that
I'll
creates-
explain that. I'll explain that.
Okay.
Yeah.
So Dr. Singh is going to explain. So I'm not going to into the details. So this
Because I think you skipped abdominal view, so I thought I'll take a couple of slides there.
please.
Uh,
Any other question?
Yeah, there's just one question which I could not make out well, but I'll read it out as it's written. Perimembranous VSD and inlet VSD looks like normal crux defect. I didn't get it.
No, it's like I think they wanted to ask about inlet
Huh.
VSD, not perimembranous VSD, because
Yeah.
see inlet VSD and crux defect.
Oh.
Inlet VSD is we do not consider only inlet VSD as a crux defect. It is considered as a part of ventricular septal defect. Only septum primum defect, septum interatrial septal defect, or a septum primum defect, we consider it as a part of AVSD, but not only inlet VSD we consider as a part of AVSD.
Great. Thank you, sir. Thank you very much. I think your talk was very lucid and hardly any questions. Great job done, sir.
Thank
So,
you very much.
I'm going to present my talk. I am Dr. UP Singh, and I am a cardiologist. I did my MD from Amritsar Medical College, did my DM cardiology in 93 from PGI, and I have been dedicatedly involved in non-invasive cardiology since 1993. It's about 31 years now. For last about 1 decade, I have a passion for fetal echocardiography, and this is what I was converted from cardiologist to fetal cardiologist. We have guidelines which are recently published in this is ASC, American Society of Echocardiography guideline. These are the most recent guidelines on fetal echocardiography. You guys can go look up this, download this. They are very comprehensive and nice and up to date. These are from 2023. The issue is that how do you screen the fetus for fetal heart? There are 2 ways of doing it. One way is that you screen everybody, which is an ideal way of doing it, because the chance of fetus having cardiac abnormality in a low risk group is very small. But if you see the total volume of the low risk category of pregnancy, the total number of cardiac defects, in fact, are higher. The sheer number, not the percentage. But if you talk about percentage, you have a higher percentage of heart disease in high-risk patients for congenital heart disease, but the number is smaller because this category represents a smaller number. So we always would wish that if we could scan everybody, we may be able to screen for congenital heart disease and at least take care of lethal or those who are not possible to sustain with life before the child is born. But this screening for fetal pregnancy, everybody, is a bit of a challenge. That challenge I'm going to break. I just want you all guys to do basic screening echo. And if you see what are the high risk category of people, pregnancies or feti which are likely to have a congenital heart disease. You have a maternal history of a congenital heart disease, metabolic disorders, even diabetes, exposure to teratogens, fetal abnormalities. The most common is that ultrasound is done and then we find that the fetal heart is abnormal. As of today, this is the commonest indication of screening for a high-risk congenital heart disease. And these are the patients referred for a specialized fetal echo. There are other things. You have irregular heart, increased chromosomal abnormalities and other genetic associations. You have a family history of a heart problem. So these are all areas where the fetal echo is required. If the risk of congenital heart disease is less than 1%, which is a general public risk, which is about 1 in 1,000, the fetal echo is by a specialist is not indicated. You can do a screening echo yourself between more than 1% to 3%. I think it's ideal to a fetal echo to be done by an expert, because that is where it is more important. The likelihood of missing something is not there. In the performance, in whom should we do fetal echo? By whom should it be done? When it should be done? And what equipment do we need? It's recommended for a high-risk pregnancy. I'm talking about the advanced fetal echo or exclusive fetal echo in this area. Anybody who's trained. Training means about fetal echo learning takes about 4 or 5 years, but you've got to be trained in under somebody to have an observation. We still have no guidelines on international that who are the people, those who are competent to perform a fetal echocardiography, but a fetal medicine specialist who's trained in cardiology or radiologist or a cardiologist. Again, a cardiologist got to be trained in fetal echocardiography rather than just a pediatric cardiologist or an adult cardiology. That's not enough. So we can start a fetal heart examination in early gestation. We can do a limited fetal echo, but we can pick up some lethal abnormalities on the fetal heart early enough. But 16 to 24 weeks is an ideal time when most of the growth has happened and the heart has size has increased. But let me tell you, heart size still is about the size of an almond. So looking at the size of the heart and fetal echo is going to be very challenging. Third trimester, many abnormalities like rhabdomyomas, ductal restriction, so many other conditions can actually happen. Arrhythmias can happen late in the gestation. So scanning a fetal ultrasound, in case it detects some abnormality or there's some suspicion, should be referred for a fetal echo. Early pregnancy, transabdominal or transvaginal is fine. And then in the late gestation, we can use a linear probe with a very high resolution, curvilinear probe, which could be of a higher resolution in early pregnancy because it has low penetration, but a lower frequency probe, which has a higher penetration. So this is used in a third trimester or advanced pregnancy when you have a lot of spine shadows or rib shadows obstructing the view. A cardiologist who is not actually trained in fetal echo, I think ideally, I also passed through the same phase when the fetal echo field was kind of developing. I entered into that field. But, as a cardiologist, I might feel that I don't know how to swim, but doesn't matter, this is a very shallow waters, but you can get something unexpected there. So I understood the water was not shallow enough in area. So it's a good idea to learn swimming before you jump into the sea. Let me take one by one these aspects. Let me talk about equipment first. Most of the cardiology equipments have certain advantages and disadvantages. There is no speckle reduction. We cardiologists love speckles. In fact, there's a less of dynamic range because we need more of a contrast in adult echo. It's less smooth, but it's very good in color. But as compared to this, we have radiology related with the marked speckle reduction. We have a very nice smooth image, but it's not as good in color Doppler. We know that. For a speckle reduction, there are various techniques evolved to do that. And one of the techniques is compound imaging. You have a lot of speckles here. What you do, the scanning by the system is it scans in this direction, then scans in another direction, scans in another direction, because the speckles are kind of unique to the direction of the beam. So the speckles would be different. You subtract the things from each other. The speckles get subtracted and you get a nice smooth image, with obviously the cost of reduction of a frame rate. You maximize the frame rate by reducing the width, increasing the depth, and zooming, which should be the right zoom. The 2D color, and it's always wise to have a side-by-side 2D with the color. You don't do color without having a 2D on the side-by-side. You don't lose anything actually. There is no reduction in the frame rate or resolution. So it's always a good idea to have a 2D image alongside for a reference. There's something new which I think you guys need to know. Maybe you try to find out in your system, balance or priority. Balance or priority is that what priority do you give to 2D versus color Doppler? And if you look at your color bar, you would see a 2D bar alongside, which I didn't understand in the beginning what it actually means. Let me go back again. So this line indicates what priority do you give to the 2D. The line is lower down, the priority to 2D is low. If you go higher, the priority to the 2D. Priority means what? Balance means what? Means that when you see the image, how much information of 2D is represented there, because there's an overlap of information from color Doppler and 2D. So how much 2D is suppressed to show color is what balance is. Okay, you search in your equipment where balance or priority is. Now here you see the balance is set to this place, and then you see the color Doppler is not as good. You shift the priority to the color Doppler and look at the pulmonary veins. You can see it very confidently. Again, shifting the balance to a high priority to the 2D masks your color Doppler, gives speckles in the color Doppler because of the 2D. But if you keep it on a higher side, it would give a larger, and you can see a large VSD here where 2D information has suppressed that. So balance is a very important thing. I generally keep balance to the maximum when I'm scanning and doing a color Doppler. There are other techniques of improving your smoothness. I would not really go into detail, but this is something which is nice. You can use a power Doppler. Now, most of our flows in the fetus are slow flows. They're not fast flows. The velocities are low. The Doppler is based on velocity shift, correct? So if the velocities are not high, you're not going to get a good color Doppler. But if you, let's say, if I use an amplitude rather than the velocity, what is amplitude? Amplitude, I would give you an example that how many number of RBCs are moving in that direction rather than the velocity. The number of RBCs is fairly large. So if you use the amplitude, you would be able to get. So if you use a power Doppler, it uses amplitude rather than power. Okay. What is an amplitude? This Arijit is singing at one frequency. The frequency is same. It's not very different. When it's joined by a choir which sings at the same frequency, the frequency remains the same, the wavelength remains the same, the amplitude increases. So if you use this amplitude, large number of RBCs traveling through the vessel, uses the power Doppler, you'll be able to get a better quality of imaging. Size does matter. I'm going to tell my cardiology colleagues that this is the size for reference. This is the size of the heart in reference to an adult heart. And this is actually size of an almond. And you can see my hand for a reference in an adult heart. See the pins and the size of the heart. So if the size is small, you have challenge on the resolution of the equipment. And you all know that resolution depends upon three factors. You know, there is an axial resolution, which is alongside of the beam. There's a lateral resolution, which is poorer than axial resolution. That's a fundamental physics of ultrasound scanning. And azimuthal resolution, which is the thickness resolution, which is the poorest. Why I'm showing you this? So if you are taking a measurement in the lateral side, your measurements are likely to be a little off the track because the resolution is poor. But if you take the measurements in the plane of the axis, If you take it this way, measurement in your plane, in your sector, it's likely to be little off. If you take it this, because the resolution is very good, that is what is important. Then azimuthal is thickness. I'm going to give you an example of azimuthal resolution. On the monitor, what you see, you think that this is a thin razor kind of an image, and this is what you presume. You see this color, and you see another color coming, blue away from the transducer, and it looks like as if it's coming from the aorta, but it isn't. Okay, so this is why it isn't, because there is something called azimuthal resolution. What you are seeing is not a thin, razor thin image, it is actually a thick image. Okay, it's kind of a 4 slice or 16 slice CT. You have a thick image. You see the reference structure which are in front and back represented on the same plane. Correct? So if you have this is the pulmonary artery and aorta represented in the same plane. That is why you see the pulmonary artery and aorta in that way. This is how, when you see the pulmonary artery and aorta crossing each other, I mean, they look in the same plane, but they are not in the same plane. This is because of the poor azimuthal resolution. Azimuthal resolution become poorer when you are on a color Doppler. Angle of acquisition in fetus is very important, and remember always to scan the fetus again. Okay, in case you have abnormality, I'll emphasize that in my next slide. So scanning, look at the scanning here. This is a 4-chamber view, which is a lateral 4-chamber view. You don't see much of the crux here. Like Dr. Prashant was telling you, the crux seems perfectly good unless you change the. So this is the baby acquired an ideal position, the apex on the top, and this is a apical 4-chamber view. Look at the common AV canal. If you had just relied upon this view, you would have missed a very, very important finding, that is common AV canal. So for now, we know that for everybody, for beginners and even for advanced, apical 4-chamber view acquisition is must till you say that, okay, fetal echo is complete. So fetal echo is not complete. You review the fetus again with an adequate fetal position. Patient can wait. Doesn't matter. It's good to not to miss AVSD. Okay, then to say a patient is in a hurry, wants to go. So it's perfectly fine. You scan the patient once, twice, till you have an apical 4-chamber view. The fetal echo is not complete. I mean, it looks like a horse here, but obviously when you have a different angle, it looks like a frog. So that's what. So whenever you have a positive fetal echo, always repeat that. In my practice, I have seen, once I have a positive fetal echo, even if I have a VSD, I always scan it again. I have found other abnormalities, because the most common missed abnormality is the second one. You're so engaged in the first abnormality, you miss the second abnormality. So this is second one which is missed. So this is very, very important. I tell you the truth, I have seen 1% abnormalities once I review my videos months after I've scanned and sent the patient. When I'm going to present a talk there, all my senior colleagues would agree, we find something new there. So we tend to miss abnormalities. Once you have an abnormal fetal echo, repeat again and again, right? So that's one is very important. I'm running short of time, so maybe I'll try to skip that. Now, this is a perimembranous VSD. Okay, and this is a dropout. Why I say dropout? This is a aortic valve, and this is above aortic valve. You can't have a VSD above aortic valve. So this actually is an aortic wall here, which was thin and shows the dropout. Okay, so I think I would cover this in my subsequent talk. I would skip all this. And why, for the cardiologist friends, we always knew that, okay, we can diagnose TAPVC. How? because we can diagnose TAPVC with pulmonary vein entering into the left atrium. It's so simple. But that is not as simple in the fetus, because in 16 to 20 weeks of gestation, pulmonary veins look like going right into the left atrium. This is one pulmonary vein, that's another pulmonary vein. It looks like as if entering, unless you see this. This is atrial wall. And with the poorer resolution with our current equipment, you may not see this membrane. If you don't see this membrane, you might feel that the pulmonary veins are connected normally. That's why in the 2005, when the resolution was fairly poor, the prenatal detection of TAPVC was 2%. Okay, but now with a good resolution, you see the pulmonary vein and you see this membrane, and this is the posterior chamber. So we developed a couple of indirect signs. One of the indirect signs was if you have an increased distance between aorta and the left atrium. Second was a twig sign, that you see a common chamber in this increased distance. We had published another indirect sign, that is a bald left atrium. It's not actually punctured. This is the sign with the Coumadin ridge. You guys on adult cardiology know a Coumadin ridge is a kind of ridge which we used to see on a transesophageal echo. This is a ridge of invagination of the left atrium into the left atrial wall. This is because of the indentation between left atrial appendage and left upper pulmonary vein. This ridge was actually sometimes mistaken for a thrombus, and people started Coumadin on that, and that's why it's named by Coumadin ridge. We can use this Coumadin ridge to our advantage. How? Now, if you have a Coumadin ridge, you require one pulmonary vein to enter into the left atrium. So if one pulmonary vein enters into left atrium, that's only you would develop this Coumadin ridge. And if you see this Coumadin ridge, okay, that means this rules out TAPVC. At least one pulmonary vein is entering into the left atrium. So this we found it very useful. Overall time taken to look for left Coumadin ridge was less than 2 minutes after you acquired 4-chamber view. Other indirect signs were for TAPVC, which I think I would cover up again in my talk after Dr. Ramamurthi presents. And I'll skip a couple of slides and then go to. So these are indirect signs for transposition of great arteries, indirect signs for transposition of great arteries, and these indirect signs are very, very important. The next thing which you guys need to know is that in the fetal heart, usually there are no gradients. There are parallel circulations. Blood would tend to flow in the low resistance area and would kind of skip the area where there is a resistance. So that's why the flow is less on that side. Let's say, for example, there is an aorta, coarctation of aorta. The flow across the coarctation is by resistance. The flow reduces the across coarctation. It prefers to travel from the other side. Okay. So that's why if the flow is less, you would get less gradient. So you don't get gradient. For example, this is a patient of tetralogy of Fallot. You have a smaller pulmonary artery, and if you're trying to look for the gradients, there's hardly any gradient across the pulmonary valve. It's just 1 meter per second is the peak velocity. So you don't get gradients here. Blood, rather than going through the pulmonary artery, prefers to go to aorta. Aorta gets dilated, PA gets smaller, and that's how you diagnose tetralogy. So tetralogy of Fallot, you don't diagnose by VSD and increased velocity. So this is what is this is the fourth common congenital heart abnormality, coarctation. It's the most commonly missed abnormality, coarctation. And what happens here, if you have a coarctation of aorta, the signs of coarctation aorta, the most common sign of coarctation of aorta is RA-RV dilated, and that's it. Okay, if you are lucky, many a time you see this small narrowing at the isthmus. This becomes a coarctation of aorta, but many a times you don't get that. Commonly, you get a ventricular disproportion in coarctation of aorta. And why does it happen? You have the resistance across this coarct segment. That means there is a resistance from the blood coming from LV to aorta is resisted here because of the increased distance. Preferentially, blood flows from foramen veil to the right side. It goes to the pulmonary artery, and then from the ductus, it goes to descending aorta. The purpose is served. So now in this process of blood flowing from the LA to RA, the RA and RV chambers and pulmonary artery are dilated, which is the most common indirect sign of coarctation of aorta, and we have various sensitivity and specificities there. We, in the fetal heart, we have special views. Dr. Ramamurthi is going to take this view of the three-vessel view. So I would not discuss that. And then we have various structures where I'm going to tell you something very important. In the fetus, we have ductus arteriosus, which is amenable to constriction by various substances in advanced pregnancy. When the ductus becomes sensitive to prostaglandin modulation, any prostaglandin inhibitor would produce a ductal restriction, can produce right ventricular obstruction and problems. There are simple and common causes of ductal restriction. You can see that. Another thing is the ductus venosus, which can go abnormal in direction. Another common factor in difference between fetal heart and adult heart is that the disease can progress rapidly in a prenatal period if the blood flows less to particular area. Even a simple severe aortic stenosis can develop hypoplastic left heart syndrome because it is the flow which lets the chambers enlarge and form for the future. But in case the flow is less, then the chambers on the left side do not grow well and produce a problem. Arrhythmias, I would take that arrhythmias in my end of the talk. We don't have a luxury of an ECG like an adult cardiologist. We have to depend upon the mechanical factors, and by doing mechanical factors, you can actually pick up the arrhythmia. I did publish one review in our Indian Academy of Echo Journal, that my journey from adult to fetal cardiology. For an ISO guidelines, I'll skip that because that already been discussed by. But let me tell you something very important. Remember, in case you are doing a 4-chamber view, you are going to pick up most of the things, and very good performers would have most, even novice would be able to pick up things in 98%, only 2% missing rate. But in an LVOT and RVOT, this is where, you know, most of the beginners or novice, they actually fail and create problem. 3-vessel view also is reasonably okay, but LVOT particularly. So please stay back. At the end of this webinar, I'm going to discuss LVOT and RVOT views, because this is, I think, which you all guys need to practice and, you know, perform better. So whenever you have a scanning protocol, there are scanning protocols, and ISOG has been discussed multiple times in multiple fora. But once you have a scanning which is abnormal, then it's done. Then you don't follow any protocol. The ISOG protocols are done. Then you have to go to segmental sequential approach. So segmental sequential approach is that you have veins, then atria, ventricles, and arteries, how they are connected with each other. Okay, the 4 anatomical segments. Dr. Ramamurthi, I'll take just 3 minutes more.
Yeah, no problem.
Yeah, so 4 anatomical segments: venous, atrial, ventricle, and arteries, how they are connected with each other. So this is segmental sequential approach. Then you figure out what are the associated abnormalities: ASD, VSD, stenosis, then the functional assessment. Okay, so this is the steps by which you follow. So again, common structures: 4-chamber view. This is the abdominal view. Okay, and how do you decide the situs? Dr. Prashant Acharya sir wanted, I am just showing you this clockwise rule. Now, in case it's clockwise, you have an aorta, stomach, and gallbladder or umbilical vein are in a clockwise fashion. Okay, clockwise fashion. 1, 2, 3 are clockwise, then head is caudal. It's simple, head is caudal. If head is not caudal, you see this, then there is a problem. So if head is caudal, you can see the heart. Forget about head. What I do is heart. Okay, the heart is caudal. Just scan abdominal view, clockwise rule, and I move my probe caudally and I see the heart. That means situs is normal. Now, if it is other way around, if you have aorta, stomach, and umbilical vein on an anti-clockwise position, head or heart has to be cranial. You do a cranial sweep, the heart has to be there on a cranial sweep. So which means that stomach is on the left side, your situs is fine. But if it does not happen, that means the stomach. Now, clockwise, if answer is yes, you are good to go. In case you have clockwise and the answer is no to this rule, then stomach is not on the left side, the stomach is on the right side. So once you know the stomach is the right side, you know which is left and right, you can proceed from there. So then again in isomerism, I would not like to go into that. So I'll skip all that. This is all what you need to do in once you have atria, you need to find out which atrium is which side. Then you have what is the way which atria are connecting to the ventricle. You can do it. AV morphology, chordae, papillary muscle. You need to see what is the AV connection. Are there two atria connecting to two ventricle? Are they concordant or discordant? It's a long discussion, which I think would take a lot of time here. I would skip that data and move on to. So then after we've decided atria or ventricle, you decide what are the normal arterial relations. Normal arterial relation, the aorta is posterior. Actually, the pulmonary artery is anterior and to the left of the aorta. PA anterior and to the left of the aorta. And this is how you decide aortic relationships. D, the TGA is aorta anterior and to the right. LTGA, aorta anterior and to the left. Okay. And you can have a anteroposterior relation. You can have a side-by-side relation, particularly in DORV. And these are the various positions of great arteries which are known to occur, and they do occur. So then you look for associated abnormalities like a VSD, that is stenosis, then regurgitation, obstructions. Then you do the functional assessment of the heart and arrhythmia. So that's how it completes your, and this is the reporting format which we use, is that we do mention about gestational aid and biometry, situs. Then we say the venous system in segmental sequential approach. We mention about atria. We mention about atrioventricular connections, which way they're connected. We mention about the ventricles. Then we mention about the atrioventricular connections. Then we make a mention about associated abnormalities, and we mention about cardiac rhythm and cardiac functions. So thank you very much here, and I think I would stop short here, and let me see if there are any questions in the meantime. Dr. Prashant, you want to say something?
No, again, some brilliant images and some very, very good clinical points which Dr. UP Singh has said. And I think we all are waiting to listen to Dr. Ramamurthi. Good morning, Dr. Ramamurthi.
I think there are not much questions here. And one is that, sir, ductus arteriosus dilatation, can you discuss in short, please? Yes, ductus arteriosus dilatation commonly happens when there is an increased flow across the right ventricle, particularly in the late gestation. The ductus dilates, becomes tortuous. There are two kinds of tortuosity, U-type and S-type tortuosity. ductus become tortuous, dilated, and in fact, you get increased flow and velocities across it. Once you get increased flow and velocity, you might think that this could be a ductal restriction, but actually a tortuous ductus would save you.
I tell you, we have published a paper on ductus tortuous ductus arteriosus. It was very common with the post-COVID or a post-severe viral infection. The ductus becomes tortuous, and it may create functional coarctation aorta. It appears that the aortic isthmus seems to be quite smaller, but actually it works as a still phenomena. Blood is being stilled from left side to the right side because it creates less resistance. So a tortuous ductus arteriosus, of course, it is easy to pick it up, but there are a few things which is associated. Is please rule out a chronic viral infection which she must have suffered in last 4 or 6 weeks. If it is there, then think about a small aortic isthmus which may convert to a normal size aortic isthmus once that tortuous ductus gets closed spontaneously after the birth. So that's something which is there. And if you find, even if it's dilated, that is pouch of Comeral, occasionally it may persist as a pouch of Comeral after the day 5. If you do an angiogram, then you may find this pouch of Comeral after that. So that's what we have seen. We have documented already 3 cases like pouch of Comeral, which may be persistent for quite some time after the birth. So that's what about tortuous ductus.
Yeah, wonderful, sir. Dr. Ramamurthy, please, the floor is all yours. And I think let me do that formality of introducing Dr. Ramamurthy. Does anybody need the introduction for Dr. Ramamurthy? I really don't think so, but again, I would say who hadn't heard about Ramamurthy and is doing a fetal scanning, I think the guy is not well connected. So Dr. Ramamurthy is currently a consultant at Srinivasa Ultrasound Scanning Center. Do I tell you that this center was started 35 years back? And he was the first radiologist to start a practice in Karnataka. Wow. So this is in Bangalore. He founded Fetal Foundation of India, and he is founded Medical Ultrasound Society of Karnataka called MUSK. And this again is at 25 years old, and where he is actually dedicated himself to training, mentoring newer generation. He is a radiologist. He did his MBBS and DMRD from Bangalore Medical College. And from a CMC Vellore, he did his MD radio diagnosis, DNB also in radiology. And he had a stint of associate professor in MS Ramaya Medical College, Bangalore. That's what actually reflects in his professorial talks. Dr. Ramamurthy has written a wonderful book on imaging of fetal brain and spine. You must read that, probably the best book I've ever seen. And he's contributed many chapters to many books. He's given oration awards, and I think he needs more. And not only in India, is given in Bangladesh, Singapore, Malaysia, Kuwait, UAE. He's actually involved in training people in Kuwait. Oh, hats off to you, sir. And he's the sought for speaker in India. To get an appointment from him for a talk is a task. Dr. Ramamurthy, please. You can share your screen, sir.
Yes, yeah. At the outset, Dr. U.P. Singh, thank you for hosting this wonderful program, and thank you for making me a part of this program. And my namaskaram to my co-faculty, Dr. Prashant. And I think you have set the whole session with a rollicking start. And I was partly to the last part of your presentation, wonderful graphics, I should say. And those graphics really go a long way in actually helping us to understand a complex organ like the heart, the way it twists and turns, to finally produce the wonderful effect that it produces for over the lifespan of an individual. So with those remarks, I think we should get down to business. It is 11:50 on my watch. I'll start sharing my screen. And Dr. Yupi Singh has asked me to do two distinct areas. One is the area of three vessel trachea view, and the other one is the sagittal arches. Most of this presentation will be allocated to the three vessel trachea view because it's a part of the basic examination that we need to do in the mid-trimester anomaly scan. And the amount of information it gives is astounding, and we will go through that. And then afterwards, in the end, I will take you through the sagittal arch views, both in terms of technique, in terms of normal findings, in terms of abnormal findings. So let me do the first presentation first. Okay, is my screen seen?
Absolutely good, sir. Good to go.
Okay, and the laser pointer I've chosen because it looks good both on light and black backgrounds. I'll just take you through one clip, and I just want you to tell me if this clip is playing well. Oh, if I use the laser pointer, I can't play clips. So I think I should go back to the regular pointer. Yeah. I just want you to see if this clip is playing well. Smooth. Is the clip playing all right? Hello?
Yeah, it's a little slow, but okay.
It's slow, but okay.
Yeah.
My speed is good. Anyway, we'll take it as it comes by, right?
Yeah.
Okay, the three-vessel trachea view was first described by Yu et al. In 1997. So it's there for a long time. 1997 is 3 plus 24, 27 years, right? And it has been included as a standard plane in extended basic fetal echocardiography. And these are the views. Of course, you have the upper abdomen, which is should figure out over here. Upper abdomen followed by all the other views. And therefore, it becomes very, very important for us to know it. A word on the technique of getting the three-vessel trachea view. So we all know that the four-chamber view is an axial view. This is a side view of the transducer, and this is the side profile of the beam, and we are cutting the heart transversely in the axial plane, four-chamber view, and it's a simple translatory movement upwards. That's it. When the transducer moves upwards, and maybe you'll have to subtly angulate as well, you move from the four-chamber view, as you can see here, and you pass through transiently the five-chamber view, and then you come into the three-vessel trachea view. So I'll play that clip again. You start in the four-chamber view, and then you briefly go through the five-chamber. Then you land up into three-vessel trachea view. A very subtle move of both translation and angulation. And you can extract out your planes as follows. Okay, that's the four-chamber view. That's the five-chamber view. And that's the three-vessel trachea view, all in a flow, right? Now, by default, and you see the same thing. So I start from the four-chamber view, and then move on to the five-chamber, and then to the three-vessel trachea view. You can actually extract your views as well. That's the four-chamber view. That's the actual pulmonary artery bifurcating. You can see. Then I go up a little bit. That is a three-vessel view. That's the pulmonary arch or the ductus arch. This is the short axis of the aorta. This is the IVC. And then I go on to the full-fledged three-vessel trachea view with the characteristic V happening here. this being the trachea and this being the SVC. We'll come to the anatomy a little later, right? Okay, so now we need to understand that this is a view, a transverse view going through the superior mediastinum. We need to identify the sides of the fetus, which we have already, because you would have finished situs by the time you come to the three-vessel view. So after having marked the right and the left sides of fetus, right and the left sides, we find that the rightmost structure is the SVC, in the middle is the aorta, and the leftmost structure is the ductus arch or the pulmonary ductus arch. So the same thing translates out here in the three-vessel view. We'll go to the three-vessel trachea view a little later on, and you find the SVC to the right side, the aorta in the short axis, right in the middle, and you find the pulmonary artery in the long axis. Also showing you in this particular picture, the right main pulmonary artery or the right branch taking off, classically going behind the aorta and the SVC. This is the traditional or a trademark relationship of the RPA going behind the ascending aorta as well as the SVC. Right, so that is the three-vessel trachea view, and it's important to realize the amount of information, the spatial information stored here in one single plane, which is this plane here, an axial plane. When you see cross-section of one great artery matched with the long section of the other great artery, these two great arteries must be perpendicular to each other at their origins. So if you get a three-vessel view like this, you know for sure that the great arterial crisscross is present. So look at the amount of hidden information as far as the three-vessel trachea, as far as the three-vessel view goes, right? We also have to understand that you can draw a straight line across the anterior aspects of all the three vessels, meaning that they have a linear arrangement and none of the vessels is breaking the line and going anteriorly or posteriorly. Very, very important. And that the aorta is a trace smaller than the main pulmonary artery. Both of them are almost equal. Aorta is a little smaller. The extravascular structures that we see in the three-vessel view are the lungs on either side, and you have the distinct thymus in the middle, which acts as a packing material between the anterior chest wall and the great arteries that we can see here. And you can see the interface between the thymus and the lungs very well. We need to look at that. And of course, the other extravascular structure is the trachea. You can see the trachea here, but the three-vessel view is at a lower or a cordon level compared to the three-vessel trachea view. So in the three-vessel view, you can almost see the trachea breaking up into the carina. You can see one bronchus here, you can see another bronchus here. So SVC, aorta, pulmonary artery, and already the trachea has split into the two bronchi, right? So how do we go from the three-vessel view to the three-vessel trachea view? Again, a very, very subtle angulation. A little Keffelard angulation will fetch you the results. And once you begin to do this maneuver, it becomes ingrained. It becomes a part of your screening protocol. You don't have to, your brain no longer has to tell your hand to do it. Your hand takes over and from the three-vessel takes you into the three-vessel trachea. So this is the three-vessel trachea view, and we'll see more of this in the coming slides. Okay, so the three view is three vessels plus the trachea, goes without saying, but it's more interesting to know that this is also called the axial arch view or the transverse arch view. Axial is transverse. So how is it the transverse arch views? Because here, in contrast to the three-vessel view, where you actually saw the full ductus arch coming in. That's the main pulmonary artery. That's the ductus arch. This is the ductus arteriosus, descending aorta. The entire ductus arch was here. What is missing in the three-vessel view is the aortic arch. So it's only the ductus arch which comes in this plane. The aortic arch comes a little higher. So you need to go a little higher. And when you go a little higher, in addition to the three-vessel, you begin to see the three-vessel, the aortic arch as well. So the aortic arch missing here, the aortic arch comes up over here. And that is how you distinguish between the three-vessel view and the three-vessel trachea view, right? So therefore, why do we call it the transverse arch view? Because you have both the ductus arch as well as the entire length of the aortic arch. When you say I see the entire ductus arch, it means you're seeing the main pulmonary artery, you're seeing it proceeding as the ductus arch. It narrows down at a certain point of time. That's the ductus arteriosus, ultimately joins the descending aorta. So ductus arteriosus or the ductal arch is very well seen in the 3VT view. Similarly, the aortic arch tapers a little bit, becomes the aortic isthmus, and just before it reaches the descending thoracic aorta. So if you ask me what is the easiest way to see the ductus arteriosus and the aortic isthmus, and there are many, many clinical situations where you want to look at this, the answer is three-vessel trachea view, right? Remember, both the arches start a little differently, but both the arches are aiming at the same target. Both of them want to go towards and join the descending thoracic aorta, and that is why they converge. And when they converge, they form a V, right? The apex of the V or the convergence is always to the left of the spine, and that needs to be acknowledged, right? Now, here's some more information on the three-vessel trachea view. Just shown you a clip over here, and we realize that I'm panning between the three-vessel and the three-vessel trachea view. So therefore, what I want you to see is that the ductus arch is almost constant, but between the three-vessel and three-vessel trachea view, it's the cross-section and then it grows. Cross-section and then the aortic arch grows, literally grows. And that growth or that propagation of the aorta should be kept in mind. And I'll also come to the fact that both these arches oftentimes are not at the same level. They are at a little different levels. As in this case, we will look at this feature in another slide. And we need to know that this aorta grows. Also, the fact that the ductus arch starts anteriorly closer to the chest wall. The aortic arch starts a little posteriorly, further away from the chest wall. And this, of course, is the SVC. This is the trachea, which is actually splitting into the carina. You can see the two bronchi over here. At a lower level three-vessel, it becomes the bronchi are seen. When I come to the 3VT view, the bronchi actually are joining upwards to form the trachea. I hope that is clear. This is the descending thoracic aorta. And just before the descending thoracic aorta, that is the aortic isthmus. And this is the arterial duct that you have here, or the ductus arteriosus. I just want you to know that this growing effect of the aorta to complete the V, that is important to be recognized. We'll come to the checklist a little later on. And also the fact that the ductus arch is far away from the SVC. The aortic arch and the SVC are like twin sisters. They're all in each other. They want to be next to each other. Please bear that in mind as well. So this slide reminds us that there's also a third arch. And the third arch you can see both by grayscale and by color. Grayscale depends on the angle with which you're going, and color depends upon the PRF with which you're looking at the three-vessel trachea view. Now here's the grayscale view. That's the ductus arch. This is the aortic arch. This is the trachea. That's the esophagus. Remember, whenever you see the trachea, you see the echogenic esophagus behind it, and the trachea and the esophagus are one unit because they come from the foregut. They take their origin from the foregut together. They are both foregut structures embryologically. And this is the SVC. Just like you have the ductus and the aortic arches, you also have the azygous vein, which goes from its prevertebral location to the right of the descending aorta. It moves anteriorly, hooks over the right main bronchus, right hilum, the hilar structure of the right lung, and joins the superior vena cava. Remember, there are two arterial arches to the left of the trachea and the esophagus, and the one venous arch is to the right side. So the one venous arch to the right and the two arterial arches to the left should be taken cognizance of. On a day-to-day basis, we don't really bother to see this arch because we take it for granted, but we need to see it in certain situations, right? Now, in the color Doppler, of course, you begin to see is diametrically opposite to that in the arterial arches. The ductus, the aortic arch, ductus arch in blue flow away from the transducer in this apical approach, whereas in the azygous, you have the fetal, the blood is flowing from the azygous vein into the SVC, so it lights up in red. So that is extremely, extremely important to note. Now, this is just to tell us that the aortic arch and the ductus arch may not be in the same plane. Now here I will, you can see that when I see the ductus arch, I don't see the aortic arch. When I see the aortic arch, I don't see the ductus arch. Why does this happen? Because nature doesn't know that we are going to do echocardiography for every fetus. Otherwise, it would have done this. It just says, okay, you go to the descending aorta, you also go to the descending aorta. You can go a little higher, I will go a little lower. And it's normally the aorta which goes a little higher and the ductus arch which goes a little lower. As you can see here, I'll take you to the bookmarks. The first bookmark, you see the entire ductus arch beautifully. That's the ductus arteriosus there. And here, you see the aortic arch beautifully. That is the isthmus here. When I see the aortic arch, I don't see the pulmonary or the ductus arch. When I see the ductus arch, I don't see the aortic arch. And if I want to see both, I'll have to move a little down and angulate up, and you will learn to do it. You will always learn to do it. No problems, that can be done. But remember, don't be surprised that you don't get both arches at the same level. Another example showing you the same. Aortic arch seen, ductus arch not, ductus arch seen, aortic arch not, and you can go a little oblique and literally trap it, both of them in the same section. And again, look at the azygous vein. That is the azygous vein to the right of the trachea and the esophagus. And these are the two arterial arches to the left of the artery. Now, just like we have for the four-chamber view, you have an apical approach, you have a basal approach, you have a right lateral, left lateral approach. The same thing holds good for the three-vessel trachea view. And this, of course, is a traditional apical view. In the apical view, it is very good to do your Doppler because the flow is collinear. The flow is collinear, and you can do a very good Doppler. But remember, the interfaces are not that strong because you're going collinear to the grayscale. The interfaces don't come out so well, but the Doppler comes out very well. For me to measure, I need the interfaces. I need to look at where the wall stops and the lumen starts. And therefore, I'll always try to go a little onto the lateral side, a hybrid lateral or a pure lateral. And let us see how the right side up looks like. So that is a lateral with the right side up. And you will see that the separation between the aortic arch and the ductus arch comes out beautifully. Your measurement becomes more, your endpoints become more crisp. That is with the right side up. And when I do it with the left side up, again, the interfaces between the vessels light up, my measurements become very, very fine-tuned, and I'm very confident of my Z scores over here, right? So it's important to note that you have advantages in both apical as well as in the lateral approaches to the three-vessel trachea view. Let me stop these clips. And this is important to know as I play this clip. When I do a lift-up approach and I turn the color Doppler on, I find that the blood in the ductus arch is actually moving away from the transducer, whereas the blood in the aortic arch is moving up towards the transducer. So although my classical teaching is that both the arches should color in the same direction, that works well if you're in the apical approach. It doesn't work well when you're in the left side up approach. It also works well when you're right up. It works well here too. But when it's left up, you have a red occurring in the aortic arch and a blue occurring in the ductus arch, and that's perfectly normal. This is not ductus-filled reverse flow at all. This is normal, and you can sort this out by actually imagining the spatial orientation, the two limbs of the V vis-a-vis the direction of the Doppler ultrasound beam. Right? So what is the importance of three-vessel trachea view? Three-vessel trachea, three-vessel view is a screening test. You must do it for all fetuses that's passing under your care. You can't say, okay, if there's some indication only, I will do it. It's not a part of the advanced fetal echocardiography. It's a part of the basic extended fetal echocardiography. It's good for the outflow tract anomalies because you see both the ductus arch and the aortic arch, which represent the outflow tracts of the ventricles. And it perhaps is the only view where you find both great arteries in the same view. When you take your RVOT, you see only the pulmonary artery. When you take your LVOT, you see only your aorta. But which is the view which gives you both so that you can compare and contrast? The answer is three-vessel trachea view, a beautiful, elegant way of showing both the outflow tracts. And the beauty of it is no rotation, no skill needed. So your RVOT, LVOT, you have your rotation clockwise, 45 degrees, 90 degrees, so on and so forth. Dr. UP will take you through it later on. But for three-vessel trachea view, simple. You don't have to really worry. It's not cortical, let me say, it comes from your brainstem. It's that simple, right? And we know for sure that if you combine the four-chamber view and the three-vessel trachea view, it improves your detection rate for CHD enormously. But what I'm going to tell you now is the checklist, which is important. You might have the skill to do it, and you might have the will to do it. Yes, you've got the skill and the will. You have produced the three-vessel trachea view, three-vessel view on your monitors in every case. But it's important to run the features that you're going to look for in these views. So simple, it's just a sum total of what we've done, and quickly we'll go through it. The checklist is that from left to right, please recognize the ductus arch, pulmonary artery, aortic arch, aorta, SVC from left to right. No vessel missing. So three vessels are there. Your account should be right. It's three vessels and in the same order. And no extra vessel. And for that, you should just look at the left of the pulmonary artery. That will give you the exact place where to look for the extra vessel. Size-wise arrangement and compare the sizes. When you have two great arteries, it's excellent to compare the size. Please look at the size of the ductus arch pulmonary artery to the aortic arch aorta size, and you know for sure that normally the aorta should be slightly smaller than the pulmonary artery. Size-wise arrangement, compare. Measurement, if you find that there is a discrepancy, borderline, you're not able to decide, you can do a measurement in the three-vessel trachea view to document the size abnormality in terms of Z-scores or Z-scores. Linear arrangement, just imagine the straight line cutting through the anterior aspect. None of the vessels are breaking any rules as far as standing in a neat row. Always complete the V. the completion of the V occurs when you go from the three-vessel to the three-vessel trachea view. As I told you, the aorta propagates, it grows and gives you that extra limb completing your V. And always look at the apex of the V and recognize it to be the left of the spine, and never forget to turn the color on, just like you do color for your four-chamber view, color for your LVOT, color for your RVOT, color for your three-vessel trachea view is important. Both the aorta arterial arches, same direction of coding, and no aliasing to be seen either in the aorta nor neither in the aorta nor in the pulmonary artery. Recognize the extra vascular structures in terms of the trachea. I have missed out the trachea here, in terms of the trachea and the lung and the thymus, because unless you do recognize and pinpoint that this is the trachea, you will not be able to say that it is the left-sided relationship of the aortic and the ductus arches to the trachea. So that word trachea is extremely important. I will add it soon after this lecture gets over. And no other structure, especially in terms of a cystic structure, should be seen in this particular view. These are examples of Z-scores. You can see that there is a discrepancy here between the pulmonary artery and the aorta. That's the SVC. This is the trachea. Aorta looks half of the pulmonary artery, and therefore I'm going to quantify it, and that is how you quantify it. And note, I have not used an apical three-vessel view or three-vessel trachea view. I've used a lateral view. Okay, now we'll come on to the abnormalities in the three-vessel trachea view. We will look at abnormalities of size, number, spatial relationships, incomplete form of the arches, Doppler abnormalities, AOP, a connection, miscellaneous, non-CVS lesions, non-cardiovascular lesions. And for this, I have done an interesting way of looking at it. I'm going to do the reverse care. So for the sake of this lecture, we are taking the reverse care. This doesn't happen in practice. Nobody ever does the three-vessel trachea view first and then comes to the four-chamber view and then goes to the abdomen. No. My idea is not to take you backwards in your scanning. Your scanning is right. You start from the upper abdomen, move to the four-chamber, move to the 3V, 3VT. Yes, there's no changes in that. But to make the discussion more interesting, I'm going to take you first to the three-vessel trachea view and then make you anticipate what you would find in the other views which you would already have done in practice. So let's look at caliber. The normal is main pulmonary artery is greater than aorta, greater than SVC. But what are the abnormal situations? You can have an aorta small or an aorta large. You can have an MPA small or an MPA large. And you can also have an SVC which is large. So what we will do is to look at all these situations in terms of case examples, and also realize that there are combinations. There are combinations which can occur. For example, in coarctation of aorta, it's not only the aorta which is becoming small, it is also a compensatory dilatation. The hemodynamics is like that. It robs the aorta, gives the pulmonary artery. So both ways the swing occurs, and that is how your eyes are able to perceive the chamber disproportion as also the great artery disproportion. So we'll see a few of these examples. And the first example, of course, is all a favorite example. Here is a 27-weeker, and this is a three-vessel trachea view. You know that, yes, this is the trachea. Always orient with the spine. Spine is extremely important for any cardiac view. But in the three-vessel trachea view, when you're asked to interpret, look at the spine, get your bearing first. And then, because it's a three-vessel trachea view discussion, look for the trachea as well. Look at the esophagus. That is the trachea and the esophagus that you can see here. And now you will agree with this is, of course, the left side. This is the right side. You see the SVC here. This is the aorta. This is the ductus. Aorta is smaller than the ductus. Definitely, it's a lot smaller. And the other thing I would recommend is when you find the aorta is smaller and you've benchmarked it with the pulmonary artery, my suggestion is that you can also benchmark it with the SVC. The normal aorta should be a lot larger than the SVC. And here you realize that the aorta is almost equal to the SVC. But what is more interesting is that there is something to the left of the ductus arch. So there's an extra vessel here. So not only this has broken two rules. The first rule is the size of the aorta looks small, both vis-a-vis comparison of both its neighbors. And of course, there's an extra vessel. So we are going to do a color Doppler, and color Doppler shows me the flow in the same direction. The smallness of the aorta is brought out again, and that is the trachea and the esophagus not filling with color. This is the RSVC and also the LSVC, again not filling with color. Why? Not because they are thrombosed, because I have done this with an arterial setting. You want to fill these two up, you'll have to go to a venous setting. And when you do a venous setting, your arterial arches will overbleed, will never limit themselves to the lumen. So we know that we are wanting to look at the aortic arches, and this is the setting which is important for us, right? So therefore, the question is, the aorta is smaller. Now, we'll have to introspect. If I were to show you the four-chamber view here, which chamber is going to be smaller? Yes, because the aorta is smaller. The LV ought to be smaller. And this is the four-chamber chamber view showing you a diminutiveness or smallness of the left chamber compared to the right chamber. And also, there's another clue here. There is a bleb in the left atrioventricular groove, and that is a dilated coronary sinus, telling me that that extra vessel I saw there indeed is the left SVC, and that is why the coronary sinus is dilated. And definitely, whenever I see all this happening, my worry is about coarctation of aorta. So I need to do the sagittal arch view. We will see more of this later on. And in the sagittal arch view, you find that the ascending aorta, descending aorta, good caliber, arch of the aorta, good caliber. But when I come to the isthmus, narrow. The isthmus is narrow, and you will see a slight shelving which is occurring over here, and that is due to the mismatch in the size or the caliber of the isthmus to the descending aorta. And what's happening here is the ductus arteriosus trying to join the descending aorta. So always never mistake a ductus arch for the aortic arch, and your check point is the arterial arches, the neck arteries coming out over here, and the fact that the aortic arch starts from the mid-chest. We'll come to that a little later when I do the sagittal arches, right? So that's a classical isthmic narrowing. But remember, a sagittal arch is much more technically demanding, but a much less technically demanding is the three-vessel trachea view. And in this particular case, you will find that that is the aorta, that is the aortic isthmus, very, very narrow. That is the aorta, that is the aortic isthmus, very, very narrow, as supported by your z-scores of -3.14 that you can see here. So that is a classical coarctation of aorta where you had two clues. One was the size and the other one was an extra vessel. We don't know for what reason. The left SVC and coarctation often come together. They are strange bedfellows. We have not been able to crack that mystery. So therefore, if there's a left SVC, be critical, rule out, be more sensitive to the possibility of a lurking coarctation of aorta. Right? And now we go on to this. Here again, you can see that that is the ductus arch, left side. This is the spine. You can see the trachea here. Trachea is highlighted by the echogenic margins. I forgot to tell you this. In the anatomy slide itself, the trachea has echogenic walls. whereas none of the vessels have echogenic thick walls like the trachea. Very important to know that. That will help you to identify the trachea. And you have the two left-sided arches, but you'll find that the aortic arch is again very, very small. But in contrast to the previous case, when I turn the color Doppler on, in the previous case, the aorta had blue, whereas here it is red. So this is apical in approach. This should have been blue, but in red. So I know that the aorta is getting filled through the ductus arteriosus. It's coming into the isthmus and filling the aortic arch. And that can happen only if there's an aortic atresia or a very severe stenosis. And therefore, what am I going to expect or foresee in the four-chamber view is a hypoplastic left heart. And of course, needless to say, you have a very small left ventricle, that's the spine, a non-contractile left ventricle, a mitral valve which is not opening and closing, a compensatorily dilated right-sided chambers that you can see here, and a classical right ventricle taking over the apex of the heart, the entire gamut of the hypoplastic left heart syndrome. And note the foramen ovale flap is now opening into the right atrium. So where did we start? We started with a smaller aorta, went on to say that there's reverse flow, and went on to reason that yes, it should be a hypoplastic left heart, and proven it by doing the aorta, right? Doing the four-chamber view. And when you turn the color Doppler on, there is no forward flow in the aorta. This is the LVOT. No forward flow, a very, very thin calibered LVOT that you can see here, telling you that the aorta is atretic. Now let's look at the opposite end of the spectrum. Now here is a three-vessel trachea view. That's the right side, SVC, aorta, ductus. Now you compare the aorta to the ductus arch or the pulmonary artery. You will agree with me for sure that the pulmonary artery is definitely smaller in caliber than the aorta. Turn your color Doppler on, you find normal flow forward. My normal flow forward in the pulmonary artery. Now, how does your thinking go? The pulmonary artery is small, the aorta is good sized. You're going to say the pulmonary artery is small, and therefore you're going to expect a reverse flow in your three-vessel trachea view with color, but you find that there's a forward flow, not only in the pulmonary artery and the ductus arch, but also in the aorta. So therefore, you know that you're going to expect something happening in the right side of the heart, not in the left side, just like you expected left side in the other two cases. Right side here, you go to your four-chamber view, you have a classical right. This is the spine to orient yourself. A right ventricle, which is small, a tricuspid, which is not opening and closing, and a compensatorily large left ventricle out over here. And this is a tricuspid atresia. And as this clip actually pans out, notice the ventricular septal defect. And it's thanks to this ventricular septal defect that in spite of the tricuspid atresia, you have a fairly well-maintained forward flow occurring in a pulmonary artery, which is patent, but nevertheless, which is a little smaller in caliber. So a tricuspid atresia. Again, let us look at this particular four-chamber three-vessel trachea view. This is the left side, this is the right side. And definitely from a mile away, this is the ductus arch, pulmonary artery, much smaller compared to the aorta. From a mile away, even if you don't want to see it, your eyes should see it, because you're going to go through the checklist after you get your three-vessel trachea view. Turn your Doppler on. In contrast to the previous case, instead of forward flow, you have a reverse flow. So pulmonary atresia. And therefore, what will you look for in the three-vessel, in the four-chamber view? Instead of a left-sided chamber, which is small, you will seek out a left-sided chamber, a right-sided chamber, which is small. And let me stop this clip. And take you over here. and that is the classical right chamber, which is small. The left ventricle is contracting well, the right ventricle is not contracting well, and the limited excursions of the tricuspid valve. And you can also see that the whole thing is dyskinetic. The ventricle is just bobbing up and down. When you turn the color Doppler on, you have a dramatic forward, backward, backward in terms of a to and fro flow across the tricuspid valve, telling you that there is a bit of flow going into the right ventricle, but the entire flow is coming out as tricuspid regurgitation because blood cannot pass through the pulmonary artery. Pulmonary artery is atretic, and that is why you find a reverse flow in the ductus arch, right? So these are size discrepancies that you can see here. Now here is a case which can go beyond what we have seen, and let me show you this. Here is the left side and the right side. You have a ductus arch here, you have an aortic arch here. Now my eyes tell me that yes, the ductus arch looks a little smaller than the aortic arch, so it's picked up the difference. Full marks to that. But what I'm unable to say is whether the ductus arch is abnormally small or whether the aortic arch is abnormally large, which is culprit vessel. And for that, my other views are important. How do I correlate? I'll stop this, go to the four-chamber view. Four-chamber view not helpful at all, because the chambers are equal, the valves are opening and closing, so I take the help of Doppler. Now I turn the Doppler on, and in the Doppler, I see a dramatic mitral regurgitation over here. A mitral regurgitation means, what will you say now? It's a left-sided lesion here. So will you call the ductus abnormally small or the aorta abnormally large? Aorta is the left-sided structure. So therefore, the needle of suspicion will go to the aorta, and I will say that the aorta is abnormally large. And what view will give you the answer? LVOT. And look at the LVOT here. You have a very narrow aortic root, aortic valve, which is seen throughout the cycle, and a classical flaring, post-stenotic flaring. This is a valvular aortic stenosis, and your aortic caliber increase is due to the post-stenotic flaring, right? But you have already clues saying that this is a left-sided abnormality rather than a right-sided abnormality, and you can quantify using your Z scores. So that is for the caliber of the vessels. That's for the caliber of the vessels. Then we go on to the number of vessels, and in the number of vessels, you have 2 vessels, normally abnormally seen instead of 3 vessels. And there you can only have aorta, pulmonary artery not seen, pulmonary artery seen, aorta not seen. We'll look at both. Now here what is happening is you find in the 3-vessel view, you find a classical single vessel, and let me take you through that vessel. Yes. Why is this the right view? Because you see the trachea here. You see the SVC here. You don't see the pulmonary artery. You see a vessel which is abnormally long. Now, there are 2-3 things I want you to see in this 3-vessel view. If this is the SVC, and this vessel is hugging SVC like its twin sister, so you expect this to be aorta. But the aorta should have come from the mid-chest. It's coming right from anterior. You can see that aorta is coming right from anterior. So that should get your antennae up. And why is the pulmonary artery not seen here? Because a pulmonary artery is at a caudal plane. I will take you to the caudal plane. That is the caudal plane, and that is the pulmonary artery with its bifurcation. And when I see this, the aorta is not seen. So this is clearly not that anatomical little up, little down situation. This is an upper story. The pulmonary artery and the vein in the same floor, a little higher, a mezzanine floor kind of a thing, but they are not, they should not be on different floors. Here, clearly, they are on different floors. When you go your up and down, you don't see the trachea at all. You're down here. When I go up, you see the aorta. So straight away, I know for sure that the aorta is become long, aortic arch is unduly long coming from the anterior chamber, which is the right ventricle, and the pulmonary artery, which should have come from anterior, is coming from the posterior chamber. You can see that here, right? So therefore, that's one on top of the other, and this is, and also you see that the aortic origin is anterior to the pulmonary artery origin. Remember, this is the chest wall, this is the spine, this is the pulmonary valve, this is the aortic valve. Aortic valve is closer to the anterior chest wall, anterior to the pulmonary artery, and the aorta is to the right of the pulmonary artery. So this is DTGA, and when you do your arches, you will definitely show that the aortic arch is cephalad, and the pulmonary arch and the ductus arteriosus, this is the descending aorta, is caudad. You know that this is the aortic arch. Why? Because the neck artery is coming from this arch, telling you that this is CTGA. So again, even before going to the arches, you will realize if you critically look at the three-vessel trachea view, almost the entire information is hidden in this view. You have to crack it, open it, and bring out these nuggets of information, giving you almost the entire diagnosis in the three-vessel trachea view. And a little bit of sweeping will tell you the entire story. The treachery in CTGA is that the four-chamber view looks innocuously normal. There are no clues at all in the four-chamber view, and that's extremely, extremely important to know, in contrast with the next lesion that we're going to see. And here, of course, again, let us go retrograde or reverse gear, and I'm showing you the three-vessel trachea view. And to do that, I will take you to the bookmarks to cut a long story short. That is a caudal plane. This is the right side. So I see the SVC here. This is the SVC. Now, one thing I'm going to ask you is, there is always a vessel next to the SVC close to it, and normally we recognize that to be the aorta. The aorta never branches in the axial direction. But what you're seeing here, instead of the aorta, you have the pulmonary artery. Why is it the pulmonary artery? Because it's branching. You can see the right branch going into the right lung. Let me play the clip for you. You will realize this, right? So therefore, here you have the, you'll have to give me a little time. Cancel. I'll share the screen again. Just give me a minute, please. Just give me a minute. Again, seen or not seen? Hello,
Yeah, it's okay. It's okay, sir. Good, go ahead.
Okay, fine. Okay, so you can actually look at it. That is the SVC. And this is the next vessel. Let us call it X, the arch, X arch. I don't know whether it is a pulmonary ductus arch or it's an aortic arch. But what helps me is I see the bifurcation here. So this is a pulmonary artery. And remember, there's only one condition where the pulmonary artery becomes the friendly neighbor to the aorta, to the SVC. It occupies the position which the aorta occupies, and that is the CCTGA, or the corrected transposition. So you see the pulmonary artery, which now has taken the position of the aorta, pushing the aorta to the position of the ductus arch. You will see the ductus, the aortic arch out over here, and you will also recognize that the aortic arch is now to the left of the aortic, of the pulmonary arch. Always when you talk of great arterial relationship, it's always the aorta to the pulmonary artery which is described, never the pulmonary artery to the aorta. So always describe the aortic relationship to the pulmonary artery, and you will realize that the aortic arch is to the left of the pulmonary artery, left of the pulmonary artery. I'll take you to the aortic arch. That is the aortic arch to the left of the pulmonary artery, and therefore this is an LTGA, which is a CCTGA. This is your trachea, and also see, although this is the aorta, in the three-vessel trachea view, the aorta is far away from the SVC. Classical, we saw a I sign in CTGA where the aorta is long and it's close to the SVC, only two vessels. Whereas in CCTGA, again only two vessels, but the aorta is far away from the SVC. Why? Because this space is occupied by the ductus arch. You can see that that space is taken up by the ductus arch. Classical. And of course, in CCTGA, you have the writing on the wall is very, very clear. You find that the left-sided ventricle is the morphological right ventricle. You can see the moderator band and the tricuspid valve, and the right-sided ventricular chamber is the morphological left ventricle, right? So that's a CCTGA and a CTGA, where we found only one vessel in the three-vessel trachea view, and we also learned how the difference occurs in terms of the spatial relationship of the aortic arch to the pulmonary arch as well as to the SVC. Right? This is a CAT, again a common arterial trunk, showing you the SVC and only one great vessel over here, and the answer comes to you from the not from the four-chamber view. Four-chamber view is normal except for an axis rotation, but from the LVOT. When I do the LVOT in this case, you find that there's a mole-aligned VSD. There is a huge outflow tract which is getting out. That's the truncal valve, and I call this the truncal valve because I notice the pulmonary artery coming out of the common arterial trunk. So this is the common arterial trunk, and simply because there is no other, once the pulmonary artery is given out over here, the rest of the trunk continues as the aortic arch. And in the three-vessel trachea view, you only see this aortic arch, and the pulmonary artery is again under, it's in a ground floor, whereas the aorta is in the upper floor, as you can see in the LVOT view, and that is why only one single vessel here. Again, another condition where you have a single large vessel. Single large vessel. There are two conditions. Single large vessel. The two conditions are a CAT and a PAVSD. Now let's crack this one. You have a large outflow tract. You have this as the right-sided structure SVC. So this is close to the SVC. So I'm going to think of it as the aorta, but the aorta is coming a little anteriorly. We will explain why that's happening. But what about the color Doppler? color Doppler shows me an interesting thing. Shows me a forward flow in the, but there's also a small vessel which is coming when I go in red that I can see here, which I cannot see here. Very, very important. A lot of times color Doppler tells you the presence of a small artery which is not seen on the grayscale, but brought to light by the color Doppler, right? So you know that there's a thinner vessel which is seen, which is showing you a color Doppler reversal, ductus dependent. If you have called this, the big vessel, as the aorta, the smaller vessel has to be the pulmonary artery. Now let's look at what the four-chamber view has to show us. The four-chamber view is normal. The four-chamber view is normal. Just like in the CAT, the four-chamber view, except for axis rotation, was normal. Here also the four-chamber view is normal, but your answer comes from the LVOT. Again, a single large vessel, a mall alignment VSD that you can see here. And when you do your arch view without color, with color, simultaneous display, this is the aortic arch, right? Why is it the aortic arch? The neck artery is coming from here. So I know this is the aortic arch, but you will see the second vessel, the pulmonary artery, is now getting reversed filled and it's stuck under the arch. So ground floor, first floor or ground floor, first floor or ground floor, they are different at different levels. So we saw two lesions of CAT, VSD, both having mall-aligned VSD, both having great single large outflow tracts, both having essentially normal different features when you come to the outflow tracts. So this is a PA VSD, and of course, this is the classical reverse fill of the pulmonary artery. Why is the four-chamber view normal? Because of equalization of pressures, because of the VSD. If the VSD were not to be there, it would have become PAIVS, which we saw earlier on as a case in caliber difference. Now let's look at this particular case, which is again a PAIVS. Okay, I brought it in here again. Three-vessel trachea view. You have a ghost. You can see the three vessels. One of the vessels is really small. The other vessel is good. That is the aorta showing me the forward flow. Pulmonary artery showing me a reversed flow. And that is again showing a reversed flow here. But the difference here is that when I do a four-chamber view, the right ventricle is small. Interventricular septum is intact, and then there's a holosystolic tricuspid regurgitation that you can see here, all telling me that this is PAIVS. In a PAIVS, the interventricular septum is intact, and hence there's no equalization of pressures, and therefore you have, just like hypoplastic left heart syndrome, this becomes the corresponding hypoplastic right heart syndrome. So from two vessels alone, remember in two cases, CTGA and CTGA, the two vessels were not seen at all because they were upper floor, ground floor. And in the other one, where we saw two examples of a CAT as well as a PAVST as well as a PAIVS, simply because the other vessel was small and it was reversed filling, you couldn't see that vessel very well in the same plane, but at a small inferior plane, you saw it. So these are the two major groups of anomalies in the case study where there are only two vessels seen, one aortic arch is missing, SVC with the aorta, SVC with the pulmonary artery alone. We'll move to the other end of the spectrum, four vessels, and here, luckily, we have only two lesions, anomalous pulmonary venous drainage as well as persistent left SVC. And for this, we need to understand that in the checklist, we need to look for the extra vessel to the left of the ductus arch. Always tarry, consciously say, okay, there's nothing there I've seen. That is the way we program our minds to do it, right? And for this, what I'm going to do is to take a parallel approach. I'm not going to show you one case of LSVC, one case of supracardiac, but I'm going to split longitudinally, show you the differences between persistent LSVC versus vertical vein in supracardiac TAPVC at section to section would be innovative. So let's look at the hard facts. The hard facts are, yes, this is common. Isolated persistent LSVC is common. You can see the incidence over here, but also associated with CHD, in which case it's non-isolated. But as isolated, it's really, really common. Whereas vertical vein in supracardiac total anomalous pulmonary venous drainage is rare. It occurs as an isolated finding, or it can be as a part of right atrial isomerism. Either way, it is rare. This is 0.5% of the population. Here it's 0.5 per 10,000. It's 0.5 per 100. This is 0.5 per 10,000. Look at the quantum difference incidence. The persistent left SVC drains inferiorly into the coronary sinus, whereas the vertical vein in supracardiac TAPVC drains superiorly into the brachiocephalic vein. When the LSVC is isolated, it has no significance, whereas if it's a vertical vein, it means you have to operate this child, postnatal surgery, and if you've recognized it prenatally, the outcome of the entire surgical management or entire management is very good. So therefore, you have radical differences from one versus other, which implies or which tells us that you need to have your identity. You need to know whether you're dealing with the commoner LSVC or the rarer vertical vein, and we have now the visuals. Now I've chosen two cases, and I'm going to play both the clips. This is 3-vessel trachea view, 3-vessel trachea view, and in both these you have the 4th vessel. You can see to the left of the ductus arch, extra vessel, left of the ductus arch, left of the ductus arch. This is the extra vessel. This is left up. This is right up. So the extra vessel is here, right? And the extra vessel is there. Don't get confused. I'm giving you the sides and I'm giving you the spine. The moral of the story is that if you were to show me only 4 vessels in the 3-vessel trachea view and ask me to diagnose and say whether it is a LSVC or whether it's a vertical vein in TAPVC, I would say it's not possible. No, I need further views. So let's go to the further views. Okay. The first view I'm going to show you is the 4-chamber view. 4-chamber view in the persistent LSVC shows you signs of dilated coronary sinus. You see the dilated coronary sinus there and the bleb which I spoke of over here. Here, instead of the sinus, I see something else. I see that the distance between the left atrium and the descending aorta is increased. Remember, the distance between the LA and the aorta is hardly 2 millimeters or less. Look at here. This is the LA is actually touching the aorta, right? Whereas here it's a mile away, it's far off. And in that space, when I should see nothing, APTH, there's no other vessel behind the heart except the descending aorta. And if you're using a good machine, high resolution probes, you will see a right-sided azygous vein, a normal right-sided azygous vein. But here you have a extra structure, and that is the horizontal collector or the twig sign that you can see. And once I have these findings, I now know that the extra vessel I saw in the 4-chamber view in here in this case is LSVC. Here in this case, it's TAPVC. Now you go up. The LSV, the 4-chamber view, the 3-vessel trachea view itself is not going to be more helpful. So you go beyond. You go up, and what are you looking for? When you go beyond the 3-vessel view, you go to the level of the left brachiocephalic vein, LBCV, left brachiocephalic vein. And when I do that, I find I'm going up. You can realize that there are 4 vessels. From 3 vessel trachea view, I'm going up. And when I go up, there is no evidence of a left brachiocephalic vein, which should be seen as an arch across the thymus, right? There's nothing, not at all. Whereas here, I see that's the 3 vessel, and then I go up. That's the 3 vessel, I go up. You find not only the presence of left brachiocephalic vein, the left brachiocephalic vein is dilated also. So the left brachiocephalic vein absent in LSVC, whereas in left brachiocephalic vein is not only present, it's dilated in the vertical vein. Look at the differences. So that is important. Now, the other important thing I just wanted to show you is in the same picture is the fact that in the 3 vessel trachea view, let me get the 3 vessel trachea view. I want you to see the relationship of the left SVC to the aorta. I said that the left SVC should be touching the aorta. Is it touching the aorta here? No, it is far away, a little far away. Whereas here it is touching the aorta. You can see the aortic arch, it's touching. Here it's not touching. Why is it not touching? Because the left brachiocephalic vein is absent and the SVC moves away. It diverges. And that divergence you can see beautifully over here. The LSVC and the RSVC are diverging, whereas here it doesn't happen. So that is the value of the 3 vessel trachea view. And lastly, you will see when you do a sagittal view, the persistent left SVC goes all the way down to the level of the diaphragm and drains into the coronary sinus, the classical cobra head sign. I call it the cobra head, not the cigar pipe. For me, it resembles a sign with the cobra hood above. Whereas here, you will see that the TAPVC vertical vein stops at the lung hilum. It doesn't go down to the diaphragm. And when I turn the color Doppler on, you find a hepatopetal flow here, whereas a hepatofugal flow over here. And that is the way you differentiate between the LSVC and the vertical vein. Oh, I've got here, you can see another slide showing you the position of the aorta. We finished, and you can take a screenshot of this, summarizing the differences between the LSVC and vertical vein in supracardiac TAPVC, right? So there is a pitfall here, and the pitfall is you might look at the left atrium sometimes, which can sneak into the 3 vessel view. It doesn't sneak into the 3 vessel trachea view, but it can come into the 3 vessel view. Don't consider that as an extra. Your 3 vessel trachea view is important. You might get the left atrium, which comes in there, but it will never reach up to the 3 vessel trachea view. So that is important to understand. So missing arches. Now here is the entire ductus arch, but the aortic arch should have reached here to form the V. The aortic arch is missing. On the other hand, you have another situation where you have the entire aortic arch which is present. This is the SVC, but a part of the ductus arch is missing. What is missing here, in effect, is the isthmus. And what is missing here is the ductus arteriosus. And let us look at cases. And this is where real-time sweep and that aorta growing or propagating towards the descending aorta is important. Okay, so I'll just take off the full screen for a little time, and then I'll take you through this. And I want you to very carefully look at the ductus arch. The ductus arch is going through the ductus arteriosus and communicating with the descending aorta. But I want you to very carefully look at the ascending aorta and the so-called aortic arch. It is not meeting with the ductus arch, but it's going up and dividing into the neck. Very, very important. So you have one limb which is very well seen, the other limb is missing, and that is the way you diagnose an interrupted aortic arch. And once you also recognize that the aorta is narrow compared to the ductus arch or the pulmonary artery, and putting one and one together, you have made a diagnosis of an interrupted aortic arch. You take your arch view, you find that the ascending aorta is narrow, and instead of bending to form a graceful aortic arch, it goes straight and aims at the fetal neck, divides into the neck arteries. So, interrupted aortic arch. And then we move on to the opposite end of the spectrum, and the opposite end of the spectrum is ductus agenesis. And here I've chosen to show you a tetralogy of Fallot. You find that this is the spine, that is a big vessel overriding. This is a small vessel, the crossover is present and bifurcating. So this is the aorta overriding and big. This is the smaller pulmonary artery which is dividing. Okay, which is dividing. So this is Fallot's tetralogy. Agreed. This is a trachea. The aortic arch is complete, but is the ductus arch seen is the question. The ductus arch oftentimes is abnormal in TOF. It can be tortuous, it can be hidden under the aorta, it can be absent. And that is a classical ductus arteriosus absence that you have seen or recognized in TOF. Spatial orientation, I'll go a little fast because I have another half an hour left and I want to use it for the arches, right? So we'll go to the spatial orientation and amongst the three vessels in relation to the trachea and in relation to the anterior chest wall. Now, here is a case where I cannot draw a straight line anterior to the pulmonary, aorta, and the SVC. Let me play this clip to you and let me see that. This is the pulmonary artery. You can see it bifurcating. Left side, aorta, SVC, but I should be able to draw a straight line. I'm not able to draw a straight line. Why? Because the aorta is big and it's broken the rule. It's gone anteriorly. So I have to draw one line and another line. And this is classically the signature of TOF in the three-vessel trachea view. Why has the aorta gone anterior? Because it is shifted anterior to override the ventricular septum, and that is why you have a malaligned ventricular septum. That is the coronal septum has gone anteriorly, apportioning more space to the aorta and taking it anteriorly, eating away on the space of the pulmonary artery, making it small, and that is how you have all the components of the tetralogy of Fallot. And here are the other views showing you the overriding of the aorta and showing you a very narrow pulmonary artery, which is bifurcating, of course, very well seen here. Abnormality in space orientation between the two arches. In relation to the trachea is important, and quickly we'll go through. Now here is the V is seen, but the V is not going to the left of the spine. It is going to the right of the spine. The right of the spine. This is a V shape or V type of. This is a V type of. Look at that. That's a V type of right aortic arch. That means the aortic arch and the ductus arch both are going to the right side. Both are going to the right side. You will see that that's the four-chamber view, which is normal, and this is the mirror image branching that you can see here. On the other hand, here is another three-vessel trachea view. That's the left. This is the right side. On the left side, the ductus arch. This is the trachea. Always recognize the trachea, echogenic border. The ductus arch is left-sided, but the aortic arch is right-sided. And there's a U-shaped communication out over here. That's the esophagus. And that's a loose vascular ring around the trachea and the esophagus. That is a left ductus arch, right aortic arch, U type, in contrast to what we saw, which was V type. Now, a close mimic of the U type is this. You will see the U again here. You will think of it as a U type of right aortic arch. But when you do your color Doppler, you have a nasty surprise here. You find that the aorta is sending out another branch here. Aorta has no business to do it. So this is double aortic arch. Very, very easily missed. And thanks to the color Doppler, when you come and revisit your three-vessel trachea view on black and white, you find the vessel here. So this is a double aortic arch. And let me take you to the bookmark. The bookmark 1. You will see the aortic bifurcation here. Right. This is the ductus arch, aortic arch. Aorta breaks into two, a right-sided bigger component and a left-sided smaller component. And you will see that the trachea and the esophagus is now encircled by a tight arch. And this baby will need release. It will have stridor. It will have problems in swallowing, in contrast to the other one, which is a loose ring where only 5% of them present with symptoms postnatally. This is a tight arch. Spatial orientation too close to the thymus. You can see that there is hardly any thymus. And on color, you will see that the three vessels are very, very close to the anterior chest wall. When I do the ductus arch is extremely close to the anterior chest wall. In this case of Fallot's tetralogy, this is a PAVSD that you can see here with the right aortic arch. And you will also see the other tetralogy of Fallot with the ductus arteriosus agenesis I showed you also was the right aortic arch. So the thymus is not forthcoming. There's no separation here. And therefore, I'm worried about 22q deletion in this particular case, right? So the thymic thoracic ratio, we can read up a few miscellaneous. One of these is a communication between the ductus arch and the aorta. Communicating very, very well. You can see the communication extremely well when I magnify, and that's an aortopulmonary window. Here is a very suboptimal view, very tough patient to do a scan. I can see the three-vessel view, but when I turn the color Doppler on, there is mayhem happening in the ductus arch over here. There's so much of mosaicism, there's so much of turbulence here, aliasing happening over here. And therefore, I know that there is a pathological narrowing of the pulmonary artery, which I would have missed if I had not turned the color Doppler on. And when I do a ductus arch view, you find a classical steno regurgitative lesion. You have pulmonary regurgitation in diastole, and in systole, you have a liaising and a turbulence, a mosaic display telling you that there's turbulence and sky-high velocities. So valvular pulmonary stenosis, thanks to the three-vessel view with Doppler. Three-vessel view without Doppler, nothing much. You might not have picked up the thickened valves over here. It's very poor imaging thanks to the BMI of the patient. And that is a classical pulmonary stenosis. Here is a three-vessel view that you can see. Three-vessel view, we know, has to have only one or unidirectional flow. And here it has bidirectional flow. You can see a red, blue, red, red, blue, red, red, blue, red, which is a polyvalvular dysplasia. And here is the use of aortic isthmus in a later case of early onset IUGR. Here is use of Doppler straddling the SVC and aorta in sorting out arrhythmias. Here is a tortuous, we were talking of tortuous ductus arteriosus, both Dr. UP Singh as well as Dr. Prashant before I started. And this is a classical case. You will see here that this is a ductus arteriosus, which is dilated. Nothing to worry. This is a third trimester occurrence. I'm not going to be really worried. You see the aortic arch coming up very well on the left side, but the ductus arch, the ductus arteriosus is really, you can see that. Yeah, this Prashant said there's C-type and S-type, and this I think will be the S-type, right? So that is normal, nothing to worry in the third trimester. So the ductus can narrow when you give indomethacin. Here is polyhydramnios, indomethacin tried out. And classically, you have the pulmonary artery, the ductus arch, narrowing of the ductus arch, and you have to follow it up on a twice weekly or weekly basis to say that, yes, it's only narrowing, there's no reverse flow all happening. Very, very important. And of course, here is an extra cyst that you can see just posterior to the trachea. And when I do an orthogonal, I find that this is a dilated esophagus. Just behind the trachea is the key. Just behind the trachea, this whole thing is dilated. This is the descending aorta. That's the spine. This is the whole esophagus, which is dilated in this case of pyloric atresia in Carnison. Conclusion, three-vessel trachea view is one of the planes in the extended basic examination. Three-vessel trachea view and three-vessel trachea view enable us to compare the aorta, the main pulmonary artery, and the SVC. Abnormality is correlated with four-chamber and other views. Some situations, four-chamber view is normal, and examples are CTGA, TOF, and common arterial trunk. Size, number, orientation, intact V, etc. should be studied. Always correlate with the right and the left side. You should have done your situs first. Color Doppler in all studies, very important, and many lesions are detected. Many lesions that we detect are gonotroncal abnormalities and have a direct bearing on 22q11 deletion. And even if you've missed something in the four-chamber view, oftentimes you rescue the diagnosis by a three-vessel trachea view. A classical example is you have missed picking up the right-sided, left-sided discrepancy in a coarctation of aorta. But when you come to the three-vessel trachea view, certainly the great arterial discrepancy will actually pull your attention towards it. So thank you very, very much for a very patient listening. I'll stop sharing now and I'll take you through the other lecture. Just give me a minute. I'll have to open that as well. Okay. Dr. UP, am I sharing? Is my slide sharing effective? Oh, no, I have not.
Very good. In fact, people are scolding us that why don't you allow Dr. Ramamurthi? Why should he wind up? He should continue.
No, I'm not. I'm continuing. You've given me time till 1:30 and I have 18 minutes more.
No, you carry on. You're perfect. I think your other end is tied. We are okay.
I just hope my presentation was understandable.
Absolutely, as usual.
Thank you. Thank you very much indeed. Thank you.
Go ahead, sir. Go ahead.
So we now move on to sagittal arches, and this is something which I made. The normal I made over the last 3 days because I had to import clips from the machines and from the machine in the office and put it into the presentation. But the abnormals, I had to, last night I did a little bit of a work on it. I just hope it comes off well, right? Now, we need to realize what is a sagittal arch. What is a sagittal arch? We all know that if you use, this is the end-on of the probe, as I see the edge of the probe, whereas this is end face of the probe. End face of the probe, end-on of the probe. I hope my hands are doing the trick. I've tried to show you the side view of the end-on of the probe here, and I'm showing you the en face of the probe here. So when I do an end-on, that means the probe, the beam is cutting axial. But we know that the arches are vertically oriented. Both the ductus arch as well as the aortic arch are vertical arches, isn't it? So when I do an axial, I cannot see the arch in its full glory. I need to see, why is an arch called an arch? Because it has two pillars and an arch, right? So I need to see the two pillars and the arch. And for that, the only way I can do it is to rotate this probe 90 degrees. I am axial, I have to be sagittal. And from axial to sagittal is 90 degrees. That's it. So if you learn this spatial exercise of rotating 90 degrees, bringing the end on to the end face, as you see from the side, you will cut the fetal anatomy in a sagittal section. So what is your end? What are your points of beginning and stopping? So that is your beginning. You're beginning in an axial section, that is that is the 4-chamber view. Whereas you have to stop when you get a arch view. And I have shown you a ductus arch. Why have I shown you a ductus arch here? I've simply shown you a ductus arch here because just like the midline of the brain gives rise to the picture of the cave of the corpus callosum, a midsection of the chest gives you a ductus arch. Remember, the ductus arch is the corpus callosum of the heart, right? If you do this, corpus callosum. If you do this, it is ductus, right? So that's the ductal arch. We'll come to the anatomy. So how do you go from here? Here is the question. I have given you the gist of the rotation from an axial to a sagittal. And now I will show you what does it mean when you look at the probe movement. And here is, I'm starting with axial. I have turned sagittal. Look at that. Now, this is not in relation to the patient. It is in relation to the fetus. Look at me. I'm looking at the monitor. I'm not looking at the anterior abdominal wall. I wouldn't know if I look at the anterior abdominal wall and do the scan, I would be all over the place. I might be scanning the brain and I'm doing this looking. That's not possible. You look at the monitor and look at the probe movement. I will start off again, transverse, look at me rotating 90 degrees, and then a small little, you can see me going a small little angulation. And why that angulation, will come to it later. Again, transverse, and again, I hope that is clear. A very subtle, but a very deliberate movement. Now, you might be wondering what I'm seeing on the monitor when I'm doing this. So I will show you what unfolds on the monitor. So you start with the 4-chamber view, then I'm turning, right? I've turned, I'm getting into the sagittal plane. Already I'm seeing the ductus arch view, right? So the essence is you start axial, you see the spine in axial, then you turn, as you're turning, the spine becomes sagittal, and so does the rest of the thorax. And you see the beauty of the arches which are unfolding in front of you, right? So that is the probe movement that you wanted, Dr. UP wanted me to actually bring about, and that I hope it has done its exercise, but that's only half work done. Now, what we need to do is to realize that there are 2 arterial arches and there's 1 venous arch. So how will I get the 2 arterial arches? And there is, I don't need to see the venous arch, but in case I have to, how will I do the venous arch? So for that, what I have used is to show you the 3-vessel trachea view again, now very familiar to all of us. This is the left side ductus arch. This is the right-sided, this is the in-between aortic arch, also going to the left of the trachea. This is the SVC, right? So if I cut, I have 12 minutes, that's more than enough for me. So if I cut in a sagittal fashion here, I would get a ductus arch. But if I get cut through a sagittal fashion over here, I would get an aortic arch. And if I cut through a sagittal fashion through the SVC, I get my hammock view. Simple. So because it's different points, I need to use that little difference in moving the transducer and actually angulating it. So I have given you a spatial idea of how the probe actually has to move, and I'll let you know how it translates. Okay, so let me start the clip again. Let me start the clip again. There we are. Okay, axial, all of you agree. Now I flip 90 degrees, sagittal view. You see that the ductus arch coming in. Then I do a little manipulation. You get the aortic arch, which is coming in beautifully. And then in the end, you see the hammock view. You see the SVC and IVC, right? Repeat, axial to sagittal, a little bit of angulation and movement. I get the ductus view, then I get the aortic arch view, and then I get the hammock view. So let's look at the anatomy using this clip. So I will take you to the bookmarks. I'll take you to the bookmarks. The first bookmark is the ductus arch view, right? Right. This is a beautiful ductus arch view where my bookmark didn't help me. I got a better one using the cursor over here. So what is the anatomy here? The anatomy is the anterior chest wall. You can see the cartilage of the sternum, hypoechoic cartilage of the sternum, anterior chest wall. This is the anterior chamber, which is the right ventricle. This is the infundibulum, the muscular infundibulum. I see the pulmonary valve here, main pulmonary artery, a bit of the right pulmonary artery, which is captured over here. And then it goes on. Remember where this occurs a little above or below. On the other side, the left also is being given out, right? This is the ductus arteriosus, which is coming on and joining with the descending aorta. So what are the two pillars? The pillars are the infundibulum and the main pulmonary artery. You have the ductus arch, and the ductus arteriosus is the arch, and your other pillar is the descending aorta. So that is the anatomy that we need to know. And again, here you have the long section of the infundibulum and the main pulmonary artery matched with the short section of the aorta. In fact, you can see the aortic cusps very, very well. The Benz sign, you can see it very well. Oftentimes when I show you real time, you will understand. And this is the short section of the aorta. So this is called the circle, and this is also called the sausage. Although this is the ductus arch view, we are near about the short axis view. I have not brought in the short axis view because this is outside of the portions. But remember, this is how we see the short section of the aorta. This is a part of the tricuspid valve that you can see here. This is the pulmonary valve, and this is the all-important septum, which is a portion between the membranous and the outlet septum. And that is very well seen when you see a short axis view. You will also see the posterior to the ascending aorta. You can also see the left atrium out over here. So that is the anatomy. That is the anatomy of the ductus arch. And we'll go to the anatomy of the aortic arch. And in the aortic arch, the two pillars are the ascending aorta, descending aorta, and the arch is the aortic arch itself. You can see the neck arteries going out, and you can see something happening in the window of the arch. That is the right pulmonary artery. And you can see another vein over here anterior to the carotid, and that is the left brachiocephalic vein. And lastly, we go on to the hammock view. In the hammock view, you have the SVC, you have the IVC. 7 more minutes. You have the IVC, you have the middle hepatic vein, you have a bit of the ductus venosus, that is the left portal vein, ductus venosus, and this indeed is the IVC. So that is the IVC you can see here. That was the SVC. So that's the anatomy that we need to understand, right? Now, there's also another thing which I must introduce here, and all of us know about it. So the arch can be especially the aortic arch, can be very, very well seen by a dorsal approach. So oftentimes we've finished the almost entire echocardiography and suddenly the fetus turns. What are we going to do? We still have the aortic arch to do. You can do that by doing a dorsal approach. So that is the fetal spine. Put your transducer just to the left of the fetal spine. You will go through the descending aorta and the aortic arch, as you can see here, and you will see that happening here. That's the aorta. And turning from the axial, you will see the aorta expanding from a circle, getting you the whole arch, and I'm zooming on. You will see the whole arch and you will see the, right? So you can do it very, very easily. And sometimes the results can be stunning. You will see me going from the axial. I'll just play it once more before I go on to the abnormalities. So that is axial, certainly axial. Make sure you see the aorta, hinge on the aorta and turn 90 degrees. Hinge on the aorta. I'm not losing the aorta. Turn. Even if you lose, you come back. And you look cephaloid, you will find the aortic arch beautifully forming. Use your zoom tool. You can do it for both color as well as for black and white. So the main reason, it's important to know that if you don't know sagittal arches, you can still do wonderful echocardiography. You can get all your connections right. You can get your findings right. But if you know your sagittal arches, certain situations you need to use it. And two situations is coarctation of aorta, interrupted aortic arch. You need a sagittal aortic arch to tell you that. And of course, in CTGA, CCTGA, you will need it as well. So let's look at COA, which is indeed the commonest situation. You've suspected it in the four-chamber, in the three-vessel trachea view and the four-chamber view, and you need to look at it in the aortic arch view. So I'm going to show you a dorsal arch. You can see I'm going from the dorsal. Why? Because the descending aorta is on top. This is the ascending aorta. This is the arch of aorta. You can see the great arteries. But look at the isthmus. The isthmus is narrow and it is kinked. And narrow compared to what? Compare it with the descending aorta. And because of the size difference, caliber difference, you have a classical notch which comes on the posterior aspect. And that notch or that little indentation is called the shelf sign, nothing big. Because of the size mismatch, you have a small little shelf which develops there, and presence of a shelf means that your positive predictive value is going to be higher. You know the various ways where you know that the false positivity for coarctation of aorta is more, and you know with various criteria which can get you closer to the truth. This is one of the criteria. Let me stop this. Beautifully seen. That is the shelf sign. Now let me take you through here. And I've brought this clip with a particular reason. I do not want you to see the color. I want you to see only the grayscale. You find that the aortic isthmus is narrow compared to the descending aorta, right? So you're very convinced with this grayscale. But when I turn the color on, look what happens. I'm not able to replicate that very well. Moral of the story is color overrides. Your setting should be fantastic to bring about this subtle change over here. And therefore, don't say I'm not seeing it on color and therefore the isthmus is not narrow. That's wrong. You're seeing it on grayscale. That's great. That's good enough. So color Doppler might actually mask the presence of of narrowing. But remember, color Doppler is also important because there are Doppler perturbances in coarctation of aorta. And this is a classical perturbance which you see as a systolic reversals which are happening over here. And you also see a diastolic runoff. The ascending aorta is not filled with blood. Why? Because it's diastole. But after the coarctation, the blood flow is still continuing in the orthogonal or the antegrade direction in spite of the heart in diastole. This is called a diastolic runoff. Again, a classical sign in Doppler in coarctation of aorta. Here is, so we saw two systolic reversals, diastolic runoff. So color may not be helpful, but color will be helpful if you're looking for particular signs. So that is the way we use color. Here is a coarcted segment. The coarctation is the isthmus is joining collinear to the descending aorta. You can see the collinearity. Compare this to the perpendicularity. This is the isthmus in another case. This is going end to side. This is the descending aorta. This is going end to side. So you can have all sorts of things happening in coarctation. You only have to be cognizant of this, right? And here's another sign. This is the arch of the aorta that is narrow, and you see the distance of between the origin of the left subclavian artery and the left common carotid artery. The distance is more. All of them are signs of coarctation of aorta. And here, in fact, in between these two arteries, there is narrowing also, which is happening there. And that brings us to the tubular hypoplasia of the aortic arch. And here in this case, it took me a very, very long time to say that this is tubular hypoplasia and not interrupted aortic arch. You can see how very, very faint or how very subtle the aortic arch is seen. The ductus arch is seen very well. It's easy to fall into this trap. We should not. This is the branch over here. Ascending aorta, you will see that the entire aortic arch is very thin. And to cut a long story, I've got you a still. That's the ductus arch. I'm not mistaking that. And you see the very thin, the whole aortic arch is thin. And that's classical arch tubular hypoplasia. And this is, of course, an anterior aortic arch. How do I know? Because coming from the anterior chamber, I know that the aorta, this is the aortic arch of the neck arteries, but the neck arteries are coming from the arch, which is coming from the anterior chamber. So therefore, this is CTGA. Posteriorly, you see the pulmonary artery coming from the left ventricle, and also see the size, a narrowing of the right of the aortic arch and the ascending aorta. So therefore, aortic stenosis also in this particular case. And in this CTGA, there was also a VSD. I have not shown you that VSD over here. So it's aortic stenosis plus VSD plus CTGA. So I think bang on. I've just gone 1 minute ahead. Just 1 minute ahead. I think that was what I had to show as far as the technique of sagittal arches and a little clinical utility of why we have to do it and what findings do we look for. Thank you very, very much. Thank you very, very much. Over to you, Dr. UP.
Wonderful talk, sir, as usual, as usual. And people are still saying, give extra time to sir. Sir has another presentation in ISOG, so he cannot do it. So I think, what I have a couple of questions, sir. Can I go ahead?
Oh, please, please, please.
All right. So, no, I have it in YouTube. So there are a few questions which, people are asking about Z-scores and this thing, but parameters, but I'm going to discuss that. So I would skip those parts. And then there have been about 100 praises. Then we have, please explain TUI part in 3D.
Dr. UP, I was just what the topic you gave me and the time. Fortunately, you gave me such good time that I could do it my style. I could do it in a slow and deliberate manner. But in this time, I could not have included a stick. It's humanly impossible. I hope you understand.
Yeah. So next time for sure. So then the question is, what is shelf in isthmus in coarctation of aorta?
We did that. I showed you. I showed the audience the shelf sign in more than 2 cases. That's the posterior indentation where the narrow isthmus joins the relatively larger in caliber descending aorta. Although if you read literature, it says the angle between the ductus arteriosus and the isthmus. For me, I feel it's between the isthmus and the descending aorta.
Right, sir. So, sir, any references for normal velocities of PA and aorta during fetal echo in second trimester?
Yes, you have. There are a lot of things. I'm sure you go on the net, you will get it. You will get it. But remember, your visual impact is more important. The fact that the valve is abnormal, the fact that it's not winking, the fact that it is seen throughout the cardiac cycle, the fact that there's a post-stenotic dilatation, the fact that there is the mosaic display, turbulence, and maybe a regurgitation I had shown you in my case, pulmonary stenosis, all that adds up. Measuring the velocity is only one cog in the entire cogwheel. And we take a thumb rule saying that if it's more than, say, 150, 160, 170, that is abnormal. If it is more than 200, definitely abnormal. Centimeters per second.
True, sir. True, sir. So now the question is, do we always evaluate fetal heart when the spine is posterior?
Oh my God, I strongly recommend you not to do it. Not to do it. Please wait. I only showed you the aortic arch. I'm not exhorting you to do the entire fetal echo with spine up. Don't misread me. I told you that there is yet another elegant way to do the aortic arch. And once you start doing it, you know you're not cutting corners. Your pictures come out so well that you feel, yes, this is worthwhile. And I may not even make this lady wait for a dorso posterior, but your entire echo should be in a dorso posterior position. You cannot do an entire echo in the dorso anterior at all. No, not really, except in the third trimester. Except in the third trimester, you can do it. In the third trimester, you won't expect 36 weeks. You're seeing the case for the first time. You want to look at the heart. At the basal four-chamber, turn the Doppler on, show the two inflow tracts, right? And go to the three vessel view, show the two arteries. You can, that much you can do, but you cannot do all your rotational LVOTs, RVOTs, and do the finer aspects of the diagnosis. Definitely no shortcuts, always dorsal posterior, or at least, near about, say some 5 o'clock to 7 o'clock position you can manage with the spinning.
Question is that, can you say something about UAPA and Scimitar syndrome?
Scimitar syndrome, yes. The first part is UAPI.
UAPA, that's what is mentioned.
PAPVC, did you say, doctor? No.
Maybe I really do not know, or PAPVC, I really do not know.
Okay. Anyway, Scimitar syndrome would actually bring about PAPVC also. Now, remember, when we look at for the pulmonary veins in the four-chamber view, we normally look at the two inferior pulmonary veins getting into the left atrium. And if that is lacking, and if there's a twig sign, we begin to suspect a total anomalous pulmonary venous drainage. But what we don't do on a day-to-day basis is the superior pulmonary veins, the both of them. We don't get them so easily because they are small in caliber. They carry lesser pulmonary inflow, venous inflow into the left atrium. And that is why we don't see them, but with greater frequencies of the transducers in thin patients, you may be able to show, but that doesn't mean you are going to include it in your practice. If you see the two inferior pulmonary veins, we have ruled out total anomalous pulmonary venous drainage. We are not worried about one small pulmonary vein from the upper lobes, which is going into the infracardiac or supracardiac. We are not worried because those children do well and you can correct them later on if at all they come up for clinical, if at all they clinically present, right? So that is one aspect of it. Having said that, there is one particular finding which prompts us to look for the partial anomalous pulmonary venous drainage, and that is a mediastinal shift to the right side. Now, whenever there is a mediastinal shift to the right side or a mesocardia, remember the heart is always a left-sided structure. When it moves to the right side, it comes under the sternum. When it comes under the sternum, mesocardia or a dextro position, we've got to rule out, first of all, congenital diaphragmatic hernia, CPAM, etc. as push pathologies. Once you've ruled out push pathologies, you have to think of a pull pathology, which is a right lung hypoplasia. So in a right lung hypoplasia, in a case of mediastinal shift to the right side, that is when you targetedly pull down your PRFs, go from an axial, go to a sagittal, and go across the smaller right lung. Keeping in mind that you might see a vessel which is cutting from the lung base through the diaphragm into the IVC. So drop your PRFs, go sagittal, and very gently. It's not there in this presentation. Otherwise, I would have shared with you some pictures. And when you see that happening, a partial anomalous pulmonary venous drainage with a right lung hypoplasia equals scimitar syndrome.
Sir, so I think sir has already explained the diastolic runoff, but somebody wants that if you could mention that again.
Okay, now diastolic runoff. Okay, let's start with the basics. The arch of the aorta, just like any other artery, fills during systole. So during systole, the ventricle, left ventricle is loading the ascending aorta and the arch of aorta. And because it's loading, the blood flows through the aortic isthmus into the descending aorta, right? But in coarctation, there is a holdup of blood where after the origin of the left subclavian, before the ductus arteriosus joins. That is why you saw in all the pictures I showed you, the ductus origin was after the isthmus joined, isn't it? So there is a little holdup of blood. So when the heart pumps blood, there is a systolic loading of the ascending aorta and the arch of aorta. Blood cannot escape with ease into the descending aorta. Why? Because of the constriction. So there's a temporary hold up. And because of the temporary hold up, although the heart is relaxing, the pressure buildup is there because the aortic valve closes. The pressure buildup is there, and even in diastole, that pressure is released out through the narrow constricted coarctation distally. That is why you see in diastole that the flow continues in the orthogo, in the antegrade direction. That is diastolic runoff.
A quick small case, Dr. Sharad Gupta has said, sir, I got a case of 18 weeks. Pulmonary artery was diffusely narrow than aorta, but fourth chamber and valves are perfectly normal. So no evidence of aortic stenosis or VSD or narrow RV. What is the explanation?
No, he said that the aorta was narrow, isn't it?
A diffusely narrow aorta. No, PA is diffusely narrow than aorta. PA is smaller than aorta, basically, with the no VSD.
Okay. Okay. And no findings on pulmonary.
Otherwise, no other finding, no VSD, no RV, nothing.
No hypoplastic right ventricle,
Exactly.
and the flow is normal. I would still think of it as a valvular stenosis and follow up.
Yes.
A valvular stenosis has two varieties, a subcritical and a critical. You will not get changes in the fourth chamber view and the flow related parameters in subcritical. A subcritical stenosis can progress to critical or can stay as subcritical. I would think of a subcritical pulmonary valvular stenosis.
So there are a few questions.
And one more thing, Dr. UB, one more thing. Go back and look for overriding of the aorta. Very, very important.
You might miss it. Yes.
You might miss it. There are many instances where I have missed a very subtle override. Overriding is extremely dicey. In my lecture on the overriding aorta or overriding artery, I've shown many cases where it's so easy to miss. Your narrow pulmonary artery should take you back to the LVOT. Look at it from various angles, and in one angle, when you go epically, perhaps you will see an overriding, and your whole diagnosis changes from a subcritical pulmonary stenosis to a tetralogy of Fallot.
Sure, sir. So there are things which I think I would discuss. So subaortic VSDs I'm going to discuss. So please, guys, hold on for a while. TOF I would discuss. So hold on for a while. Sir, the Dr. Yogesh Sathe has mentioned that UAPA is unilateral absence of pulmonary artery, part of MRKH syndrome.
Part of which syndrome?
MRKH syndrome. Maybe he would
MRKH, Muller-Kuster-Hauser. Muller-Kuster-Hauser. MRKH. Muller-MR. Rokitansky.
I deliberately skip all that. I don't.
It is where there is an embryonic failure of the Mullerian tract. It is uterine agenesis that then that can come with a lung agenesis. And if there's one lung agenesis, the corresponding pulmonary branch is missing. Simple. When you do a color Doppler, you will never see that trifurcation or that pulmonary artery. If the right is missing, right pulmonary artery will not be there. Simple.
Perfect, sir. I think the question answer would continue, permanently. And I thank you, sir, from core of my heart for this wonderful discussion. You have been captivating the entire audience. They're glued to YouTube, and that's what our feedback is saying. And most of people have sent hearts to you on a YouTube reaction. Thank you very much, sir. Thank you very much.
Thank you. Thank you, Dr. Thank you, Dr. UP, for this wonderful initiative. And thank you for the encouraging words.
I hope people would wish that we would carry this on till late evening, but there is always a constraint. Thank you, sir. Thank you very much.
Thank you. Thank you. I'll sign off. Thank you. Thank you all. Thank you.
Bye. Best of luck. Yeah. The fetal heart is lying horizontal. Sorry for that. I think I'll begin because the volume was out. Now we start scanning from an abdominal view, where you confirm the situs. Then you move cranially with your probe, then to see the fourth chamber view. In the fetus, the fetal heart is horizontal, unlike the adult heart, which is a little vertical. So you get fourth chamber view, cross-sectional view on a horizontal probe position, which is actually moved cranially. You move a little more cranially, you get an LVOT view. So you go a little more cranially and some angulation rightwards, you get an RVOT view. move a little more cranial, you go through a 3-vessel view and 3-vessel trachea view, and then maybe you have to go a little more cranial also to see the arches and other things. Now, if we see this, I'm going to take you through the scanning. This we scanned, and I'm going to tell you how to optimize the fetal echo. Now, this is what we've done. You started a fetal echo, you chose an appropriate preset for this, and you have to have a good 4-chamber view. Good 4-chamber means that you have to see 3/4 of the rib. Okay, so this rib has to be seen, entire rib, not in sections. So if you see the entire rib in one plane, you are in a good cross-sectional view of the abdomen. So once you scan here, this is the spine, the sternum. You see this is a pulmonary vein, this is fossa valis, and now this is an abdominal view, stomach, aorta, and this is an anti-clockwise position. So means that the fetus is, the head is cranial, heart is cranial. If you moved little more cranially here, you saw the aorta coming out. Let me try to give you tips about how to optimize. This was less than optimized. Look at the frame rate. Let me go back to you and show you. We were here. Look at the frame rate, 62 hertz. Okay. So if I move the depth, remove, I see we make it. Okay, the depth is less. You see, your frame rate is going to start improving. Now you make it shorter, the width is smaller, and then look at 87, it's so you have improved the resolution by increasing the frame rate, by optimizing the image as per the depth is concerned and as per the width of the probe is width of the sector is concerned. So before that, what you do is that once you've done this, you make an assessment of the lungs, the heart size, cardiomegaly, which is taken into account by cardiac area or cardiac circumference versus the circumference of the chest. And once you've done that, you've seen the axis, you've seen the structures outside the heart. Now you are comfortable. You can actually zoom the heart so that it fills about 80% of the screen. And that's how you would be able to see the structures far well. Correct. So now you are focusing on the heart. You can move your zoom pan up and down to actually figure the heart right in the middle of the screen. This much zoom is important to view the heart. So you must not miss this. Okay, I am done one trick. Now you look at the grainy. Now the speckles and speckles all around. Okay, and what did I do? You know, from here, I removed compound imaging. So once we remove CRI, you see a lot of speckles around. In fact, this echogenic focus has become brighter than before. But to remove this speckle and have a nice looking, you need to put the CRI on. So this is compound imaging on, right? Now I'm going to try another thing. This is SRI put off. Now it looks a little more hazy. The contrast between the tissue and the blood is far better if I keep the SRI on. So I usually keep SRI at 2 and CRI also at 2, but you can always increase CRI, SRI depending upon the structure what you are seeing. So this is part 1 of optimizing the image of a fetal heart. So let me take you to another step of optimization. Now you reduce the gain of 2D to optimize it. Now I'm going to tell you something very important which we need to do. You decrease the dynamic range. Okay, in this equipment, it is dynamic range contrast, which is increased. Actually, the dynamic range is reduced. You reduce the dynamic range and you see the blood and tissue interface far better. but this becomes more contrasty image, and you might miss couple of things like a ventricular septal defect. And this is when you have a dynamic range which is high. This is good for tissue characterization, but we don't looking for tissue characterization in a fetal echocardiogram. So this is, we have to increase the contrast range here. The contrast we increase. Now here we have to reduce the contrast and kept it around 8 in this machine. So this is a good contrast of ventricular walls, the valves, and the blood or the chambers. Now I have moved the probe slightly cranially, and this is what we get this, because this was a lateral 4-chamber view. We get a lateral LVOT view. This is left ventricular outflow tract. That's the aortic valve. So now this is the aortic valve, and that's something which I would repeat again and again, and I'm going to show you. There is a common mistake. Now here, see that this is an aortic valve, and you see a kind of a defect or a dropout here. Mind it, this is not a VSD, because VSD does not happen above the aortic valve or distal to the aortic valve. Okay, this is the part of the aortic wall which have been having a dropout because it was thin. So do not mistake this as a VSD because it's above the aortic valve. Another important thing which I want to tell you is that once you are here, you see the aortic valve, you see the aorta, you don't see the LV apex. So if you put a color Doppler on, if you have an apical muscular VSD, you won't see it because you are in a different plane. This is not actual cardiac apex. This is foreshortened. So once you're seeing the aorta, so then the cardiac apex is not seen. Even this is not a cardiac apex, it's foreshortened because the aorta is seen. Okay, so the cardiac apex is in a different plane. So remember that another piece of information. This is descending aorta, then this is the pulmonary veins. Okay. So let's move ahead. While I was scanning, here we are to optimize the image. And this is RVOT. Now you'll see, I'll go little cranial. This is an LVOT, little cranial, you will see an RVOT, which I would show you when I go to an RVOT view. There is something else you can do. You can actually add chroma. Chroma is said to be good because if you remember the rods in the eye is in phobia, more abundance, right? The cons. So let's skip that part and okay. Now this is LVOT. You would see an RVOT there. Let me go to the color Doppler. Now that's a color Doppler. You have a size of the box which is very large. So that's why the frame rate is going to drop. It's about 57 Hertz at this point. And look at this. Keep looking. Remember, this is when you're driving, this is the dashboard of your car. So when you're actually scanning, that's the dashboard of your machine. Keep looking sometimes on this, the frame rate. I'm more interested in frame rate than the other things. This tells you SRI is on, CRI is on, but I know that. But I'm more interested in only one parameter, like you are looking at the speed of the car. I am interested in the dashboard. Look at the frame rate. I want the highest possible frame rate. That's how I would get a better resolution for a very small structure that is heart. So now look at this frame rate. I'm going to make this box smaller. The moment I make this box smaller, I have reduced the Nyquist limit. Okay, once I reduce or increase the Nyquist limit, I can see the pulmonary veins far better than before. See this pulmonary vein, and this is seen very nicely by reducing the Nyquist limit or the velocity range, you may call it. So see the pulmonary vein at a lower Nyquist limit or a velocity range. Okay, I increase the Nyquist limit And by increasing the Nyquist limit, the pulmonary vein is not seen clearly entering into the left atrium, but I get LVOT flows very discrete and clear, which was not very clear before. So once you see outflow velocities and inflow velocities, signals on a color Doppler, it's good to have a high Nyquist limit or a high velocity range so that you do not get the color bleeding onto the vessel wall or onto the walls of the ventricles. Now, another important thing, it's a good idea to have 2D and color Doppler side by side. Remember, I told you the frame rate does not drop. The frame rate remains the same once you are doing it. So it's good idea to have a 2D side by side as a reference to your color Doppler, because color Doppler might overwrite. The baby is moving. So now in between, you see an RV outflow tract and the flow across an RVOT. You can actually use radiant color, which makes things little better to understand and removes the clutter. This is a wonderful way of color Doppler. I use it very frequently. And this is an RVOT view, which I think I am going to discuss further. Okay. So now this was the color Doppler. Now this is an aortic flow. This is an RVOT view. I think I'll discuss that in my subsequent slide. So that's another view, which is a basal 4-chamber view. When I was scanning, no, there's a large area of scanning. I don't see the frame rate here because it's been cropped. But anyway, to improve. Now just keep looking at the image here. Look at the improvement in the image immediately when I move. Forget about the frame rate. Look at the image which I improves as I reduce the depth and I reduce the sector width, right? So this is a fossa ovalis here bulging to the left. The aorta, what you see here, this is the left ventricle. This is the mitral valve, which is placed little towards the base, tricuspid valve insertion toward the apex, moderator band, and this is the right ventricle. This is the left ventricle. And that's the pulmonary vein, what you see here. And this is again the fossa ovalis. The thing is that both atria are equal in size to each other. Both ventricles are equal size to each other. RV slightly larger at 16 to 24 weeks of gestation. As the gestation increases, RARV and pulmonary artery becomes bigger because RV becomes a systemic ventricle in the fetal circulation. So let's skip and go a little forward. Now here is an apical 4-chamber view. We tilt the probe ahead cranially, and then you get an aortic valve, and that's an aorta what you see. You need to optimize this image by improving on a dynamic range. I am reducing the dynamic range. Look at the contrast we are getting, and this is a better view of LV outflow. And the contrast when you have a dynamic range high is not as good. Now what we do is that we can use a chroma, as I told you before. And now let me go to a color Doppler. You know, inflow signals as they are going away from the transducer are looking blue, and the flow coming towards the transducer is an LVOT flow. I have reduced the size of the sector, color flow sector, which has improved the resolution of the color signals. So now this is an LVOT. I'm moving the probe cranially to get an LVOT view. And here what we would do is that we would put the Doppler to show you the velocity across the LVOT. Now this is an RVOT view. This is an angled one. You see both branching of the pulmonary artery, the right pulmonary artery, the left pulmonary artery. The right pulmonary artery goes behind the aorta. So let's go to the Doppler and try to tell you how to optimize the Doppler, right? So again, I'm reducing the Nyquist limit here to see pulmonary vein. So the reduction of the Nyquist limit, you can see the pulmonary veins well. Increasing the Nyquist limit, the venous structures or low flow signals, they are not seen very clearly. but you get large clarity and high flow signals like LV inflow, aortic, and pulmonary flows. Okay. So now this is the radiant flow. Let's put the pulse Doppler on. Look at the pulse Doppler size. This size of the pulse Doppler sample is good once you're trying to take sample of LV inflow and outflow also. And when do we do that? We do that in two situations. One is that when we have to do a PR interval where you need or you're managing any arrhythmia. And secondly, when you're doing a tie index, both these situations, you need LV inflow and outflows together. So otherwise, once you're trying to look for LV outflow signals, you keep the sample size small. Smaller the sample size, discrete would be the signal. See, this signal is discrete. Okay, so now this is a discrete inflow signal, outflow signal. How do you optimize this? You optimize by moving the baseline down because you are interested in LV inflow signal. You reduce the Nyquist limit, and this is what you get a good view. Then what you do is that you reduce the gain. Now you reduce the pulse Doppler gain to get a nice envelope of the pulmonary, of the aortic flow. And this envelope means that you have a translucent area which indicates that this is a laminar flow and not a turbulent flow. This translucent area inside, this is the median velocity of blood, and this is translucent area, which tells you this is laminar flow, which you do not again in aortic stenosis, where you get a turbulent flow. There is no translucency in between. Okay, then secondly, it's important to notice here, these are clicks. This is the aortic valve opening click and a closing click. Very, very important because these clicks are actually used to calculate the tie index. You can see the mitral valve opening click and mitral valve closing click. In case you see these clicks, these are far better method of calculating the tie index rather than on onset of the flow, because clicks are more discrete to actually make a measurement. So let's move ahead on the next presentation. Let me tell you what the structures look like. LVOT we can have in a two format. If you are looking for a lateral four-chamber view and you move the probe cranially, and this is what you get, a lateral LVOT view. Okay, the lateral LVOT view, you notice the interventricular septum is actually perpendicular to the 2D, to the sector, and the aorta also is reasonably perpendicular. So if these structures are perpendicular, if you are using the resolution of axial method, these things are seen very well. Now, what are the structures here? Interventricular septum, the right ventricle is anterior. This is right ventricular wall. This is right ventricular cavity, interventricular septum. And then the most important thing, you can see a VSD. You can see a muscular VSDs here. You can see a subaortic or perimembranous VSD just below the aortic valve. So this view is wonderful to look at the perimembranous VSD, particularly when you're using a color Doppler, because then you are absolutely parallel to the VSD flow. Second most important thing here is the continuity between interventricular septum and the anterior aortic wall. Now, this continuity is very important. If this continuity is there, means that there is no VSD here. This continuity, the interventricular septum and anterior aortic wall form an angle, an obtuse angle. Now, this angle is also important. If you lose this angle and the aorta is right, straight, parallel to the interventricular septum, I would show you that. And in case that happens, look, okay, let me draw that and show you. Okay, now if you have, this is the angle it forms, and if the angle is lost, let's presume the aorta is something like this, and it's actually parallel to the interventricular septum. This indicates that the infundibular septum is gone. This is a case of a tetralogy of fellows. Okay, let's go to the pointer again. Okay, so this is what it is. Then the next structure, what you see, you can go to the so now the next thing. Anterior mitral leaflet has a continuity with the posterior aortic wall. This is the posterior, this is anterior, this is posterior. Anterior mitral leaflet, posterior mitral leaflet. The anterior mitral leaflet has a continuity with the posterior part of the aorta. Then you can take a measurements here, measurement of aortic annulus, which I would tell you, Z-scores I would tell you. But let's move ahead with the apical LVOT view. The apical LVOT view, because in the lateral LVOT view, you are not parallel. Your Doppler line is not parallel with the LVOT, so it would not be accurate. Now, this is, you got to be parallel to LVOT in this case, or at least within 30 degree, you can make a correction of the angle of the pulse Doppler, but beyond 30 degree, it becomes inaccurate. So this is about 30 degree. So you can make an angle. The LVOT flow is like this, but you are reasonably parallel to the flow of the blood in the LVOT. So if that is so, pulse Doppler would be the best thing to be done in LVOT, apical LVOT outflow. You can again look at the interventricular septum and the anterior wall of aorta continuity with an angle. You can see the mitral valve, anterior mitral leaflet, and posterior aortic valve continuity. This is very important to rule out many disorders like DORV, which I would share with you. Once I'm discussing these LVOT view, I'm just going to discuss, because I'm going to use this, the conotruncal abnormalities, which indicates abnormalities of the conus and the great arteries is a conotruncal abnormality, very high likelihood of genetic association, and something which is important, the fourth chamber is normal. So if you do a screening fourth chamber view, you are unable to get LVOT and RVOT views, it's likely that you're going to miss these conotruncal abnormalities. A bit about embryology. This is more of a pictorial rather than an actual. There are coni behind and under the both aortic and pulmonary valve. If none is absorbed, both the great arteries, they come from the right ventricle. And in case the aortic, this conus is absorbed, the aorta falls down and goes to the right side and joins the LV. This is normal. And in case the conus, subpulmonary conus is gone, then it connects to the LV. And aorta, the conus is maintained, it connects to the right ventricle. This is DTGA. And then both coni are lost, you get a rare condition called DOLV. Stay put, I would show you a case of DOLV, which we saw. This is once in lifetime, you see that. Now about the embryology of heart, I think I don't like it. No one does. So I don't want to put you to sleep. I think let's skip embryology from here. Let me show you a VSD. There was a request, so I'm going to show you all kind of VSDs, particularly which are related with the LVOT view. The VSDs could be muscular outlet VSD. This could be a perimembranous VSD. Let us show you. Now, it's a very problematic, as I told you, there is a dropout. Now, if I stop here and I show you this is the aortic valve. Now there is a dropout here, which could be a VSD. Now there is a dropout above the valve or distal to the valve, which cannot be VSD because the VSD cannot happen above the aortic valve. So this is the aorta. So VSD does not happen in aorta. This is just an aortic wall, anterior aortic wall or sinus of Valsalva, which is thin. And there is a dropout because of the resolution issue, lateral resolution issue of our equipment, which I discussed in the morning. So now you have a sub-aortic or a perimembranous area which is dropout. Why there is a dropout here? Because this is the thinnest portion of interventricular septum. That's why it's called a membranous septum. Rest is the muscular septum. You don't get a dropout there. You get a dropout here because it's thin and your lateral resolution, this side resolution is poor. You see a dropout here and you might think this is the VSD. But that's a challenge. And I would say more than 20-25% of the cases which you scan every day, which is a high number. So in here, you actually what you do is that you scroll the video clip, okay? And then you see two things. I call it phasic flow, okay? Now this is a phase in systole. In systole, the blood has no reason to go this side. You should have a pulmonary blood flow going this side. So this is abnormal. So you look at the phases, then you can see this going that side. So then this is the pulmonary artery flow. Okay, this is the pulmonary artery flow. This is the aorta flow. So this should be blue. So I think it's a bit confusing, isn't it? Okay, let's discuss it further. Let me show you first the simple, pure VSDs. Now you see this VSD. You have no doubts, do you? Now, this is a VSD which has an aorta which is about 50% override. You see, okay. Then let me show you in a still format. Okay, so that's the aorta which is about 50% override of the interventricular septum. And the second thing what I told you is the continuity of interventricular septum and anterior wall. The continuity is lost. There's no continuity between the interventricular septum and the anterior wall of aorta, correct? There is a mitral and aortic continuity maintained. The posterior wall of aorta maintains the continuity with the mitral valve. Now this becomes a parallel. Now aorta is absolutely parallel with the interventricular septum. Once you see this with an overriding aorta, there is a very strong suspicion of a tetralogy of Fallot. We call it the mal-aligned septum. You just see the septum, which is right in the middle, and you see this aorta. Now see the blood coming from both the ventricles to the aorta, and there is a 50% override. You can see 50% override on a lateral LVOT view, but that's not very accurate because the override degree might vary. So what we recommend is that go to apical 4-chamber view, go to apical 5-chamber. 5-chamber we call when you see the aorta, or apical LVOT view. That is where you make an assessment about override, not on the lateral, because lateral may be erroneous override. Just showing the same patient on a 3D, the left ventricle, right ventricle, you see aorta, and you see the interventricular septum absolutely parallel to the aorta, which should not be, and there is a aortic override, and that's on the color Doppler also you see an aortic override. Another case on override, okay? Now you see this override, that this override here is more than 50%. Okay, this is LV, this is RV. Now this is obviously about 70% or more towards the RV. So aorta is rising more from the RV than from the LV, more than 50% override. And this goes in favor of DORV, double outlet right ventricle. What is double outlet right ventricle? One artery, that's a pulmonary artery arising from the right ventricle, and the second artery, aorta or PA, is more than 50% coming from the RV. So if you have more than 1.5 arteries coming out of the right ventricle, it's double outlet right ventricle. So this is the case of a double outlet right ventricle. and the blood is coming from the LV and RV. Okay, so then a simple, again, I'm showing you non-controversial, clear-cut cases of a perimembranous VSD or a subaortic VSD. Now, this is a subaortic VSD. You guys have no doubt. Now, this is 50% override, no doubt. You have aorta, which is parallel to the interventricular septum, no doubt. Loss of continuity of interventricular septum and aorta. Aorta is not going this side. It's not making an angle. It is angle 0 with interventricular septum. This is the classic type of subaortic or perimembranous VSD. And then this is how it looks like on graphics. And then what you see is that the pulmonary artery is small, and small pulmonary artery and interventricular septal defect with an aortic override means what? Means tetralogy of Fellow. I tell you something here. I had a talk delivered on a YouTube on a tetralogy of Fellow. You can follow that. More the override of aorta, smaller the pulmonary artery would be, and severer would be the cyanosis. So if you have a severe cyanosis tetralogy of Fellow, override is more toward the right side, meaning that large quantity of right-sided blood is going into the aorta, causing cyanosis, making it severe cyanosis, and the pulmonary artery is small, less blood goes to the lungs, more cyanosis. If you have a 25% override of an aorta or less, then more blood from RV goes into the pulmonary artery, and then you can have as a pink Fellows. Okay, so pulmonary artery has to be smaller to say that this is tetralogy of Fellows in fetal echo. In adult, you may or may not have that. Many a times, like there was a question in the chat box, that you can have pulmonary artery of a normal size and you can have a tetralogy of Fellows later. That means the PS was small. It is a case of pink tetralogy, but this override of aorta you would always see. So there would be a problem in mild cases where to say whether this is pure VSD with override or this is a part of tetralogy, pink tetralogy or a mild tetralogy. Would there be a confusion? Now, let us take you to doubtful cases of VSD, which accounts for 10-20% of, at least my clinical practice, and I hope yours too. Now, this is an LVOT flow. You see some red color flow here. You're not sure whether this is an RV inflow. This could be an RV inflow, or this is a VSD. Let's run it again. This is an RV inflow. You see it clear? Okay, let me pause and take you to the RV inflow. Okay, so here is the RV inflow. RV inflow, there's something here. You can mistake it for a VSD, but I'm not talking about that. These are inflows which can actually overflow on the interventricular septum to look like a VSD. But that's not, here is no inflow. Look at, there's an outflow. Outflow, the LV outflow. There is an outflow. Okay, let me stop again. And then this is very important point. This is an LV outflow. Blue color, the blood going away from the transducer. Agreed. Now, this is blue color, blood going from the away from the transducer. This is going where? This is going to pulmonary artery, which would cross like this. There will be a crossover here. Done? Agreed. Now, why there is a red color blood flow here? Because this is systole, the blood cannot go in this direction because there is no inflow, right? This is not diastole. So this cannot be inflow. If you see the red color blood going this way anteriorly, this does not fit in the phase of the heart. So I call it out of phase flow, out of cardiac phase flow. This indicates a VSD. Is it easy or difficult? I think difficult. Okay, let me try to explain you another method. Okay, now be watchful. I'm going to show you a color M mode. How many of you use colored M mode? I think very few. Let us start doing color M mode every day to practice it like we would practice for fire drill. Okay, before, without fire, you actually do a drill. So in all pregnancies, say about 24, 23 weeks gestation, when the size is adequate and no shadowing of the ribs, you perform a color Doppler, save that clip. Remember, I'm going to tell you the steps. Perform a color Doppler, and it should not be in a dual mode. It should be in a single mode. Okay, no 2D along with. So single mode color Doppler, you record, press, freeze it, press P5, it will save the image retrogradely. Once you save the image, you run that video clip, and on that video clip, you run anatomical M mode. Okay, now here it is. Color Doppler, this is, I'm running from a video clip already saved. I put an M mode, anatomical M mode. This is how the anatomical M mode would begin. The one frame and anatomical M mode on the lower panel. So I take my cursor position close to the VSD where I saw. The VSD was somewhere here. And I make the angle correction so that I am close right angle to the flow. Now you saw this flow. Yeah, there it is. Now there is the flow on the Doppler, color Doppler. You see this is the flow. I have aligned my M mode cursor here and I've zoomed it, mined it, zoomed it. Without zoom, you would not see things clearly. Once I've zoomed it, now look at what is happening. Now this is inflow signals. This is blood circling in the RV, inflow signals in LV. Inflow signal here, this is RV inflow, RV outflow, this is inflow signals. So this is phase where there are inflow signal, mind it. And this is systolic phase. Systolic, diastolic, systolic, diastolic. Okay. And this is the VSD, right? This is the cursor here. This is the cursor here when I do a cine, and this represents this place. When I see here, you see a red color coming here. This is where. This is not in systole. This is not in diastole. This is an isovolemic contraction phase. Okay, so this is again out of phase, not in inflow, not in outflow. Correct? You don't see outflow here, but you see a flow. This is a color Doppler. So practice it, and you do it. Okay, let me show you another one. Let me show you a couple of them so that you can practice it later. Again, I'm taking a color Doppler M mode on a saved clip. I rotate the angle so that I'm kind of parallel to the VSD flow. Then this is side by side. I've already zoomed it. This is the zoom. You must zoom it. Okay, once I zoomed it, now you see here. Okay. Right. Okay, so then I'm going to show you something more here. Just at the end, which I forgot, you can change the color. So once on the screen, you can change the color. I found that the color here was okay. This one was fine. But if I change the color mode, okay, and look at this. I love this color frame. So if I use this color frame, look at the clarity of the VSD I have. This is inflow, inflow. This is out of phase. This is not inflow. This is end of the inflow. So this is a VSD. So I'll skip this. I've already done that. Okay, and then let's go to the next clip. Okay, now here. Another frame by frame saved clip. You see something here. Okay, stop here and then. Now, this is what I wanted to tell you. You see any outflow? Not much. You see any inflow? Not at all. No inflow, not much outflow. There's nothing happening around here. And you see this color. If you see this color, this is out of phase color. Out of phase color means this is a VSD. Okay, it is happening in isovolemic or contraction or isovolemic relaxation phase of the cardiac cycle. So again, I put an M mode and I'm just making it fast forward. This is the last thing I'm going to show you, and then go to the regular routine on M mode. I just want you to encourage you to use anatomical M mode. This is a wonderful way recently found, and I don't find any literature on this as of now. We have literature on pulse Doppler of the VSD flow, but M mode is little unique. Okay, here what you see, right? Now this is an M mode. This is the flow. This is the inflow, and this is out of phase flow. This out of phase flow here is a VSD, right? Okay, so that was a VSD. Now VSD, the second thing which I wanted to tell you was VSD with aortic and mitral continuity. In this graphics, I can show you, this is an interventricular septum, okay, and that's the pulmonary artery, and this interventricular septum, this is posterior, the aorta was continuous with the anterior aortic valve, and the posterior aortic valve, what you see here, is continuous with the anterior mitral leaflet, which is aortomitral continuity. But in a DORV, where you have a conus, this is called a subaortic conus. You have a conus below the aortic valve. This separates aortic wall from the anterior mitral leaflet, and the continuity is lost. If this is a hallmark of differentiating tetralogy of fellows from DORV, that if you have a conus or there is a loss of aortomitral continuity, it goes in favor of DORV. But there are DORVs rarely which can have mitral aortic continuity also. So you cannot actually bet on that. So this is again the same patient which I showed you. More than 50% override of the aorta. You don't see any sign of this is the tricuspid valve. Okay, you don't see any sign of mitral valve. That means the anterior aortic valve is not anyway connected, or posterior aortic valve is not connected anyway with the mitral valve anterior. So this is a DORV. Now, next could be on an LVOT view, the pulmonary artery is connected to the LVOT. You think it's aorta, but this may not be aorta. Look at this. Now, Dr. Ramamurthi very nicely showed you these video clips. And now, left ventricle, you see the valve, and you, as a reflex, you would always say, oh, this is an aorta, and this is aortic valve, LV, aorta, aortic valve. Until you see this aorta, so-called aorta, is dipping posteriorly. It's dipping down towards an LA posteriorly. Aorta doesn't dip posteriorly. Aorta goes like this. Okay, if I stop here and show you, the aorta goes like this. So this is where it is going posteriorly, right? And aorta would go like this. So this is how the aorta would look like in LVOT view. When I show you subsequent LVOT views, just see that again part. The aorta forms this obtuse angle, and here this is not aorta. This is the pulmonary artery which is going posteriorly. Okay, right? So this is pulmonary artery and not aorta. Again, when you have an LV and LVOT, you think this is LVOT and you think this is aorta, but this is going posteriorly. Not only that, you see an RVOT also in a lateral view, apical lateral view, then you see the aorta. So you see both the parallel vessels. You see both the parallel vessels, RV giving rise to the aorta and LV giving rise to the pulmonary artery, like Dr. Prashant and Dr. Ramamurthi showed you. These are the parallel vessel, what you see, LV giving rise to the pulmonary artery, which goes posteriorly. Here again, this goes posteriorly. Ideally, you would have expected aorta to go this way and PA to go this way. It's a PA because it's connected with LV. The artery which is connected with LV goes posteriorly, which obviously is the character of the pulmonary artery. Now, once you see a VSD, it's a good point actually to look for the VSDs. It's very, very important to prognosticate because these patients tend to do well immediate after delivery. They do not crash. Now, you see this one VSD here. This is a subpulmonary VSD. This is pulmonary artery. Okay, and then this is the VSD, what you see close to the apex. And not only that, you see another large VSD, interventricular septum. This is good for mixing of the blood when the child is born. Can we have a mitral pulmonary continuity? Yes. In a patient with a TGA, transposition of great arteries, where the pulmonary artery arises from the left ventricle, aorta arises from the right ventricle, there the pulmonary artery, the conus is gone. There's no pulmonary subpulmonary conus. When the conus is gone, like I showed in that cartoon, that it falls into the left ventricle and gets connected with the mitral valve. So that is where this is the posterior pulmonary artery wall, and this is continuous with anterior mitral leaflet. This happens, we call it mitral pulmonary continuity because there is no conus. There is conus below the aorta. That's why there is no mitral aortic. This is large conus. Okay. So this is TGA with mitral pulmonary continuity. If, let's say the vessel which is arising from the LV is not aorta. Four-chamber view looks great, looks okay. If you just scanning four-chamber view, you are likely to pass it as normal. And if you don't scan an LVOT view, you would miss this abnormality. You move to the LVOT view, in a lateral LVOT view, you see this large VSD. This is the vessel which is overriding. Incidentally, this is not aorta. This is a truncus arteriosus because you see a pulmonary artery coming out of this. This large artery, had it been an aorta, it would have not divided. It doesn't divide here, right? So large VSD, blood coming from both RV and LV. And then next what you see, this is a truncus valve, this is pulmonary artery and aorta. All right. I was asked many a times that how do you differentiate between truncus and let's say tetralogy of Fallot, and this is the pulmonary artery coming from the RV, and this is the aorta coming from the left ventricle. So where is the problem? The issue is that once you have this, you just have one valve. The pulmonary valve, if there is no pulmonary valve, okay, you don't see a pulmonary valve and you see the pulmonary artery coming from the aorta without the valve, this is truncus arteriosus, right? There is no valve here. There's only truncal valve this place. That's how you differentiate. And again, I'm going to explain you here, right? Now, see, this is the valve. Many a times the truncal or aortic valve looks like a blob in the middle when during systole, there is a dropout here, dropout here. This is the valve which is actually continuous. Now see this valve, and then the pulmonary artery is arising from this main artery, which is truncus, and aorta is arising. So truncus is bifurcating into pulmonary artery, into aorta, and there is no pulmonary valve. Absence of pulmonary valve is a very important sign for truncus, and that's what you see on a color Doppler. No artery connected to LVOT. What does that mean? It means that main artery is arising from the RV. That is a patient with the truncus arteriosus, and you have a VSD which is draining LV into RV, and then you have an RV outflow, and this is the single vessel which is coming from RV. Nothing is coming from LVOT. And then what you see further down, you see there is an LPA and the right pulmonary artery arising separately from a common arterial trunk. So this is truncus arteriosus. Fine. So the single vessel was truncus arising from. Okay. So many a times in a severe case of DORV, you see both vessels, pulmonary artery and aorta, arising from the right ventricle, and LVOT is devoid of origin of any great artery. Now, double outlet left ventricle. Yes, does it happen? you're going to witness it. Okay, so now see carefully. This is a difficult case, so pay attention here. This is descending aorta. This is left atrium, left atrial appendage, conical. I'll explain you many things here. You see this finger-like left atrial appendage, so meaning that this is left atrium. Fine. Okay, so now you see the right atrium, this kind of a mesocardia. This is right atrium and this is fossa vallis. What fossa vallis is doing? It's not bulging to the left atrium. It's at least in the middle or flipping to and forth between LA and RV. There's something wrong ahead. Now there's a large left ventricle. This is the mitral valve. Tricuspid valve is atretic and this is small right ventricle. Okay, so far understood? Let's move. Now descending aorta, this is spine. Oh, stopped playing. Anyway, let me try it again. Okay, now see, this is the right ventricle, which is chink-like. Okay, it stops in between anyway. This is the right ventricle, which is chink-like. This is the crux. This is the tricuspid trachea, RA, broad into the right atrial appendage, small right, narrow right, left atrial appendage. This is LA, this is RA, pulmonary vein into LA. This is LA to LV, and this is RA to RV. There's no flow because there is tricuspid trachea. Okay, so then pulmonary vein showing here, and there is no way for RV to go into RA to go into RV because there is a tricuspid trachea. The entire blood goes into LA and LV. Okay, skipping it further, now RV has a small size, but it does carry some flow, and that is a to and fro flow from the LV through two VSDs, one VSD, another VSD. This view is again underutilized. This is a cross section of LV and RV on a sagittal plane. Okay, so now this is left ventricle. You see one artery arising from here, and then that's another artery. So there are two arteries. Now I want to show you there are two arteries arising from the LV. Now you see these two arteries. All right. So there it is. One artery, another artery. Maybe if I go scroll, it's yes. You see one artery arising from LV. This is left ventricle. RV was small. You remember that? This is one artery arising from LV. There's a second artery arising from LV. Pulmonary artery, which is small. There's a pulmonary stenosis, large aorta, which is anterior. There's actually a malposition of the arteries. So this is a double outlet left ventricle. PA and aorta arising from the LV and RV. Nothing is coming. It's only connecting with LV through VSDs. I showed you. So this is a very rare case of DO, LV, double outlet left ventricle. There's a double outlet right ventricle. Both gate arteries arise from right. Double outlet left ventricle. Or there is a rare thing which I haven't seen till date, double outlet both ventricles. Both arteries are overriding. So is it common? No, absolutely no. Double outlet was thought that does not exist at all, but then the case reports keep coming in. Van Praag in his autopsy series published about more than 100 cases way back in 89, 90. So it does happen, but extremely, extremely rare. So what about aorta size? That was the question which was asked on the chat box, and I'm going to explain you that. This is the Z-score on parameters blogspot, or in your equipments also now they have the Z-scores installed. When you go to the measurements, you can go to the Z-score. It would take either BPD or femoral length or estimated the gestational age. So you put the gestational age or any biometric parameter there. So once you do that, it knows at which size of fetus you're talking about, and then you feed the valve dimensions here in centimeter, if you are in millimeter. Once you fill this, and then you would immediately get the Z-score along with. Many equipments that today are giving you Z-scores in their equipment itself. You can utilize that, but there is some disparity between this Z-score and Z-score in the equipment. And how do you take a measurement? One measurement is at the junction of the aortic valve or somewhere here. It is the aortic annulus. And second is the aorta, and that's mid of the ascending aorta. This has to be, this is in diastole because valve is closed. This has to be in systole and leading edge to leading edge. Remember that for accuracy. So once you've taken measurement, if the aorta is more than 2 z-scores or precisely 3 z-scores, then you can say that aorta is large. What are the reasons for aorta being large? You can have aorta being large in a tetralogy of fellows. You can have, because there's an increased flow, less flow to the pulmonary artery, more flow to the aorta, aorta enlarged. Pulmonary atresia, same reason. Aortopathy, when you have a bicuspid aortic valve, don't worry, I'll show you an example. So bicuspid aortic valve, you have an aortopathy which is unrelated to the bicuspid valve flow pattern. There's a separate entity. The aortic walls are abnormal. Their collagen pattern is abnormal. So aorta is dilated. Marfan syndrome does not manifest as a dilatation, but severe Marfan rarely has been reported in the fetal circulation. Also, you have a mild pulmonary stenosis, and most of it is bicuspid aortic valve can produce post-stenotic dilatation. Severe aortic regurgitation of any reason would produce a dilated aorta because blood would enter back into LV, then doubling the volume in the LV inflow, going again out from the LVOT would make the aorta larger. That is from our archives long back, and this is LVOT. Then you see this aorta, ascending aorta in the distal part is ballooned out. You see a ballooning of ascending aorta. And then this is again a view where you see ballooning of ascending aorta. And that's an autopsy specimen here, which shows a dilated aortic arch. This is a recent one. You see this is descending aorta, this sagittal view. And you see this is arch of aorta. The ascending aorta, the z-score was 3.2 here. This ascending aorta is dilated. Let me remind you, the most common reason of dilated ascending aorta like this is a bicuspid aortic valve. And many times you see this turbulence across the aortic valve. This is aortic stenosis. You have a narrow aortic annulus and markedly dilated, double the size of ascending aorta here. The distal aorta is markedly dilated, partly because of the aortopathy in the bicuspid aortic valve. And you just see the aortic flow is hitting the wall of the aorta here and dilating it actually. And these are the increased velocity signals, 2.5 plus flow velocity across the aortic valve. Again, you see on a 2D, a dilated distal part. This is the first branch, brachiocephalic, and there is a dilatation of ascending aorta. And again, you see lasing across the aortic valve. Okay, so then this is the case we published long back. And this is the patient where you have severe aortic regurgitation. You have a forward flow and a flow reversal in aorta, and that is what you see, a forward flow from LV to aorta, and if aorta to same quantity and same intensity, amplitude, blood. The amplitude tells you the severity of aortic regurgitation. And on an autopsy, we saw one of the aortic valve leaflets was missing. It was a non-coronary cusp. There's a left coronary cusp, right coronary. The non-coronary cusp was absent. It has never been reported before in the literature. Pulmonary valve was looking absolutely supple and normal, while the aortic valve was thickened and some discoloration of aortic wall because of myxomatous degeneration there. Bicuspid aortic valve, you see the aorta. So now see this horizontal closure of the aortic valve. Let me take you slowly through it. And that is the horizontal closure. And this is leaflet 1, leaflet 2. This is no 3 leaflet, 2 leaflets. This is the bicuspid aortic valve closing and opening. So this is the bicuspid aortic valve. You see that clearly, bicuspid aortic valve. Fine. Okay. So then bicuspid aortic valve, you see, do you know that when you have a stenosis, you see the valve in systole also? Normally, you don't see the valve in systole because you see the valve in the systolic position because it's thickened. 2, it does not snug with the wall of the aorta. Now, normally it would have snugly attached to the wall of aorta. You wouldn't see the valve in the open situation. So if you see the valve in open, it's thickened and doming. This is the patient of the aortic stenosis. What are the reasons where you can have a small aorta? I'm going to show you this case. This is the case where you have LV and RV inflow with large inlet VSD and an outlet VSD extending into the outlet. That is again a cross-sectional sagittal view. You see an LV and RV, which is anterior. This is the VSD. Okay. And then further, when you see, this is another, VSD. On a 3D, what you see, volume rendering, aorta, and the aorta is small, and the pulmonary artery is large. Once you have a large VSD, small aorta, think of what? Yes, exactly. Think of interruption of aortic arch. So this patient was interruption of aortic arch. You see this fork sign. This is brachiospelling going to the head, and this is another branch. This is type B of interruption of aortic arch. Once you have a small aorta and you have no VSD, you have pathetic looking ventricular sept, ventricle, left ventricle. It is hypokinetic. And this is a case of aortic stenosis or aortic atresia. There is an aortic atresia, and then you can see a forward flow in the aorta, but aorta is very small, and there is a mitral regurgitation. And on 3VT, three vessel trachea view, you see reversal of flow in the aorta, which indicates the forward flow wasn't enough. So that is the forward flow. You had both forward and retrograde flow in the aorta. I think we've learned one thing today, that we've still a lot to learn. Thank you very much for your kind attention for this part. And let me take questions here, and then maybe I'll switch to the next talk. Okay. Let me see if there are any. Are there any questions? Okay. Let me go through the questions here. And no audio, that was corrected. What is the ideal frame rate you recommend for different situations? For heart, you have to have the best frame rate. Do not compromise. And how do you get a best frame rate? You reduce the size of the box. You reduce the size of the width of your frame. That would make you good frame rate. You have the smallest possible. You know what you do? You make a small color box and you keep scrolling the color box this side, that side to see the aorta, the pulmonary artery. You have a panoramic view first, large box, color box, then you make the color box small, and you can actually steer that box this side, that side to see various structures. You'll get an excellent resolution with that. Okay. Normal and abnormal tie index, I think we would discuss that later because it doesn't fit in the frame of today's talk. And sir, what is the ideal PRF for visualizing interventricular septum? Wonderful question. Both low PRF and high PRF, both. Remember both. So once you have a high PRF, that the blood would not, or the color would not bleed over the interventricular septum. So normally there would not be a bleeding across the interventricular septum, right? So high PRF. Then you would see some small VSD also at a high PRF. Now, once you get suspicious, oh, there looks like a VSD there, because VSD could be low pressure. Why VSD is low pressure? Because pressure in LV and RV, the gradient between two is very small. LV and RV are almost the same pressure throughout systole and diastole. So then the flow across the VSD is a low velocity flow. The velocities are low. So what you do when you want to see low velocity, you reduce the Nyquist limit. You reduce the Nyquist limit to see the VSD flow. So then how do I tackle? Then you would see the blood flowing across the interventricular septum. What happens when I reduce the PRF? you see the blood bleeding across the interventricular septum. There's another trick. I reduce the gain. I reduce the color output. I reduce the color gain from somewhere around 80s to 70s and 60s. So once you have reduced the color gain and you have reduced the next limit, that's the ideal way you would see the VSD. Okay. All right, then I tried to do anatomical M mode, even M mode for arrhythmia, but I could not find the button. Can you explain? Oh, ma'am, I think you go to my YouTube channel, you would see anatomical M mode. There are 3 videos there. There I have displayed the knobs simultaneous with the what you see on the display. So for the knobology, you would find it there. It's very easy. What was the normal anatomical structure that resembled? What was the normal anatomical structure that resembled tricuspid atresia? I didn't get that. So, Dr. Singh, how to counsel in a case of isolated dilated ascending aorta without increase in velocities level of? I think most of these patients do well, and because this is because of the bicuspid aortic valve. I reviewed the literature for some time back on the dilatation of aortic arch without any other abnormalities. There were very few cases, and most of them did well. The outcome was okay. The aorta wasn't markedly dilated as it was in the antenatal period. The growth of that component was reduced at the later stage. So kind of equality happened. The outcome is not bad. I never understand the mechanism of pulmonary atresia caused by a hypoplastic right ventricle. Could you please explain? See, wherever you have I give you an example of the hypoplastic left heart that would make you explain things better. Hypoplastic left heart can happen by 4 or 5 mechanisms. The mechanism 1, that's a postulate, right? One mechanism is that you have fossa ovalis restriction. There is less of blood coming to the left atrium, less of the blood coming to the left ventricle, and then the left and the right ventricle receive less blood. They do not grow well as the gestation advances. Mechanism 1. Mechanism 2, which we have seen a case of subpulmonary submitral stenosis by a membrane or chordaitatum or the mitral stenosis. I've seen a case of mitral stenosis which reduces the pressure in the LV. Now, because of the more resistance towards the left atrial side than the right atrial side, blood preferentially goes to the right atrium. The RA and RV would dilate, LA and LV would become small, and over a period of time would not grow as they would have grown in a normal flow situation. So they become small and eventually become a HPLV or hypoplastic left heart syndrome. Third situation, aortic stenosis or aortic atresia or coarctation of aorta, where you have a kind of obstruction to the LV outflow, increased resistance in LV, increased resistance in LA, the blood preferentially goes to the right atrium, and LA and LV become smaller, smaller, and smaller over a period of time. Many case reports have been documented in literature where you had aortic stenosis which went to become hypoplastic left heart syndrome. So same manner, if you have a tricuspid atresia, tricuspid stenosis, the less blood coming to the right side would make right ventricle chambers small and pulmonary artery also small. Many a times I have one case where you have a hypoplastic right ventricle. The PA was normal, but that was a mild hypoplasia of the right ventricle. So for hypoplasia, Z-scores, same Z-scores can be used, and Z-score minus 2.5 would be a best way to differentiate between normal and abnormal. Fetal bicuspid aorta, L kappa. L kappa is different than bicuspid aorta. Bicuspid aortic valve, I presume. But L kappa is anomalous region of left coronary artery from pulmonary artery. So L kappa again you can find in my videos on YouTube. I have all 70 YouTube videos. You search for L kappa and you'll find it. Okay. Thank you. Yes, people do call me UPS, that is uninterrupted power supply. Thanks for that, reminding me that. Inflow versus perimembranous VST. Nice question again, a common thing. One is that simple trick. If you see two AV valves and you see a VST, this is inlet VST. Okay, done. If you see inlets, that would be inlets only, no? So if you see mitral valve, tricuspid valve, in the same frame, you see a VST, this is inlet VST for sure. Now, two, if you see aortic valve and you see a VST, this is a subaortic or perimembranous VST. You see a pulmonary valve and a VSD, which I'm going to show you in next talk, subpulmonary VSD, very rare. So if you see pulmonary valve and you see a VSD, it's the subpulmonary VSD. Okay, so let's say if I tell you I see the VSD in inlet, both AV valves are seen, and I see a VSD. When I move cranially, I see aorta, I still see the VSD. Yes, this you can say this is the perimembranous VSD extended into the inlet. So the large VSD extending from inlet right up to the perimembranous portion. That's what we define it as. I hope that makes sense. Okay. I agree that you can, kind of miss tetralogy of Fallot in case you have no pulmonary artery stenosis. We did miss one. We said this is a subaortic VST, and it was tetralogy of Fallot. After birth, it was mild tetralogy of Fallot. And only once you have a moderate or severe TOF, then you start getting a smaller artery. All right. The reason for missing perimembranous VSD, yes. See, in a third trimester, in kind of a BMI of about 36 in a patient on insulin, which causes abdominal fibrosis and reduces your transmission of ultrasound waves to the fetus, so making it poor visibility. We did miss one TOF, and the reason was we did not see a perimembranous VSD dropout. And if you miss perimembranous VSD, the pulmonary arteries of normal size in a pink tetralogy of Fallot, you miss the entire boat. Correct? So it's a good idea not to miss patients. And when you scan a patient, at least I've started doing it, mention the total scan time. It's important that for the person to know that you spent an adequate time, still you did not see it. And mention the BMI of the patient and mention whether your quality of imaging was adequate or inadequate. So that would save you from unnecessary hassle later on. All right. Now let's go to the last talk, and I think I would finish it quickly. I haven't had lunch, and I presume the guys, those who are in India and Indian Standard Time, would have not also had in. So I just want to go and finish the talk. Arrhythmias, I think I would make that talk after some time later. Okay. So let me go to the other talk, and let me stop sharing this. And then I would share that again. Before I do that, let me close this, and I'm closing my first PPT, starting my second PPT of RVOT views, and then I'll start sharing again. Okay, and then RVOT. All right, there we are for an RVOT view. We've done most of the work in the LVOT views, but a bit of thing here is that once you are here, level 1, this is maybe you call it level 1 or level 0. You are here in a subcostal view, and you show them abdominal view, situs, and then move to the 4-chamber view. You see the heart in the 4 chambers. You move little cranially, LVOT, which I showed you. Move little more cranial and little clockwise rotation. The rotation should be towards the LV apex. If you rotate the probe towards the LV apex, then you would get a better RVOT view. And RVOT view 1, there are 3 RVOT views which I'm going to show you. RVOT view 1 is that you see a small RV outflow in fundibulum, then the subpulmonary conus, then you have a pulmonary valve, and you have the pulmonary artery. And if you take it in a cross section, you see the RV, and I am going to show you all that in the subsequent. The first view, RVOT view, small RVOT, no RV inflow or RV apexine, and then you see the pulmonary valve and the pulmonary artery. In the cross section, you see the aortic valve, 3 cusps, and then you see the left atrium, and the interatrial septum. You see the right atrium, you see the tricuspid valve, the right ventricle inflow, apex is not seen here. Then you see the right ventricle outflow, then you see the pulmonary valve and the pulmonary artery. If you go to sagittal plane, which Dr. Ramamurthi already showed you, so I would not spare time to delve into this area here. Then the RVU in a sagittal plane, where you see the duct, the duct of the pulmonary valve, pulmonary artery ductus, and then you see the RV pulmonary valve, and this is ductal view. You see the arch here, ductal arch, and you see the various structures which Dr. Ramamurthi explained. Let me show you RVOT cross-sectional view, because that's, let me tell you, this is something which is difficult to attain. You need a lot of practice to attain this. So start doing it. Maybe you would perfect it in a couple of days or months' time. This is the cross-section view. Now, this is again the tricuspid valve. Unfortunately, the arm is here putting a shadow, and you're not getting a good view here, but there's no shadow on the pulmonary artery. You see that well. Now, you see this is the aorta in the center. You see this pulmonary artery, which is going like this and branching into 2. Agreed? So now what I did was initially look at the optimization. This was the Nyquist limit, not a very good looking situation. You see the, okay, let me stop it here and show you. Okay. Now if you have a low Nyquist limit, now what even if you have a good wall filters, you would have a bleeding of the color outside the arterial wall. You see the arterial wall, there is a bleeding of the color, and the colors are mixing, and you don't see things clearly. What do? You increase the Nyquist limit. The moment you increase the Nyquist limit, the colors start behaving and stay inside the wall of the arteries or wall of the ventricles or atria. So now you see a nice division between the pulmonary artery and the aorta, which was smudged in a low PRF situation. So higher PRF situation in the arteries where the flow is very good and high, and this is what you see, the high PRF. Okay, so now let's move ahead in optimizing the view. Again, this is an inflow view. You have to reduce the Nyquist limit to see the pulmonary vein here. So I've reduced the Nyquist limit to see pulmonary vein. I put the pulse Doppler here. And if I show you, this is not a nice looking pulse Doppler. Why? One is that pulse sample volume is large. You are sampling a lot of area here, and you're getting a lot of smudging, and you don't see the flows very clearly. You can make out this is ENA, no doubt. You can make out this is outflow, but this is far from ideal, right? Let's actually try to Okay, first thing what I've done, okay, let me pause and I think I'll take you by scrolling only. Oh, I think I've moved to the next frame. Fine. So I take you from here, okay, and now this is not a nice looking. Fine. Now what I do is that I reduce the gain, the pulse Doppler gain. You reduce the pulse Doppler gain, and what I wanted you to see is that lucency in between. This lucent area tells you this is laminar flow, and you are getting a good Doppler. Okay. So now, okay, then pulmonary artery Doppler. Again, the Doppler sample is big. We can make the pulse Doppler sample small, and then you see the pulmonary flow. And here what you see is that lucency and pulmonary flow is slightly different. And you see the opening and closing clicks. You can hear the opening and closing clicks. Okay, so this is the pulmonary flow, right? Now let's skip something and go forward and show you. Now here we are looking at the pulmonary artery branches, and what you see the pulmonary artery branches, you can freeze here. Remember one thing, once you are here, you are taking measurements like this. I'm going to take a pulmonary measurement like this, and I am absolutely not parallel to the flow. I am perpendicular to the beam, which means I am depending upon the lateral resolution, which is poor, where I cannot actually differentiate between the edge of the pulmonary artery. So that is a caveat when you're taking a measurement. So you have to be careful when you take measurements in this side. So the another way is that you can zoom here. There is when you take a measurement, you can have a right click, and right click would zoom. You can zoom and actually find out where the edge is. And this is how you take, sorry, this is not a BPD. This is the right pulmonary artery. Right pulmonary artery goes behind the aorta toward the right side, and left pulmonary artery does not even come close contact with the aorta, it goes on the left side. So that's how, and that's the pulmonary valve seen very nicely. Okay, I'm going to repeat that again. Now this is an LVOT view, and remember LVOT view, okay, that's an LVOT view. And if I go cranially, and then this is RVOT view. The RV is going this side, LVOT was going this side. So there is a crossover of both the views. Okay, and then we go to a sagittal view, which has already been discussed by Ramamurthi, so I would skip that. Many a time you have a doubt of parallel vessels. This was one case I recorded. We thought that this is the parallel vessels. There's a VSD thou, but I'm not discussing that right now. These are the parallel vessels. Are they really parallel vessels? No. Initially, when you're slightly angled, not an appropriate four-chamber view, you might see look-alike of parallel views, but only in the proximal portion. The moment you go slightly more cranial, you see the crossover. Done. So this is the crossover. This is not TGA. RVOT view, this is not which you actually see more frequently. And this is what you see here, the RVOT view. I think please spare with me. Give me a minute. My power is setting of the. I need to put the thing on a power mode. Okay. 1 minute, please. So. All right. Sorry for that. My system was on for the full day. So, battery conked off. So now I put it on charging right now. So I'm back with the talk, right? So then, okay. So let me tell you something. Let me go back. And this is the way we were here. Doubtful. And then we were here. Okay. So then again, this is an RV inflow. And this is the right ventricular outflow tract, RV outflow, pulmonary artery, pulmonary valve, aorta, and simultaneously you can see the aortic valve, the tricuspid valve, the interatrial septum. Sorry, this is not a right atrium, this is left atrium, this is the right atrium, aorta, pulmonary artery, right pulmonary artery, and this is the pulmonary valve. So if I try to explain you on a still image, okay, now this is aorta, and this is in diastole. Why I say diastole? There is no flow across pulmonary valve. There is a inflow in the tricuspid valve. So this is a RV inflow. So this is in diastole. So diastole, the aortic valve is closed, mitral valve is closed. And then this is in systole. You see the flow across aorta, you see the flow across pulmonary artery, okay, and you see the tricuspid valve closed. So this is the diastole, systole. Now, here I can make a difference. Where is the VSD? So if you have a VSD close to the tricuspid valve, that this is the rim, close to the tricuspid valve, this is perimembranous VSD. This is where you see perimembranous VSD. You see a VSD, an outflow VSD right in the middle. The pulmonary valve is somewhere here. So that's the pulmonary valve. And if you see where the VSD close to the pulmonary valve, this is a subpulmonary or doubly committed VSD. So this is how you can make out VSDs. This is what we do in neonatal echoes as well as adult echoes differentiation. So again, structures here, because this is not commonly used, so I'm going to explain it to you. This is IVC, this is pictorial diagram. IVC, RA, the tricuspid valve, the RVOT, the pulmonary valve, the pulmonary artery, the right pulmonary artery, behind the aorta, the left pulmonary artery going to the left side, left atrium, and this is the interatrial septum, and this is trileaflet valve of the aortic. Now, this is the aortic valve in the right coronary cusp, the left coronary cusp, and the non-coronary cusp of the aortic valve. So normally you get a circle and a saucer appearance. Circle and a saucer appearance is a normally related great arteries, and this is how you see circle and saucer appearance in a normal great arteries. But in a transposition or a malposition of great arteries, where aorta and PA are malposed, you see those the circles, this crossover is not there, this saucer is not there, both circles, which indicates a transposition of the vessels can happen in a DORV, can happen in a transposition of great arteries. Now, if you see this pulmonary artery arising from the left ventricle, I showed that before in the previous, so I'm going to skip this. Okay, I showed you the mitral pulmonary continuity already. I'm going to show you subpulmonary VSD. Very uncommon. Watch it carefully. Okay. Okay. Now watch here. Now look at, this is an RV. This is an RVOT view. You see, you would see a pulmonary valve here. That's the pulmonary valve. Just below the pulmonary valve, you see this VSD. Let me stop it and take you to the frame, which is, yeah, exactly. So this is the pulmonary artery, right ventricle. This is pulmonary valve. Just below the pulmonary valve, you see this VSD is called subpulmonary or doubly committed VSD. Okay, now see the same thing on color Doppler. You see this VSD here and going into the pulmonary artery. This is subpulmonary VSD. Now, it could be a situation where no artery is connected to the RVOT, like I showed you in LVOT. It happens in two situations. You have a pulmonary atresia with no flow across it, obviously. It can happen with VSD. So then you would see, or no VSD. In no VSD, you would have a very small RV, you would have no VSD, and you would have no flow across the pulmonary valve. That's pulmonary atresia. Then in the pulmonary atresia category, the most common thing is that you get a retrograde flow in the three-vessel view into the pulmonary artery from ductus arteriosus. Correct? So pulmonary artery has to fill in somewhere, but it fills in by the ductus from the aorta. That's option number one. The pulmonary artery filling, the option number two. Option number two is main central aortopulmonary collaterals. The descending aorta gives arteries to supply pulmonary branches or the lungs. Now, see one situation. This is an aortic override, beyond doubt, interventricular septum, repeating the same thing, interventricular septum, and there it's aligned with the aorta. It is not an angle with the aorta. So then there is a septal and aortic discontinuity, and you see there's a large VSD, the blood flowing from the RV into the aorta. Blue means away from the transducer, and this is filling. So this is, the aorta is filling by both RV and LV, and there's no outflow of the VS from the right ventricle. The PA was small and was filling retrogradely from the ductus, and PA, you can see the PA filling retrogradely from the ductus, and PA was filling here. This is the ductus, and this is the pulmonary artery. The flow actually is a very interesting phenomena here. The flow from the ductus goes and enters, hits the closed pulmonary valve here, bounces back into the other pulmonary artery, and that's how the circulation goes in both pulmonary arteries. A complex case which we did long time back, but what I want to show you here, there's a common AV canal, there is atresia of the mitral valve, and this is an RV which is filling from both left and the right atrium, which we know that this is double inlet right ventricle. Then there was an MR and a TR. And what we saw in the next step was there was no pulmonary artery arising from the right ventricle. The aorta was arising from the right ventricle, and you could see pulmonary artery arising from the descending aorta. The right pulmonary artery, this is four-chamber view, area behind the heart. This is the pulmonary vein, okay, entering into the left atrium. You see this right pulmonary artery arising. You see this left pulmonary artery arising from the aorta. The both arteries arising separately. This is the main MEPCA or aortopulmonary collateral arteries. What about pulmonary size? Like we discussed, the size of an aorta. Good that you go to the, again, same site, parameters.blogspot.com, or you have an available of Z-score in your own equipment. And then what we need, that we need to feed in the gestational age or biometry to calculate the gestation, because gestational age is required. As based on that, it calculates the Z-scores. You feed in the figures, what you take a measurement, and then it will give you the result plus the Z-score and how much off you are from the Z-score. This is again an RVOT view, and this is in diastole. Both the valves are closed. The tricuspid valve is open. Now the pulmonary valve, diastolic, this is systole. Now remember, the measurements have to be taken not in diastole. The arterial measurements are taken in systole, not diastole. So the systole is closed. Diastole is closed. Now systole is open. This is where we are going to take various measurements. The first one is pulmonary annulus. Again, we have a caveat that we are actually perpendicular to the beam of ultrasound. So you take this measurement, inner edge to inner edge, main pulmonary artery right in the mid of the pulmonary artery, again inner edge to inner edge, right pulmonary artery, inner edge to inner edge, just after the origin. We take it left pulmonary artery is not very clearly seen, but it would be seen on little angulation, and you take a measurement accordingly. These measurements of pulmonary artery are very important to say dilatation, but more than that, it's to say whether it's pulmonary stenosis is there. Where do these Z-scores help you? Once you say the pulmonary artery is larger than aorta, it could be that aorta is small and PA is large. Okay, or it could be the PA is large and aorta is relatively looking small. So either thing can happen. The Z-score would settle this issue, and you take Z-score. And second area where Z-scores are very, very important is the cases like Epstein anomaly, in the cases like tetralogy of fellows, where you want to take an assessment of severity of tetralogy of fellow. These measurements are very, very important to decide the severity of tetralogy of fellow, and also the requirement of prostaglandins or tertiary care when the child is born. The large PA has aorta, many causes. You have an aortic atresia, blood is flowing through the pulmonary artery, coarctation of aorta, same thing, and all other causes of ventricular disproportion, which Dr. Prashant Acharya discussed with you in the morning, would have pulmonary artery, RARV, all dilated. Another cause which I missed here is ductal restriction, which produces obstruction across the pulmonary artery. There also the pulmonary artery is markedly dilated, mild pulmonary stenosis, and severe pulmonary regurgitation. Quickly show you a few cases, and then we are off for today's webinar. This is aorta override and overriding of aorta. Plus, if you see the pulmonary artery, you are kind of trying to figure out which one is RV, which one is pulmonary artery. So label it. This is RV and this is pulmonary artery. Understandably, PA is far bigger than the right ventricle. This is hugely dilated, aneurysmally dilated pulmonary artery, and that's happening. Why? Because there is to and fro blood across the pulmonary valve. The pulmonary annulus is small, but there is no valve. There is an absent pulmonary valve. It is causing aortic pulmonary regurgitation as well as the stenosis. So this is what happens in markedly dilated pulmonary arteries, which actually obstruct the bronchioles. So that's a different story. We're not going to discuss that. Small pulmonary artery. Small pulmonary artery and tetralogy of fellows, we know that, discussed it already, but then you can have a small pulmonary artery in various other conditions. So thank you very much for being with us for full day. I think it was an exhaustive webinar for you. We are putting a great effort to make it go on a YouTube channel. I hope even if you missed this, we would, by evening, we would post this on a YouTube channel. And not only if you missed it, if you want to revise it again, go back forward to understand it further, you are most welcome. We would try our level best to keep it on our YouTube channel. So I'll stop share here and let me go through the question answers, right? So if there are question answers, what makes you suspect branch pulmonary stenosis and how to confirm it? Let me tell you, Dr. Manohar, it's not very easy to make an assessment of branch pulmonary stenosis. Very, very difficult to diagnose in the fetal circulation unless the branch is really very, very narrow and small. You generally do not get too many gradients across it. At least I haven't seen the branch pulmonary stenosis in the fetal life. I've seen the main pulmonary artery stenosis, mid pulmonary artery, but not branch pulmonary artery. It's difficult to diagnose because of the size issues and resolution. Should not we see PDA in this view? Yes, 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 we always see. PDA is always there. What we call the ductus arteriosus is patent ductus arteriosus is PDA. So what we talk about in RVOT view, that is the sagittal plane ductal arch. That's what we call the ductal arch. What is ductal arch? RVOT, pulmonary artery, and then ductus, and then descending aorta. So that ductus we always see. You're absolutely right. We see ductus there always. All right. So let me check more questions here. Please show clips displaying all VSDs in circle and saucer view. I just requested you that we would be keeping this YouTube video online. You can always go back and see all the lecture and rewind, forward, slow speed, fast speed, whatever you wish to do. Nice Sunday, yes, nice Sunday to you guys all. I hope it was nice despite me wasting a lot of your time. Mitral pulmonary continuity lost case, why that is not DORV, sir? Yes. Mitral pulmonary discontinuity, yes, exactly. Like you have aorto mitral discontinuity, and if you have in a patient where there is an override of pulmonary artery, that is a tossing bank kind of a DORV. The pulmonary artery is overriding the interventricular septum, and then you miss the continuity between the mitral valve and the posterior wall of the pulmonary valve. You are absolutely right. That would account for double outlet right ventricle or DORV. That's how you differentiate a TGA with the VSD from a DORV. Please show aortic valve measurements again. I think we, including myself, we are all tired. You can go through the YouTube channel. We would keep it on for you. Keep rewinding, forwarding, whatever you wish to do it. Thank you very much for your kind attention and bearing with us. And I hope that we had a wonderful faculty. We probably send you a review form so that you can give us feedback on the various talks. You can rate them, you can put suggestions, you can make your comments, or whatever you didn't like, you like. So in that feedback form, it'll be very nice if you do that. We would send you in a couple of days' time. So there is still a request, short axis or RVOT views. I think everything is available. Whatever you wish, you can type it, send it on review. I'll make a special video on that. So we cannot continue this webinar further. So with a lot of thanks to guys, those who joined us. We had about 2,500 registrations, and at any given time, there were about 500 odd people, those who were hooked onto webinar, which went more than 5 hours today. And it was a marathon. So please, we are very happy that you bore with us. Thank you very much again. And I hope that we would have more on webinars in future.